Welcome everybody. I'm Dr. Tony Hanneman. I'm the founder of MedStudy, editor-in-chief of all the products, and I'm just really delighted to be here to be your host for this course. It's going to be 5 days of a tremendous amount of information. Hold on just a second. Josiah, are you talking to me? Okay.
Go on.
Okay. Okay, so tremendous amount of information. We have 13 expert teachers who know very well and are going to teach you what you need to know for the boards. So let's get started here. This is basically showing what's going to be going, what resources you have the next 5 days and after. We have 16 topics we're going through. Course videos are available the day after the presentation, including this one. Color syllabus, as you all have seen, it has the content of every slide you're going to see, so that you don't have to do a whole lot of note taking. And there's the self-testing tools, audience response questions, which we'll be going through over and over again, and I'll talk more about all this stuff. Question preview, review, bonus videos. We have acid-base analysis and biostatistics available. They're in your video section or in the course video section. Bonus videos, learning resources. Okay, you've already seen the kick-ass brain hacking techniques. That's the basically a review of what the StudyWise guide has written in it in more depth. And down the abbreviation list, antibiotics list, we'll be talking about all that. So we deliberately, very deliberately focus on the high yield board relevant content for this course. So that's what we're going to be talking about. It's for it's aligned with both the ABIM MOC and initial cert blueprints. We have other products, premium Q&As, illness script flashcards, and the core, which provide more content. Okay, at your home screen, it's broken up into 4 sections. Course sessions is up in the upper left-hand corner. The course videos are posted here day after, as I was saying, and those 2 bonus videos. Course details give you some more information about the course, like daily schedule. Getting ready is stuff you already have are familiar with or have been doing mostly. StudyWise guide, it tells, it's this actually rather, I think, engaging little booklet on, talks about how the brain works, what we know about how memory works, proven learning techniques, the myths and the truths of learning effectively. A lot of us do barely okay or even counterproductive, or we use counterproductive learning techniques. This will clear all that up. Question preview. We've taken all the audience response questions and put the question part of it, the scenario and the question with the distractors into a separate document. And it's a little flip book. So if you click on this, let me see if they're, well, it looks like I can't get to it. They taped down my keyboard. Oh, here we go. And the thing to remember about this, when you go to this, in the lower right-hand corner, there's going to be a this little table of contents area. That's what that indicates. You click on that, and then you can go to any particular one, and this has the kind of like the slide number, and you can tell how many are in there anyway. But just go there, and it'll start showing those questions, those audience response questions. Part of really good study technique, proven and validated study technique, is to preview the material the day before. The way you preview it is you go through what we're going to do in this course is you go through the audience response question, read the scenario, ponder it, and think, well, what does that bring up? What do I know about that? What do I not know about that? And as you do that, um, and then go to the question. Typically, these are on the same page, but they're longer or shorter. And you just read the question. I don't even know if it's necessary for you to read the answers, because what you're trying to do, what you're really doing is making a space in your brain for the information that you're going to be exposed to the next day. And this really works. It makes a little sticky area. You've primed it. It's all prepped for that information the next day. And it literally doesn't matter if you know the answer, if you don't know the answer. So it's not any sort of an assessment. It's just like you're prepping yourself for the next day's information. Okay, let me go back here. Okay, and then the question review part 1 and 2, you'll get that after the course. And that will give you the same thing, all the questions, but also the correct answer. So that's more for a review later on. A short thing, Q&As are such an excellent, it's like these Q&As, the Q&As in their Q&A product are like a really, really great way to study. Because when they write questions, they think, what's an important point? And so it's about something that you should know, first of all. And then as they write the scenario, they put in common findings, that you'll find from that patient in that scenario, and common histories and such. But also when they write the answers, they give one answer that's correct. They give another answer that is very close to that answer. And it's kind of the way they build these Q&As. And but is incorrect. And then there's other ones that could, if you don't know it, they would seem reasonable. So Q&As are really, really good for discrimination of your knowledge base, for discriminating the different aspects of it. And it's you contrast and compare similar information in doing this. And what that also does, another big thing in learning, is metacognition. Metacognition is knowing what you know and knowing what you don't know. And as you go through Q&As, that's a wonderful feedback for that. If you go through it and you go, I always get it mixed up between these last two ones, then that means, okay, you have some more learning to do. That's all it means. It doesn't mean anything else. And that so the metacognition, a doctor needs to know what they know and know what they don't know. That's a big thing. And this helps you in the medical knowledge area to kind of like tune up there. Okay, for CME and your CME units, MOC points, you need your verification of attendance. Most people have already done that. It's a one-time thing. Speaker and content evaluation is very important for us. And if you do it once a day at least, and put we get your ratings on both the speaker and the content as two separate items. This gives us tremendously good feedback for how the course is going and where it needs improvement. One item in that thing, the feedback in the evaluation form, is who's the best. I think we say who's the best teacher you've had in any course, but it's not here. It's like in your experience listening to other instructors, who's been a wonderful instructor is the way I would put it. It doesn't matter if it's the same subject as what you're being taught that day. It's from your recommendations that we develop a pool of our contributors for writing questions, writing into core, audio, speaking, and so on. And our very best references have come from you guys. So be sure and fill that in too. Okay, on the top of your home page, there's something called Helpful Stuff. And you can see in this area is the internal medicine area. Talks about study-wise, both blueprints, lab values, abbreviations are in there. A little review of antibiotics, like a quick review of antibiotics is you can refer to, and so on. But those are the main things. Okay, as we're talking about audience response questions, the way you answer those if you're online is you go up to the upper right-hand corner of your screen and click on audience response if it's not already open. And that's where this little window will open up that has the answer choices. So the speaker will go through here and go through the question and answer options, and then they will give you time to answer over here. On site, most of you have already scanned in the QR code at your table. That takes you directly to the same little kind of window area. Okay, so let's practice a little bit. So we'll do a question here. The speaker will ask the question, wait for when they think you've had enough time to think about it, and then press the timer. So what type of practice do you have most days? Limited or no clinical practice at this time? Residency training, primary care, outpatient, hospitalist, traditional primary care, outpatient and inpatient, or mostly subspecialty practice. Okay, the speaker will then go click, and countdown will start. So you'll have 10 seconds, or 12 seconds to answer, and then you'll see the results on your screen. Okay. Next, we'll do one more. Deep question. Why are you here? Course, research, longitudinal knowledge assessment. Oh, yeah. There's a little skewing from and what they see remotely because they're separated. We're separated by time into when everything's done. So we had to separate these two items so it's real time for both of us. But we found out on the Q&As, it matches up almost perfectly every single time. Okay, if you have a question for the speaker, right next to the audience response tab is the speaker tab. And you just fill in your question there. We'll send all the questions to the speakers and collect all the information and put it up on your homepage afterwards. And it'll be under course sessions, speakers' responses to attendee questions. And of course, if you're here, you can grab the speaker between talks. Need any online help, product support or tech support, anything like that, you can just email support@medstudy.com. And this won't go into the ether, but there is a whole team waiting to answer your questions right away there. We also are going to be putting latest announcements in this Ask the Speaker area. And that's really it for this. Reports usually come out within 3 months after the last exam date. And that's it. So it's right at 8:30. So we're going to switch over to another slide set. And I'm going to go ahead and start introducing your speaker. So we have Manish Suneja. He's a nephrologist. He's given the talk having him here. He gives the best nephrology talk I bet you'll ever hear in your life. Mostly nephrology information, and it will be a lot of stuff, but Manish makes it make sense. So he's a professor of internal medicine and residency program, the editors for the 10th edition of DeGowan's Diagnostic Examination, and he works with us year round. He's a reviewer for the core in our Q&As, and everybody loves working with him. You will love hearing him. Manish, come on up. I appreciate you being here so much.
Oh, thank you so much. Thank you for that introduction. Um, I love being here too. Just a little bit more about me. So, I trained in England and was a rheumatologist prior to becoming a nephrologist, and now practice pretty much both rheumatology, nephrology, and general internal medicine. It took me 2 fellowships to decide that I like general medicine more than any of these two specialties of these topics. And what I'm going to try and do is hopefully give you a little, pearls on the way what the boards like to test you on. So these are the topics, and without further ado, I'm gonna start with acute kidney injury. So what is acute kidney injury? So this is something. The definition hasn't changed for a long time. It is still, again, if you just go and but most commonly we don't remember the definitions, and it's most commonly reflected by an acute or sudden change in your BUN and creatinine, right? Again, your metabolic waste products are going up, they're not being excreted, so there's an imbalance between metabolic waste generation and excretion, which is reflected by increase in nitrogenous waste. And those two nitrogenous waste we most commonly check are blood urea nitrogen and serum creatinine. So those are the two big things which we are still using. Now, KDIGO, which is Kidney Disease Improving Global Outcomes, came up with a definition that it should be defined. Again, this is mostly for research purposes, that it should be an increase in serum creatinine more than zero point 0.3 or a 1.5 fold increase over baseline in the last 7 days. But most of us don't use practically clinically we don't use this definition, right? You know that BUN and creatinine have suddenly started going up and you call it acute kidney injury. Now the third part is a little controversial: oliguria. That means urine output less than 0.5 milliliters per kilogram per hour for at least 6 hours. And there was a tongue-in-cheek article in BMJ about 10 years back. They were like, oh, pretty much each and every resident based on this definition is going to be an acute kidney injury. So I would take it with a little grain of salt, and it is just acute rise in nitrogenous waste over a period of few days. Generally, 7 days is what is defined. Now, how we think about acute kidney injury has not changed. What you learned in your med schools, three branches, right? Anytime you have an acute elevation in BUN and creatinine, you got to be thinking about, is there a problem with the kidney itself? This is what we call as intrinsic acute kidney injury. Like something is wrong with the kidney itself, or there's some problem in the blood supply. So the blood supply is not coming at the right volume or right pressure, right? So it's just the kidney is fine, but the blood is not reaching the kidney at the right volume or the right pressure. So that is what is called pre-renal acute kidney injury. And then post-renal is there some obstruction to the urinary flow. So urine is backing up, it is putting back pressure on the kidney, and that is what is causing the dysfunction. So that's post-renal. So some urinary obstruction, the kidney is not getting blood at the right volume or right pressure as pre-renal, and then there's something wrong with the kidney itself. Now, I'm going to take you back to your med school days again. If you can imagine a slide of a kidney biopsy, what do you see there? So there's glomerulus, which is the main filtering unit. there could be something wrong with that glomerulus, right? We'll talk about it. Glomerulus is attached to bunch of tubules, right? If there's some damage there, it can cause acute kidney injury. So that's what is ATN. It is surrounded by this glomerulus, and tubules are surrounded by interstitium. There could be some damage happening in the interstitium. We call it acute interstitial nephritis. And then in the interstitium, there's blood vessels. There could be something wrong with it. So if all you remember is those four components which you're visualizing, and again, if this, as I was mentioning earlier, I didn't want to show you this, but this is what the framework is based on. If there's something wrong with the glomerulus, we call it acute glomerulonephritis or nephritic syndrome. We'll be touching on that in the next 10 or 15 minutes. This glomerulus is attached to tubules. If there's something wrong with tubules, it's ATN. Surrounded by that is interstitium. If there's something wrong there, acute interstitial nephritis. And then there are some blood vessels actually in the interstitium. If there's something going on there, it could be acute vascular syndrome. So all you have to do is remember a framework so that you are not relying on your memory, but there's some structure to the whole issue. But again, if you were a betting person and somebody was being admitted with acute kidney injury, let's say somebody got admitted and you just wanted to bet on it. You were in Vegas and you're like, you know what? I don't want to think about it. I just want to see how my betting progress is. So 50%, so 50 out of 100 patients who are admitted will have ATN just by prevalence and epidemiology. 30% are going to have pre-renal. So 8 out of 10 are either pre-renal or ATN, and 9 out of 10 are either pre-renal, post-renal, and ATN. So 9 out of 10 are going to be these three diagnoses. But of course, we have ABIM, right? The boards, they don't like common things. They like rare things. I have no idea why, right? We should be testing you on common things. But they do like the other stuff, so I will be covering rest of this. But 9 out of 10 are ATN, pre-renal, and post-renal. For clinical practice, if you know these three diagnoses, majority of the AKI is really, really, really easy to manage. Now, this diagram, I'm going to take you through it. So this is a cartoon. So this is your glomeruli, right? And this is the artery which actually supplies blood to the glomeruli. So it's afferent. A for arrival. So the blood is arriving to the glomeruli. And E is for exit, right? Efferent takes the blood away from the glomerulus. And this is where all the magic happens. This filtration happens. And this is where, ultimately this filtrate, which is represented in yellow, there was a reason, right? Urine is yellow. So this ultimately becomes urine, right? After going through different parts of the tubules, right? So afferent is blood arriving, efferent blood exiting, glomerulus where all the magic is happening, and this is where the urine flows. So anytime you're volume depleted, let's say you're having diarrhea, vomiting, somebody is bleeding because of trauma, anytime you're volume depleted, there's some magic happens in the kidney. Kidney is a very smart organ. There's autoregulation. It wants to maintain a normal GFR. So there are three hormones which get activated anytime you're volume depleted. Those three hormonal systems are sympathetic system. Why? Because when your blood pressure is low, what do you want to do when your volume is low? You want your heart to contract faster, and you want the contractility to be higher. So your heart is increasing its cardiac output by increasing the sympathetic system. So sympathetic system gets activated. The second system which gets activated is renin-angiotensin-aldosterone system, RAS, right? And the third system which gets activated, because I'm going to keep on coming back to it, is ADH. So anytime you're volume depleted, sympathetic system, RAS, and ADH is activated. Now, since these three hormonal systems are activated, what is the magic happening in me and you when we become volume depleted? Our afferent arteriole dilates under the influence of prostaglandins from the sympathetic system. So this is dilating. And the efferent is constricting because of angiotensin 2. Now, if you just take an example of a hose pipe is connected to a tap, right? I'm going to open the tap. It's connected to a hose pipe. I make a hole right in the middle of the hose. What is going to happen? The water is going to flow from that hole. Then I'm going to ask one of my friends or colleagues to, I'm like, go and step distally to the hole. So I've made a hole. Go and just press on the hose a little bit with their feet. What's going to happen? More water is going to come out of the hole. Or if I ask my other friend, I'm like, now open up the tap a little more. What's going to happen? More water is going to flow. That is exactly what your kidney is trying to do by dilating the afferent arteriole and constricting the efferent arteriole. It's trying to normalize the GFR. So that's why me and you, even if we are volume depleted, we do not go into AKI. Because what is our kidney doing? It's dilating this afferent arteriole and is constricting that efferent arteriole. Does it make sense? Now, there's some magic happening right here on the tubules too. What is happening under the influence of angiotensin 2 and aldosterone? You are reabsorbing all the sodium possible because your kidney is a smart organ. It realizes that you are volume depleted. It wants to hold on to all the sodium and water. So under the influence of angiotensin 2 and aldosterone, you reabsorb all the sodium possible. So what's going to happen to the urine sodium here? It's going to be very low, right? That's what you see in pre-renal. And wherever the sodium goes, that's where the water goes. Sodium and water travel together. And wherever the water goes, urea just goes along with the water. Urea just takes a ride along with the water. So when you're reabsorbing water, you are reabsorbing urea back into the bloodstream from the urinary side. Does it make sense? And what is the third hormonal system which is activated? ADH. What does ADH do? ADH also reabsorbs water from this urinary side to the blood side. And along with the water, what comes along? Again, urea. So what is going to happen to the urea concentration in here when you're volume depleted? It's going to be very low, right? So if you just understand this, half of what I'm going to tell you in the next 5 slides is done, right? It's pretty simple. So me and you do not go into acute kidney injury with volume depletion. Why? Because this is dilating and this is constricting. Now, what if you are volume depleted? You go into the ER because you're having some nausea, vomiting, you've got gastroenteritis, you've got volume depletion, you have some abdominal pain. And to treat your abdominal pain, somebody gives you NSAIDs, Toradol. What are you going to do? The kidney is trying really, really, really hard to maintain a GFR, normal GFR, by dilating this afferent arteriole, and now I'm blocking that autoregulation. So that's why NSAIDs are terrible, terrible, terrible drugs when you're volume depleted. They're not, as a nephrologist, I'm a rheumatologist too, I still prescribe NSAIDs. NSAIDs are great when you have inflammation, but when you're volume depleted, they are going to put you into acute kidney injury because you're blocking the autoregulation. That's what cyclosporin does. That's what high calcium levels do. And this is exactly what happens in hepatorenal syndrome, this constriction of the afferent arteriole. Now, ACE inhibitors and ARBs are beautiful drugs for chronic kidney disease. But when you're volume depleted, they put you into acute kidney injury. Why? Because they are blocking this efferent vasoconstriction. Right? Does it make sense? Why do you want to stop ACE inhibitors and ARBs when somebody is volume depleted? Yes? Okay, because now this table is really, really easy since we've actually discussed what the underlying physiology is. So I told you what is the difference between what happens in pre-renal. Your urine osmolality is very high. Why is the urine osmolality high in pre-renal? It's exactly ADH is acting, and ADH is reabsorbing the water, so your urine becomes very concentrated. When you look at patients who are volume depleted, their urine is going to be dark yellow because it's all the water has been absorbed, very, very concentrated. Whereas in ATN, when you check the urine osmolality is close to 300. Why is it close to 300 in ATN when the tubules are damaged? Yes, because now what is being filtered is what? Plasma, right? Because in the glomerulus, what is being filtered? Plasma. So plasma goes into the tubules, but now the tubules are dead. They can neither concentrate nor dilute the urine because the tubules are not functioning. So whatever is being filtered, what is being filtered is plasma. So roughly the urine osmolality is going to be equal to plasma osmolality. You cannot, even though ADH might be floating around, you cannot concentrate your urine. Does it make sense? Why is the urine sodium low in prerenal? Of course, because angiotensin 2 and aldosterone is reabsorbing all the sodium possible, like I showed you in the previous slide. But can a damaged tubule reabsorb sodium? No, even though angiotensin 2 and aldosterone might be very high, if the tubule is damaged, you cannot reabsorb sodium. So that's why your urine sodium is high. And a fancier way of looking at urine sodium is fractional excretion of sodium. So they're not going to test you to check what, they'll give you a fractional excretion of sodium, less than 1 or more than 2. Does it make sense? And this concept we had already talked about, fractional excretion of urea, right? In pre-renal, it is low. Why is it low? Because ADH is reabsorbing water. Along with water, what travels along with water? Urea just follows along with water. And as you're reabsorbing water, urea is coming along, so your fractional excretion of urea goes low. Where did we come up with this number 35? Based on studies. But I just want to tell you, it's just not an absolute number, it's a continuum. So if somebody is pre-renal, their fractional excretion of urea might be 6 or 7. 2 days later, it could be 20. Even though it's still pre-renal, it's telling me that it's changed from 6 to 20, that if I don't do anything soon, it will convert into ATN. Does it make sense? So sometimes it's worthwhile following the fractional excretion of urea. It's 6 today, 15 tomorrow. Kidney is trying, but ultimately all the autoregulation fails and you will go into ATN. Yes? Um, so why is fractional excretion of urea sometimes more helpful? It is more helpful when somebody is on diuretics. If somebody is on furosemide, what is going to happen to their fractional excretion of sodium? You are causing them to lose sodium in the tubule, so you cannot rely on fractional excretion of sodium to differentiate pre-renal and ATN because you're giving them diuretics. So in those cases, fractional excretion of urea is very helpful. But having said that, let's say somebody was on diuretics and their fractional excretion of sodium was still less than 1. Very helpful. In spite of the diuretics, the kidney is telling you it does not want to get rid of salt. Stop the diuretics. Does it make sense? Now, um, does this number make sense? BUN to creatinine ratio is high in pre-renal. Why is the blood urea nitrogen to creatinine ratio generally high in pre-renal? Because in pre-renal, ADH is doing what? It is reabsorbing water. Along with water comes urea. So now you're reabsorbing urea from the urinary side to the blood side. So your blood urea nitrogen goes up. That's why the BUN to creatinine ratio is up. Whereas in ATN, the tubules are damaged. You cannot reabsorb water. You cannot reabsorb urea. That's why the ratio is close to 10 to 1. Again, not an absolute, you can't just rely on one number. So you have to look at the clinical picture and look at these renal indices. But I can tell you, you can forget about if you see muddy brown cast, I don't care what the urinary indices are. The patient has ATN. So if you have muddy brown granular cast, does not matter. So this is a picture from my iPhone. You can take, if you see this, I'm like, sure, you can, again, if you want to give me the urinary indices, you can. But I'm seeing dead tubules. This patient has ATN. So if they mention muddy brown granular cast, they're already telling you that the patient has ATN. But ATN is not a diagnosis. Like, you still have to figure out what caused the ATN. Now, this is very simple. ATN is very simple. Tubules are being damaged. There's only two ways the tubules can be damaged. One is pre-renal, 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 pre-renal. Nobody is doing anything about that pre-renal state. Ultimately, the kidney gives up. Autoregulation fails. And that one is called ischemic ATN. This is the most common ATN which we see in the ICUs, right? From sepsis and multi-organ dysfunction syndrome, right? Very common. Pre-renal, 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 nobody is fixing it, is gone into ischemic ATN. Yes? The second one is nephrotoxic. Now you got to think about, something is toxic to the kidney. And now your brain has to structure that. Where can that toxin come from? Majority of the time, the toxins are given by me and you, right? Those are exogenous toxins. That's why you got to look at, did the patient get contrast? Was some drugs given? Like, of course, gentamicin, ampho, cisplatin are very well known, but pretty much so many drugs can actually cause ATN, right? And then what other exogenous toxin which can be given by the physicians themselves? The one which sometimes they like to test you on is osmotic nephropathy, which is, again, if somebody already has some kidney dysfunction, and if you give them sucrose, mannitol, dextran, um, you can actually put their tubules into osmotic damage. The proximal tubules just die. So this dextran used to be used very commonly as a plasma volume expanding agent in the surgical ICUs, but we recommend highly against it, right? Because it can cause osmotic nephropathy. Does it make sense? Now, endogenous toxins are only two. Only two endogenous toxins, either myoglobin or hemoglobin. Myoglobin comes from damaged muscles, from rhabdo, and hemoglobin comes from intravascular hemolysis, not extravascular hemolysis, intravascular hemolysis. That means the red blood cells have to be dying inside the blood vessels, right? Like microangiopathic hemolytic anemia, you'll be learning more about it too, right? Hemoglobin is toxic to the tubules, intravascular hemolysis. Why I've put low phosphorus and low potassium. So these are two electrolytes which can cause rhabdomyolysis. And sometimes they will, again, they'll give you a patient with rhabdo, CKs are elevated, and then they'll give you the electrolytes. The electrolytes will show a normal potassium in a patient who has a confirmed rhabdo. Your brain should be like, oh my God, why? I know that this patient's CK is 20,000, but the potassium is 3.6. That does not make sense. Why doesn't it make sense? Because when the cell is dying, what should it be releasing into your bloodstream? Potassium and phosphate, which are very high inside the cell. But now you're looking at the potassium and it's 3.5. That should tell you that the rhabdomyolysis was caused by hypokalemia. Why? Because the potassium should have been 5.8 or 6.0. It is 3.5. That means prior to the rhabdo, probably the potassium was 2.0. So in a confirmed case of rhabdo, if you see a normal potassium and a normal phosphorus, at least your brain should be thinking about, could this rhabdo be caused by low phosphorus or low potassium? Okay, so that's why I kind of highlighted that. Okay, moving on. They love this. Okay, you'll get one question right. They totally, totally, totally love it. This is the cheapest diagnosis you're going to make, right? So if you have a patient who's coming in with acute kidney injury and they tell you that the patient has 3 plus blood on the dipstick, you do a dipstick and shows 3 plus blood, but when you look under the microscope, all you're seeing is 2 to 3 RBCs. Does not make sense, right? When I see 3 plus blood, and what should I be expecting under the microscope? Too numerous to count RBCs. But all I'm seeing is 1 to 2 or 2 to 3 RBCs. Does not make sense. You have your diagnosis, right? It's either myoglobin or hemoglobin. So now you have to check the history and maybe check CPK and aldolase for myoglobin, and for hemoglobin. I told you most of it is intravascular hemolysis. So you'll be checking peripheral blood smear for cystocytes. LDH will be high in microangiopathic hemolytic anemia. Haptoglobin will be low, and indirect bilirubin is going to be high, right? Anytime, of course, you have a pigment-induced injury, especially rhabdo, you should be doing early aggressive hydration with isotonic saline. You might need more than 10 liters to achieve euvolemia. So the ideal goal is that you should have a urine output of about 200 to 250 cc's per hour when you have rhabdo. There is some evidence, which is again not very firmly based on randomized controlled trial, that urinary alkalization might help. But again, the evidence is not very strong. But the main goal is what? Keep the urine output about 250 cc's per hour. Most of the time, you end up giving at least 4 to 5 liters of fluid very fast, because if you have rhabdo, each thigh or each leg can actually third space about 2 to 2.5 liters of fluid. It's very hard to imagine, but when you have rhabdo, you can have a lot of third spacing. Having said that, if you've given 5 liters of fluid and the patient is still not peeing, don't keep on pushing. The damage is already done. This is the time to back up, because now you're going to cause pulmonary edema. The kidney is damaged. It's not going to be. But initial try should be to at least give 4 to 5 liters and see if you can maintain a urine output of about 250 cc's per hour. Yes? Okay. Now, we've covered ATN, right? ATN, you have a structure. What causes ATN? Pre-renal, pre-renal, pre-renal into ischemic. Makes sense. Other is nephrotoxic. Then in nephrotoxic, you got to push your brain a little. What can be nephrotoxic? Either something I am giving the patient, which is exogenous toxins, or there's only 2 endogenous toxins, myoglobin and hemoglobin. Now, what surrounds the tubule is interstitium. And again, if you look at, so this is a biopsy from one of my patients. So if you look at this interstitium, all what you're seeing is these blue dots. This blue dots is invasion of the interstitium by lymphocytes and plasma cells. So damage to the interstitium is acute interstitial nephritis. It is nothing but lymphocytic infiltration of the interstitium. The number one cause is drugs, 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 drugs. Right? Now, you got to know which drugs are the most. It used to be antibiotics, right? Cephalosporin and penicillins. But now, what are we using like candy? PPIs are being used. Like, you just have to come to my clinic and tell me something that you've got some abdominal pain, some reflux, and of course, I will give it to you. Or I don't even have to give it to you. They'll talk to their friends, and they might be taking omeprazole over the counter from Target. Or so very, very, very common, right? NSAIDs are, again, they not only cause ATN, but they also can cause interstitial nephritis as well. The only, I have no idea at all why the board loves these 2 diagnoses, Sjogren and sarcoidosis. You'll see it when you take the boards. They love Sjogren and sarcoidosis. So I am mentioning that again, the 2 non-drug causes of interstitial nephritis, which are heavily checked, is Sjogren syndrome and sarcoidosis. Both of them can cause. Generally, it's drugs, drugs, drugs. Now, what we taught you when about 15, 20 years back was, how do you know that somebody has interstitial nephritis? Oh, you got to have this triad: fever, rash, eosinophilia. What kind of rash? Maculopapular rash, the drug rash, right? But if you look at the data, it is only seen in 10%. This is a totally flawed illness script. because it is only seen in 10% of patients, and also very commonly only seen with cephalosporins or penicillins. And that's no longer, it's just not even a valid illness script anymore when it's only seen in 10%. Now, what you need to remember is somebody who has AKI, and when you look at the urine, there are WBCs in the urine or WBC cast. You're not going to see WBC cast, right? Unless you are checking it you collected a urine sample and you directly went and looked at it. But if you have pyuria or WBCs in the urine without any evidence of infection, what should you be thinking about? Interstitial nephritis, right? The first thing what comes to your mind is, oh, there's WBCs in the urine. What do? Send it for culture. But culture keeps on coming negative and you keep on sending it for cultures. What should you be thinking about? That this could be interstitial nephritis, because these classical things are not seen in majority of the patients. Make sense? What are you going to do? Look at what new medications were started, discontinue the medication, and now there's growing amount of evidence that if you start steroids early, you can decrease their chances of developing chronic kidney disease. So what I do is stop the offending medication. I'll start them on 40 to 60 milligrams of prednisone for 4 weeks and then taper it, just 4-2. But within 2 weeks, so early initiation of steroids is beneficial. It used to be kind of controversial 3 or 4 years back, but there are multiple studies which are suggesting that this is or should be the approach. Yes? Okay. Again, just wanted to show you the PPI associated acute interstitial nephritis. You don't see rash, you don't see fevers, you don't see eosinophilia. You don't, right? And one of the other things that, again, on a side note, how many, I had a resident who would send a urine for eosinophils because I'm like, oh, the patient might have acute interstitial nephritis. But then you have to, again, if there are no WBCs in the urine, please don't send urine for eosinophils because, you got to remember eosinophil is a WBC. If there's no WBCs in the urine, what do it's not going to be a miracle that you're going to find a eosinophil, right? So save money and don't send urine for eosinophil stains if there's no WBCs. Okay. Acute kidney injury after cardiac catheterization or arterial catheterization, the two big things, again, they like to check you on is first is post-contrast nephropathy. What is the ideal timeline? You get contrast, and the kidney function starts getting worse in 24 to 48 hours. The most common timeline is 48 hours. And when do we check our, I'll give contrast and I'll check the creatinine in 12 hours and it's fine and you discharge them. So we don't even know what the relevance most of the time for post-contrast nephropathies. I think it's a little overrated. We worry about this a lot. The consequences might not be that bad. But most of the time, clinically, we don't even check the creatinine 48 hours later. Like, oh, kidney function is fine, you're off. And most of them do recover. And this was a study which was published in JAMA in 2004, and every cardiologist started actually prescribing sodium bicarbonate infusion based on that. Like protocols were changed. But if you look at this study, if there was one more negative patient on the sodium bicarbonate arm, it would have been a negative study. One more, but they stopped it early. So I can tell you there have been multiple studies after that. There's no difference between normal saline and sodium bicarbonate. Just give hydration 1 hour prior to the contrast and 6 hours after. That is good enough. I give about 250 cc's 1 hour prior and about 500 to 600 cc's after the contrast. Bottom line, the boards are only going to check whether you are giving them hydration. Of course, most of the contrast now which is available is low or isosmolar contrast. Again, if you want to treat yourself and you feel good about it, you can give them 1200 milligram BID of acetylcysteine. But I think based on the last meta-analysis, physicians are treating themselves when we give this. It's a cheap drug, it's not going to harm anyone, but the evidence is actually not there for acetylcysteine. Yes? So I think with cost conscious care, all the boards is going to be actually checking is whether you give hydration or no. The other big differential when you actually have worsening kidney function after some kind of a catheterization is athromembolic disease. How would you compare? Medicine is all about compare and contrast. Now, what is the difference between contrast nephropathy and this? Of course, the biggest one is uh, contrast nephropathy should start recovering by day 4 or day 5. What happens in athromembolic disease is the kidney function, let's say today is 1.2. 4 days later, it'll be 1.4. It'll stabilize at 1.4, and then 14 days later, it'll be 1.6. Then maybe 4 weeks later, it'll be 1.8. So this is what is described as step ladder worsening of kidney function. So kidney function worsens, stabilizes, worsens, stabilizes, worsens. Now, there are certain clues which they might give you. One clue, of course, we already talked about the step ladder worsening. The other is eosinophilia. So when the cholesterol goes and uh, goes to the kidney and causes some obstruction, it does cause an eosinophilic response. So when again, most of you probably, again, if you pay attention to your patients who are really vasculopaths, like who've got a lot of bad vessel disease, you'll see their eosinophil levels are high. Probably they are having some low level of athromembolic disease from unstable plaques, right? So one of the clue is eosinophilia. Acute athromembolic disease can also cause transient low complements, and then you have to take the patient's socks off to actually see. Again, this is a very florid case of athromembolic disease, but you could have milder cases, right? So you can have small infarcts or nail infarcts, but you have to be actually looking at the peripheral sites. Hollenhorst plaque are these small yellow dots in the retinal blood vessels, which were actually found by Robert Hollenhorst. He was an ophthalmologist, and he figured out that these were cholesterol emboli, which were actually going to the retina, right? Livedo reticularis is this uh, purplish, lacy rash, which you can see in acute athromembolic disease as well. What do you do about it? Consider, a major thing is you want to stabilize the plaque, which is throwing this athromembolic disease. So you would start them on statin. There's some evidence that, again, if somebody is on Coumadin or anticoagulation, they should be stopped. Of course, you're not going to stop it if the indication was AFib. But again, if it is a frivolous indication for, does not make sense why the patient is on anticoagulation, consider stopping it. Yeah, kind of a little counterintuitive, right? But the major thing would be statins and watchful waiting. Okay. Yeah. So, there's some evidence that if you continue anticoagulation, you will actually continue to throw plaques. So it makes the plaques unstable. But again, if the indication is very strong for anticoagulation, of course, I'm not going to stop it. I'm just going to start them on high dose statin. But pretty much, there's very little you can do about athromembolic disease once it happens. 51-year-old female with AKI, history of hypertension, hypercholesterolemia, and type 2 diabetes. Medications are lisinopril, HCTZ, glipizide. 2 weeks prior, admitted to another hospital because of weakness. Lab tests 2 weeks earlier showed a serum creatinine of 1.4 with an estimated GFR of 42. Hemoglobin at that time was 10.1. And because of this low hemoglobin, she underwent a colonoscopy. Now she's coming to you, a routine visit, no major complaints, but her serum creatinine is 6.3, which is very different. Potassium of 5.3 and phos is 11.2. What is the etiology of her acute kidney injury? So I'm going to move on. So you've got 12 seconds. Okay, so the right answer is acute phosphate nephropathy. Um, People, everyone was kind of split between A and D, and I think A is a potentially reasonable answer too because it does cause ATN2. But the boards here would be looking for a very specific etiology of what is causing the problem, and I think this is a very fair question. Uh, because this was an unrecognized cause of AKI for a long time. So, acute phosphate nephropathy is injury which happens when patients are exposed to phosphate containing oral ball preps or even enemas, Fleet's enema. That's why in my hospital, we've actually kind of almost banned Fleet's enemas. There's so many alternatives. Why would you give something which is going to put your patients at very, very high risk? So generally, it is recognized only when lab studies are performed after this sodium phos ball prep or enema has been given. This is a patient in my hospital who, we could not figure out why this patient was an acute kidney injury. We did a biopsy, and what we found was, again, this is calcium phosphate deposition in the distal tubules. All the tubules were just full of calcium phosphate deposition. And then we went back and could not figure out what happened. And the reason was this patient did get multiple Fleet's enema, but since they were PRN orders, they don't show up very clearly. It was given by the nurses 5 times in 2 days for constipation. The patient did not recover kidney function. So the risk factor for phosphate nephropathy are patients who already have existing kidney disease, and now you're giving them high doses of sodium phosphate. Patients with diabetes, and anyone, I'm putting older age, but anyone more than 50 or 55 who's got diabetes, hypertension, and all the chronic kidney disease risk factors, they are very, 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 very high risk. What is the clue going to be? Hyperphosphatemia is out of proportion to the degree of kidney injury. Look at the last question which I gave you. Phosphorus levels was 11.2. Very high phosphorus. And acute kidney injury, we do see high phosphorus levels, but 5.5, 6.6, 11.2. And there was no other clue what happened other than the patient had a colonoscopy. Of course, they're not going to give you that this patient got over sodium phosphate. They want you to make that inference that most likely the patient was given a sodium phos prep. So clinical messages, please avoid sodium phos preps in your patient. There's a lot of other options available. So you gotta avoid it as much as possible, and also avoid Fleet's enema because it's an under-recognized cause of acute kidney injury as well as chronic kidney disease. Yes. Oh, this one? Yes, this one. So these are phosphate deposits. These black stings. These are all calcium phosphate deposition in the distal tubule. Very, very unusual, other than with phosphate nephropathy. Sure. Some others, for board's purposes, this is really, really, really important. This is also, why is it important? Because it's an under-recognized cause of acute kidney injury. A lot of patients who we thought had hepatorenal syndrome might have compartment syndrome, abdominal compartment syndrome. So me and you have an abdominal pressure of about 5 or 6. Right? If I checked my abdominal pressure, it would be about 5 or 6. If you are slightly obese, it might be a little higher, 6 to 8, 8 to 9. If you're on positive pressure ventilation, it could be slightly higher, 9 to 10. But most of the time, our abdominal pressures are below 10. When you have an abdominal pressure more than 12, we call it intra-abdominal hypertension. But once your abdominal pressure goes more than 20 and you start having organ dysfunction, we call it abdominal compartment syndrome. Why? So, what happens? So, if your abdominal pressure is really, really, really high, what it does is it actually compresses the renal veins. Abdominal pressure of 25 or 30 is not going to be able to compress the renal artery, right? Arterial pressures are very high. Your abdominal pressure will have to be 70 or 80 to compress the renal arteries. If that's the pressure, your belly would explode. You cannot take that higher pressure. So what is happening is you're compressing the renal vein, venous return is being affected, and you go into organ dysfunction. But why is it important is because when you do the labs in these patients, if you check of course, the kidney function is going to be getting worse, right? When you have like massive ascites. And when you check a urine sodium and fractional excretion of sodium, what is it going to be? It's going to be low. And then what are you going to be thinking of? Like, oh, the patient is pre-renal. Give them more albumin, give them more fluid. What is it going to do? It is going to worsen the situation. Right? Why is the fractional excretion of sodium low? Because the veins are being compressed. How do you do it? How do you check for it? It's very simple. You just actually put a Foley catheter in your bladder, put 25 cc's of normal saline, and attach a transducer to it. It can be done within 5 minutes on the floor, but somehow, even in my hospital, I have to sell my soul to do it on the floor. I'm like, oh, the patient has to go to the ICU. I'm like, no, it doesn't. You just have to put in a Foley and attach a transducer, and you have your answer. But again, there are policies. It's very, very, very simple, right? So if somebody has massive ascites, before you call it hepatorenal syndrome or volume depletion, please, please, please check their abdominal pressures. If it is more than 20 and you have organ dysfunction, what are you going to do with massive ascites? Do large volume paracentesis, and the kidney function will start improving. Or, the second place where we see it is with necrotizing pancreatitis. Like, the belly can become very tense because of the inflammation. Very, very tense. And you start going into organ dysfunction. In that place, the treatment is decompressive laparotomy. So the surgeons will come in, I'm like, can you just open up the belly and keep it open till the inflammation subsides, and then you can do a secondary closure. Yes? If you don't think about it, you will never actually order this test. So in the right situation, the boards will expect you to do, like, check the abdominal pressures. How do you check the intra-abdominal pressure? Foley, 25 cc's of normal saline, attach it to a transducer, and it will give you. Okay, what are some of the pearls which we talked about? On the board questions, if you have a dipstick which is positive for 3+ blood, but you're not seeing many RBCs, please think about hemoglobin or myoglobin, right? We will talk about this in the next section. If you see dysmorphic, if there's any mention on the urine analysis that the patient has RBC cast or dysmorphic RBCs, automatically you should be thinking about glomerulonephritis. Okay, anytime these two words are mentioned, you should be thinking about glomerulonephritis. And we'll discuss more this in detail. Sterile pyuria. That means the patient has WBCs in the urine, but there's no evidence of infection. Most commonly in US, what should you be thinking about? Interstitial nephritis, interstitial nephritis, interstitial nephritis. But again, in the right setting, sometimes you got to think about tuberculosis too, right? If somebody is from a high prevalent area and, tuberculosis, renal tuberculosis actually might present like this too. Eosinophils can not only be present with drug-induced interstitial nephritis, but can also be seen with atherosclerotic disease. Yes? Okay. 77-year-old presents with nausea, vomiting, general malaise, 10 cc's urine output in the last 2 days, past medical history, hyperlipidemia, hypertension type 2, diabetes, cigarette smoking for the last 40 years, pale and stuporous, blood pressure is high, heart rate is 88 beats per minute, loud carotid bruise, faint systolic ejection murmur, lungs are clear, slightly distended abdomen that is soft and without peritoneal signs. Blood sugar is 142, potassium is a little high. The kidney function was normal about 2 months back, but now the creatinine is 6.4, BUN is 165. When you do a urine analysis, you don't see much. Bland is like you're not seeing WBCs, RBCs, protein, nothing much. Which of the following is the next best step in the management of this patient? Okay, most of you got it right. I'm not going to spend time. So please don't do fancy tests if all you need is a Foley catheter, right? So you gotta, we forget. I've seen that in clinical practice multiple times too. People are doing urinary lights and fractional excretion of this and that. All you needed to do was do a physical exam. That belly was distended because it was the bladder. You put in a Foley, 1 liter of urine comes out. You have a diagnosis, right? It's just this. It's probably obstruction, right? All it is trying to do is say is whenever you're thinking about acute kidney injury, the first thing which you got to rule out is obstruction, especially if the urine analysis is bland, there's no other clear signs of volume depletion, nothing at all. The first part of management strategy is making sure that there's no obstruction. And ejection murmur, these were all distractors trying to, it's commonly you see ejection murmurs too. Okay. Now let's move on to glomerular disease. As I told you, the uncommon things are asked commonly by the boards. I have no reason why, but what I'm going to try and do is give you an approach rather than make you memorize stuff. So glomerular diseases, the big things we'll start with is what are the signs of glomerular disease? The one big thing is what? Proteinuria, proteinuria, proteinuria. How do you know that somebody has proteinuria? You do a dipstick, it'll show you 2 plus protein or 3 plus protein, but that is not enough. What you need to do is you need to quantify the protein. How can you do it? About 25 years back, everyone used to have a 24-hour urine protein, right? You would be carrying your brown bag and you're collecting your urine, and then you got to actually put it in your refrigerator, and God forbid, if you spill it, you'll be scarred for life, right? That there's urine in your refrigerator. So now there's good amount of evidence that we don't need to do that, right? Other than for stone disease, which we're going to talk about, most of the time I don't need to know exactly whether you have 2.12 grams of protein or 2.15. I just need an estimate, quantitatively. So what you need to do is just do a random urine spot protein and random urine spot creatinine, and you divide it, and you'll get roughly the amount of protein which you're excreting in 24 hours, right? So when you do a random urine protein to creatinine ratio, if it comes back to be 2, what does that mean? It's 2 grams. If it comes back as a ratio comes back to be 0.5, 0.5 means there's 500 milligrams. But if it is 2, 3, or 4, that means that's 2 grams, 3 grams, or 4 grams of protein in the urine. Yes? Generally, glomerular disorders will have, again, it's not a hard and fast rule, but generally glomerular disorders, like again, if there's some problem with the glomerulus, generally the protein level is going to be more than 1 gram. Not a rule. Sometimes it could be 0.7 or 0.82, but generally more than 1 gram. Whereas again, if you have some damage to the interstitium or the tubules, you could have minor amount of proteinuria, generally most of the time less than 1 gram. Right? Again, there are no rules in medicine, right? Anytime you make a rule, it's broken. Right? But generally some kind of ballpark areas when you're thinking about the disorders. Now, the first step in actually diagnosing these patients is to divide them into the patient who's coming in with acute kidney injury, does this patient have nephrotic syndrome or nephritic syndrome, right? These are not diagnoses, these are just structural frameworks for you to actually come up with a differential diagnosis. So nephritic syndrome is itis, itic, right? That means there's inflammation. And if there's inflammation, what are you going to see? Blood in the urine along with proteinuria. But the main feature is blood in the urine. So anytime, so this is my, you might not be able to see, most of you are not going to go and take a look under the microscope what's happening in the urine. But anytime you see hematuria and proteinuria together, you should be thinking about nephritic syndrome. Whereas nephrotic syndrome, what is the major feature? Proteinuria. How much proteinuria? Massive amount of proteinuria. What is massive amount of proteinuria? More than 3.5 grams. Yes? That's the first branching point in a patient question you got to think about. Is it nephritic syndrome or nephrotic syndrome? Right? What are you going to see? So a patient comes in, has acute kidney injury, you do a urine dipstick, you'll see protein and you'll see blood. Anytime you see protein and blood, what should you be thinking about? Nephritic syndrome. But when I look at the protein, I want to quantify the protein. How are you going to quantify the protein? Just do a random urine protein to creatinine ratio and you'll have the result within 15 minutes. Right? So what are the features of nephritic syndrome? Glomerular hematuria. How do I know that it is glomerulus? It is coming from the glomerulus. Will in the boards, in the exams, they will give you a hint. They'll either give you that the RBCs are dysmorphic or there is an RBC cast. That means the blood is coming from where? From the glomerulus. But in clinical practice, for as long as you have hematuria associated with proteinuria, you should be thinking that it is coming from the glomerulus. Yes? Of course, we are talking about acute kidney injury. So this is nephritic syndrome is the one which causes your kidney function to decline. And since the glomerulus is not working properly, you can start retaining salt and water, which can cause hypertension and a little bit of edema too. But nephritic syndrome is what causes acute kidney injury, not nephrotic generally, nephritic. And for nephritic, what should you have? Hematuria and proteinuria. What kind of hematuria? Coming from the glomerulus. How do you know? Dysmorphic RBCs or RBC cast. Awesome. So this is, again, a picture from my iPhone. You can see, again, that's why it's this, not that great. So you see these small dots. They are forming kind of a cast kind of a structure. So this is an RBC cast. These are beautiful round-looking RBCs. But can you see these broken RBCs? Can you see this RBC? Does not, and some of the RBCs have these blebs. These are called dysmorphic RBCs. When you see dysmorphic RBCs, I know that this RBC is coming from the glomerulus and there's inflammation in the glomerulus. So how do I approach it? You have a patient who has kidney dysfunction and you check the urine and what did you find? Hematuria and proteinuria. You're like, okay, I got it. The patient has what? Nephritic syndrome. But what do I do now? What do I order? So your approach should be based on checking. The first thing you should check is complement levels, C3 and C4. Order a C3 and C4. Your nephrologist and your rheumatologist are going to love you because, they'll already have some kind of a framework. So do C3 and C4. If the C3 and C4 comes back low, what does my patient have? Immune complex disease. Now you just have to memorize it. I have no structure for it. It's 4 big things I want you to remember for your boards are infection-related GN. Never forget about infective endocarditis. Infective endocarditis could look exactly like immune complex GN. So anytime before I call somebody as having immune complex GN, I always check blood cultures, do a good heart exam, and maybe do an echo too, if I'm still worried, before I start immunosuppressives. There's a lot of diagnostic errors have been made where infective endocarditis has been confused with other immune complex GNs. Lupus nephritis and cryoglobulinemia. So you got to just remember it. If you check complements in these cases, what is it going to be? It's going to be low. Now, the generally complements will come back within 2 to 2.5 hours if your lab is checking it twice a day. Let's say the complements come back normal. Now what do? Check 2 labs. Most of us actually, since I am in a hurry, we don't sometimes practice cost conscious care. I'll just order complement, ANCA, and anti-GBM together, though I shouldn't order ANCA and anti-GBM if the complements are low, right? If the complements are normal, I would check ANCA and anti-GBM. If the ANCA comes back positive, there's only 4 diagnoses. Either 3 are vasculitis. One is GPA, which we used to call Wegener's. We don't call it Wegener's because of Dr. Wegener's Nazi association, so that is gone. The second one is microscopic polyangiitis, and the third one is EGPA, which used to be called Church-Strauss syndrome. Church-Strauss they had no Nazi association. They were amazing pathologists, but since they were changing the name of Wegener's, they're like, this needs to be changed too. So EGPA. Again, more descriptive than just, eponyms. So all these 3, GPA, microscopic polyangiitis, and EGPA, are vasculitis, right? That means you will have systemic symptoms. It's not just limited to the kidney. These patients are going to present with multiple visits to the primary care physician for, pneumonias or lung infiltrates, not feeling well, fatigue, night sweats, weight loss, type B symptoms. But there is a form of ANCA vasculitis which is only limited to the kidney. There's no systemic symptoms. This is called kidney-limited ANCA. Whereas anti-GBM, you checked an anti-GBM comes back positive, it is anti-GBM kidney disease. 4 weeks later, this patient develops lung bleeding, alveolar hemorrhage. We start calling it Goodpasture syndrome. It's a matter of semantics, right? Treatment is exactly the same, right? Now, there's one major glomerulonephritis which is missing from this framework. IgA. Why is IgA missing from this framework? I've put this right in this corner. Why? Because it is an immune complex disease. When I look at the biopsy, I'll see complement deposition. But why is it not here? Because serum complements are totally normal. So yes, there's complement activation, but the complement activation is just happening at the level of the kidney, and it's not severe enough to drop the serum complement levels. So IgA will have, even though it's an immune complex disease, but it will have normal complements. So 3 diseases with normal complements are what? ANCA, anti-GBM, and IgA. And I'm repeating stuff because this is what you're going to be. If you know these facts, and you can handle any question which is thrown your way related to it. Now I'm just going to briefly talk about some of the common clinical pearls. I'm not going to spend too much time. I'll just give you what you need to know for the boards. Infection-related glomerulonephritis, normal complements or decreased complements? Decreased complements. Generally, it used to be called post-strep, right? But now we know that it's not just strep. Staph can also cause acute infection-related GN, right? But the most commonly, which is described as the post-strep, which happens after streptococcal pharyngitis or impetigo, that means you have upper respiratory tract infection, and about 2 weeks later, you will come in with cola-colored urine, right? That's the classical illness script. Or 4 weeks back, I had a impetigo or a strep skin infection. Most of my patients have forgotten about that skin infection, so I have to remind them, was there any kind of skin infection in the last 4 or 6 weeks? Because they can't make that connection. So you have to make that connection. as I told you, there's a latency period in post-infectious. That means you have an infection, and there's 7 to 10 days after the upper respiratory tract infection, and sometimes 30 days after the skin infection, you will actually present with acute kidney injury and a cola-colored urine, which is nothing but blood in the urine, right? Uh, Decreased complement levels, increased ASO titer. If I checked your ASO titer will be elevated because all of us are exposed. So in the right setting, it might be helpful, but I would not put too much weight on it. Yes? Okay. IgA nephropathy, which used to be called Berger's disease. It's an immune complex disease, but what are the complement levels in IgA? Normal. So this, why have I put IgA and post-infectious together? Because compare and contrast. Both of them can happen after a upper respiratory tract infection, right? This happens after a flu-like illness. But what is the difference? This is what we call a synpharyngitic. That means you have a pharyngitis, and within 1 to 2 days later, you'll come to my, I'm like, oh, the patients come in very scared because, doc, I'm peeing blood. This sounds very scary. I'm like, well, it's just a very classical illness script in those cases where you had an upper respiratory tract infection. 1 or 2 days later, you come in and I've got cola-colored urine or blood in my urine. I know most likely it is going to be IgA. What is the difference between post-infectious? That happens 7 to 10 days later. And this is happening very close to the infection. Yes? What else is the difference? If I had to ask you to check one lab test, I'm like, oh, I don't know whether it's 1 to 2 days, 7 days, I have no idea. History was not very clear, he was not able to give me a good history. What will you check? Complement. Thank you so much. That is going to differentiate. Now, there is a systemic form of IgA nephropathy, which is called IgA vasculitis. Some of you, again, 15, 20 years back, used to call it Henoch-Schönlein purpura, right? But now it's IgA vasculitis. Generally, if you look at this picture, the clinical pearl is, it generally happens in young adults, and you will have palpable purpura. That means there's IgA deposits in the skin too. Anytime they mention palpable purpura, they are telling you that it's a vasculitis. Purpura could be because of thrombocytopenia too, but in thrombocytopenia, you won't have palpable purpura. How do you know it's palpable? Close your eyes and feel the rash. If you can feel it, it is palpable. If you can't feel it, it is non-palpable. Right? Most of these patients have arthralgias, that means fleeting joint pains. They come in with abdominal pain too. Why is there abdominal pain in these patients? Mesenteric vessels are involved too. Right? And of course, we are talking about nephritic syndrome, so you'll have a nephritic syndrome kind of a picture, proteinuria and hematuria. Make sense? Okay, I'll bring it together, I promise you. Cryoglobulinemia was another one. Low complements or normal complements? Low complements. I'm going to tell you, this is one of their favorite questions. What they'll give you is a purpuric rash. Can you see this purpuric rash? Generally, mostly in the lower extremity. And they'll give you a story which sounds like Raynaud's. I'm like, oh my God, there's Raynaud's phenomena happening. But it's actually not Raynaud's. It's pseudo-Raynaud's. What is cryo? Just cryo is, and what if you just look at cryo and globulin. Globulin is a protein. Cryo is like a protein which precipitates in cold. So if you go to cold temperatures, it starts precipitating, and what you'll start seeing is bluish discoloration of your tips of your earlobes or your fingers. Why? Because this is where in the peripheral sites the temperature is low. Or like, oh, I have Raynaud's. As soon as you warm the hand, they resolubilize, so it gets better. Right? So the picture is going to be pseudo-Raynaud's vasculitis, which is like purpuric rash. But this is so classical. This is the only disease where complements are low, But it's very interesting how the complements are low. C4 is going to be really, really low, whereas C3 is going to be mildly depressed. All the other low complement diseases will have really low C3. In this one, C3 is slightly low, but C4 is very, very, very depressed. Does it make sense? So it's kind of an odd pattern of low complement. Most of the immune complex diseases do what? Low C3 and C4, but majorly C3. They depress the C3. This one majorly depresses the C4. If if you do know some pattern recognition, you will have like, oh my God, I think I know what's going on. Yes, there are three types of cryoglobulinemia. Type 1, which is monoclonal. This is what you see with monoclonal gammopathies like Waldenstrom's or lymphomas. But most commonly in your clinical practice, the cryoglobulinemia, which you're going to see most commonly, is what we call as the mixed pattern, which is a combination of monoclonal and polyclonal. This is associated with hepatitis C. Type 3 is purely polyclonal, and this is what we see with autoimmune diseases like scleroderma and lupus. Yes? Complements, low. And remember the pattern. C4 is going to be very low, C3 mildly depressed. As if you just recognize the pattern, you don't even have to look at the full question. I'm like, I've already know what they're trying to get to, so you don't even have to overthink. One interesting point is this monoclonal IgG directed against FC portion is nothing but rheumatoid factor. So most of these patients will have rheumatoid factor positivity. RF will be, you check a RF, RF is positive because that's what this is, monoclonal IgG directed against FC portion of polyclonal IgG. Okay. Lupus nephritis is not a diagnostic mystery most of the time. They'll give you tons and tons of clue. Nasolabial sparing. Can you see the nasolabial sparing here? This butterfly rash, serositis, mouth sores, alopecia, any kind of serositis, right? Pleuritis, pericarditis, low blood count. So they'll give you tons and tons and tons of clue. But their idea when they're asking about this in this context is going to be they want you to recognize this is a knowledge-based question, that type 4 lupus nephritis is the most common and is the most worrisome cause of acute kidney injury. When somebody is rapidly worsening, their kidney function is rapidly getting worse, most likely if I had to take a clue, like if I had to take a guess, I'll say most likely, I can, if I do a biopsy, I know I'm going to see type 4 lupus nephritis. Complements are going to be low. If the complements are low and you're suspecting this, what do you order? You order ANA because you start with a very sensitive test. And if the ANA is positive, then you go to a very specific test. What are the two specific tests? Double-stranded and anti-Smith. But, either of those two. Yes? This is one place, I was debating whether you need to, but there have been, boards does at least want you to know that, treatment is urgent. Induction is done by, we used to do cyclophosphamide quite commonly, but now it's changed to, I've put MMF in front of cyclophosphamide. MMF has less long-term risk. So you start with mycophenolate and steroids, and maintenance is also mycophenolate at a lower dose. So just a knowledge-based kind of. MMF is the first choice. So it actually blocks the purine metabolism, and it inhibits that, and very, very effective. We use it very, very, very commonly with transplant. Relatively safe, especially if you have somebody with the childbearing age, because lupus is very commonly seen between women 20 to 40, and you want to avoid fertility issues with cyclophosphamide. MMF has become the drug of choice. Yes, they're not going to go too much into detail. They might just ask. They're not going to give you MMF and steroids versus cyclophosphamide and steroids unless they're taking you towards fertility-related questions. Now, nephritis with normal complements ANCA and anti-GBM. ANCA, there are three types. GPA is what used to be called Wegener's. What is GPA? Upper respiratory tract involvement and lower respiratory tract involvement. Upper respiratory tract involvement can be in the form of anything. You name the thing. Otitis, laryngitis. The most common one is sinusitis, right? Chronic sinusitis. But tracheobronchitis, you name the thing, and it can cause in the upper respiratory tract. And similarly, it can also cause anything in the lower respiratory tract, fleeting infiltrates, cavitary lesions, pneumonia-like infiltrates. But the most dreaded complication is what? DAH. What is DAH? I should have diffuse alveolar hemorrhage. So what is GPA? You have upper respiratory tract involvement and lower respiratory tract involvement. C ANCA is the pattern which is positive, but C ANCA is just an immunofluorescence pattern. You have to confirm it with ELISA, and the antibody is against proteinase 3. Yes? All these three are what? Vasculitis. So you will have type B symptoms. Other organ systems might be involved, right? Microscopic polyangiitis is also a vasculitis. So you can have, palpable purpura. But the most common thing which we see in clinical practice is these are the patients who present with mononeuritis multiplex. What is mononeuritis multiplex? So today I'm coming in with a left wrist drop. 4 weeks later, I come in with a right foot drop. So there are two peripheral nerves being involved in two different distributions. So anytime you've got two peripheral nerves being involved in two different distributions, you got to be thinking about vasculitis. At least the thought should cross your mind. What is happening is the vasa nervorums, these are the small blood vessels which supply the nerves, have inflammation. Right? Two peripheral nerves in two different distributions. The pattern here on immunofluorescence is going to be perinuclear. That means it's going to light up around the nucleus. And when you do an ELISA, it is going to be the antibody is going to be against myeloperoxidase. eGPA, very easy. Very, very, this is a pattern recognition, right? They'll give you, the patient has either asthma, or sometimes they don't even give you asthma. Like, oh, this patient has been using his friend's inhalers for the last 2 or 3 years or 4 or 5 years. So some kind of history which suggests that there's some bronchoreactive disease. These patients also have mononeuritis multiplex. They can have two nerves being involved. But the classical feature is going to be what? Eosinophilia, 3,000, 4,000, 5,000. High eosinophils, definitely more than 1,500. Yes? So it's compare and contrast. All three will have generally, most of them will have ANCAs, but these are the common ANCAs. C ANCA and anti-proteinase 3 is generally with GPA or Wegener's. P ANCA and anti-myeloperoxidase is mostly with microscopic polyangiitis. eGPA can be either of those two, but more commonly P ANCA. Yes? Does anyone know what is, I shouldn't go tangential, but I will for 1 second. Does anyone know what is atypical ANCA? Have you seen atypical ANCAs? Like, oh, this is what the ANCA is when you have inflammatory bowel disease, right? So the ANCA is either of these patterns is going to be positive, but when you do ELISA, there are no antibodies against proteinase 3 or myeloperoxidase. So this is what you see with IBD. That the ANCA is, on immunofluorescence, the ANCA is positive, but when you do ELISAs, you cannot find antibody against proteinase 3 or myeloperoxidase. That's why anytime you do these patterns, you always have to do reflex ELISAs. I want to see, is it real ANCA? You always have to do reflex ELISAs against proteinase 3 and myeloperoxidase. How do you remember all this? Looks for clues in history and lab results. If the patient has nephritic syndrome, what are you going to use as the first step? Complement, complement, complement. And rest goes very, 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 very simple. Everything should fall into place just based on what I told you. There should be no way you are going to make mistakes in figuring out what is going on. Okay, a 19-year-old male, tea colored urine for 1 day, has some runny nose, cough for the last few days. Blood pressure is 138 over 92. Exam otherwise is normal right now. Urine analysis, there's RBCs. I did not give you dysmorphic or anything like that, no clue there. But there's 2 plus protein. ASO titer is positive, creatinine is normal, and C3, C4 is normal. Which of the following is the most likely diagnosis? So 71% of you picked IgA. That's correct. There were some responses infection related, and there was few responses towards post strep, which are kind of both similar, right? Both of them are infection. So there's some confusion still between infection and IgA. So I did give you ASO titer was positive, but that was if I check, as I told you, like if I just randomly checked all of you, 30 to 40% of you might have a ASO titer, which is positive because you've been exposed to strep in the past. What was the big clue here? It was synpharyngitic, one. It was whatever was happening very close to the infection. It was not 10 days later. He was having active infection just few days back. But even if you didn't know that clue, complements were normal. If it was infection related, the complements would have been low. So there were 2 clues. One, it was close to the infection, and the second one was complements were normal. If you just didn't know anything at all, and if you just knew which ones have low complements, so infection-related GN has low complements, endocarditis has low complements, post-strep has low complements, lupus has low complements. So if just based on complements, you could have ruled out 4, because there's only one with normal complements. And you would have actually picked up the right diagnosis. Yes? Great. Okay, nephrotic syndrome. Again, it's the syndrome, it's not a diagnosis. What is the major feature? Compared to, in nephritic syndrome, it was, there was hematuria was the major feature. Here, the major feature is what? Massive amount of proteinuria. And when you do the urine analysis, you will see there's not many diseases which will give you fat droplets in the urine. Why would you have fat in the urine? Lipid droplets. The only 2 reasons would be either you have genetic hypertriglyceridemia or nephrotic syndrome. Yes? What is it? So if you did a dipstick, you will have 4 plus protein. That means massive amount of protein. And of course, you know that anytime you see a dipstick positive protein, you got to do a urine protein to creatinine ratio. You did that. It was 6 grams, let's say. Massive. I know that this is nephrotic range proteinuria. But what is nephrotic syndrome? So what happens is there's something wrong with the glomerular podocytes. So these are the epithelial cells in the glomerulus, which become, faulty, and you start leaking protein. What is the major protein which is lost in the urine? Albumin. Right? So you're losing, when you have nephrotic syndrome, you're losing a lot of albumin in the urine. Where is the albumin made? Albumin is made in the liver. So when you lose a lot of albumin, what does the liver do? Liver is a smart organ too. It starts making more albumin. It revs up its albumin production by about 30 times. 30 times. But even though it is increasing its albumin production by 30 times, it cannot keep up with these losses. So ultimately, what happens? You become albuminic. Yes? You cannot keep up. Ultimately, you become hypoalbuminemic, and because of hypoalbuminemia, which is a major oncotic protein, which keeps all the plasma volume in the blood cell, now you develop edema. Now, you're losing a lot of oncotic protein. liver is cannot it's revved up its albumin production by about 30 times. Now it's just now thinking that, I cannot keep up with, I cannot go up on the albumin production. I need to generate something else which is oncotic. And what it starts making is lipids. That's why you become hyperlipidemic. And once your lipid levels go so high, some of them start spilling in the urine. That's what you see. That's why you see lipiduria. So some of the fat droplets are now in the urine. This is a fat droplet. Under polarized light, it looks like this Maltese cross. Yes? Confusing you? No. Make sense? So you need to understand what exactly. So, but I told you this is a syndrome. It's not a diagnosis. But once you know that somebody has nephrotic syndrome, now I'm going to give you a little bit of post-traumatic stress disorder too. Soon, the next slide. One thing before I give you some PTSD, I do want you to know that along with albumin, there are certain other proteins which are also being lost. You lose antithrombin and you lose plasminogen. So some other proteins are being lost too, which makes these patients hypercoagulable. They are at high risk of forming clots. And there's a portal coming in the next few slides about this. Why? In which situation they're very hypercoagulable, and what do we do about it? Okay, so this is where you guys, how many of you remember this? Minimal change, membranous, FSGS. Oh my God, you thought you'll never hear about this again, right? After med school. So here, for boards purposes, they want you to be a betting person because most all these three groups are going to present exactly with nephrotic syndrome. All of them are going to present with nephrotic syndrome. And what the boards wants you to do is they want you to be on a slot machine of based on what you know about the epidemiology, they want you to make an intelligent guess that what is the most likely diagnosis. Most of them will require a biopsy, not all of them. But based on epidemiological factors, you can actually come up with the most likely diagnosis. Okay? Clues. Minimal change disease. Most common in children and young adults. So if a 23-year-old is coming in with acute onset nephrotic syndrome, it is most likely minimal change disease. If a 12-year-old kid, I know we are not in pediatrics, but if a 12-year-old came in with nephrotic syndrome, nobody gets a biopsy. It is assumed that the patient has minimal change disease and they start them on steroids. Right? So most common cause in children and young adults, sudden onset of nephrotic syndrome. I want you to know, board wants you to know two associations. Association, I'm not calling causation because we don't fully understand how they do it. The two big ones are if somebody was taking NSAIDs and suddenly develops. So NSAIDs can cause minimal change disease, and Hodgkin's lymphoma. Somebody is coming in with lymph nodes in the has nephrotic syndrome, and you're doing an exam, and there are tons of lymph nodes in the cervical area. Think about Hodgkin's and minimal change disease go together. Treatment very responsive to steroids. Within 2 to 3 weeks, the nephrotic syndrome is going to go away. Most of us do a biopsy in these patients if we do not get a response to steroids. Yes? Okay. FSGS. Most common primary kidney disease. I'm just, notice the Black patients with African ancestry because race is, it's not a biological construct. It's a social construct. Right? I cannot, by looking at you, say, so it is, I'm categorically saying this because, people confuse social constructs and biological constructs. Race is a social construct. So this is high risk in patients with African ancestry because of two genes. One of the biggest one is ApoL1, and now there are treatments coming. And of course, there's a lot of research going on. Why is there hypertensive chronic kidney disease very common in Black patients? And now there is, of course, there's a lot of social determinants of health which are responsible. But ApoL1 is one gene with targeted therapy, which is going to be actually become very, very common as a point of discussion and treatment strategies. So again, if you have a patient with African ancestry who comes in with nephrotic syndrome, you should be thinking about that there is a high risk of FSGS. Yes. There are some other association. It is associated with, it's a different type. It is associated with obesity. If your BMI is very high, more than 40, the kidneys are hyperfiltrating a lot of blood, and it can cause some fibrosis in the kidney. We don't see this form very commonly. We used to see what we used to call collapsing FSGS, which was nephrotic syndrome associated with HIV, but with advent of highly active antiretroviral therapy is very, very rare. Maybe in the last 3 years, I've seen only 2 or 3 cases. We used to see it very, very, very commonly. Yes? Again, if it is in white adult, the most common cause is membranous nephropathy. So if you were a betting person, but more than more than the race, the big association which I want you to remember is cancer, solid cell cancer. So if somebody has some clues about, maybe has a 50-pack year history of smoking, there was a nodule seen, and now you have nephrotic syndrome, my bet is going to be that the most likely diagnosis is going to be membranous because of its association with cancer. Now, this is one new entity which is like, we used to do biopsies to diagnose membranous nephropathy, but now there's a blood test called, how many of you have heard this? Anti-PLA2R antibodies. So you can actually, send this blood test. If the blood test is positive, most likely it is idiopathic membranous nephropathy. So you can, if patients do not want a biopsy, you can get away without doing a biopsy. Membranous nephropathy is the one which is associated with very high hypercoagulable state. Of all the nephrotic syndrome, somehow membranous nephropathy is associated with very high risk of thrombosis. Now, a lot of people have thought about, oh, maybe because there's a hidden cancer, right? Maybe that is it, but that has not been proven so far. Whether it is really because there have been no long-term studies which have kind of corroborated the risk of hypercoagulability and underlying cancers in this group of patients. But what they are going to check you on is this. So they'll give you a patient has known membranous nephropathy, and they'll give you a scenario that the patient is coming in with flank pain and blood in the urine. Anytime you see flank pain and blood in the urine, what gets triggered because of your type 1 reasoning or pattern recognition is renal stones. Right? Of like people flank pain and blood in the urine, it is kidney stone. But they are like, as soon as you see a history of membranous nephropathy, what should you be thinking about? You should be thinking about renal vein thrombosis or renal infarction. How would you know it? So if you have flank pain, hematuria, and you checked an LDH, LDH will be elevated. Why is the LDH elevated? Anytime cells are dying, LDH goes up. So anytime you have flank pain, hematuria, but the LDH is elevated, please don't think that it is a kidney stone. They are trying to tell you that there's a kidney infarction taking place. Yes? They are going to trick you on that. First, you need to know the association. The second, you need to know that what is the next test you're going to do. You'll check an LDH because flank pain, hematuria, and LDH, there is renal infarction. Most likely in this case because of renal vein thrombosis. Now, there are systemic diseases which can cause nephrotic syndrome too. Of course, the most common one is what? Diabetes, diabetes, diabetes. Generally, it progresses from microalbuminuria to mild proteinuria to nephrotic syndrome. But sometimes the patients initially who have not been followed can straight away come in with nephrotic syndrome kind of a diagnosis. Diagnosis, most of these patients, I do not do a kidney biopsy. The only people I end up doing a kidney biopsy is if I do a retinal exam and there's no retinopathy, right? I'm like, oh, that does not make sense. They have diabetic nephropathy, but the eyes look very clear. So these patients can also have other causes of nephrotic syndrome too. Diabetes is very common. In those cases, I will do a kidney biopsy. But all of these patients, before I call them diabetic nephropathy, I do check for light chains. That's my clinical pearl. Again, this is not for the boards, but a lot of these patients you can actually, who were labeled as having diabetic nephropathy end up having, not a lot, but there's enough in my practice where if I hadn't checked SPEP, UPEP, I would have missed myeloma or monoclonal gammopathy. Yes? So, so diabetic nephropathy, what you'll see is what we call as nodular sclerosis. So it's this like the glomerulus, there's going to be nodules seen in the glomerulus. And those nodules are fibrosed. It's slightly different than focal segmental. It used to be, I'm showing my age, it used to be called Kimmelstein-Wilson's lesions. Do you remember? No. Okay. So I forgot that I told you that. So the second one, which I don't want you to forget, is this is the board favorite. So mark it 10 times the next slide, which is going to come through. Just circle it 10 times because you're going to get 2 or 3 questions related to that. Just one slide, you'll get 2 or 3 questions related to. So this is what is amyloid? This is this amorphous eosinophilic proteinaceous deposit in the glomerulus. And if they say Congo red stain is showing apple green birefringes, oh, like, okay, this is amyloid, right? This is USMLE, this is medicine boards, it never leaves you. Apple green birefringence is amyloid, amyloid, amyloid. But two types of amyloid. One, the most common one is AL, which is the light chain amyloid, which is associated with multiple myeloma. The other one, which we used to see very commonly, was AA, but we don't see it very commonly now because it used to be with untreated rheumatoid arthritis before biologics or inflammatory bowel disease where there's chronic inflammation and this inflammatory protein SAA breaks down and deposits in the kidney. Don't see it very often. Most commonly, what we see is AL. Now, what are the clues which are going to be given to you? Multiple clues. If you have a patient with acute kidney injury and high calcium, gotta think about light chains. They love this clue. The boards loves this clue. Discrepancy in urine dipstick and urine protein to creatinine ratio. That means you did a dipstick and there's no protein. But I don't know why you decided that I want to check a urine protein to creatinine ratio. I actually, when I'm seeing a patient with chronic kidney disease, even with the dipstick is negative, I still check urine protein to creatinine ratio, and this is the reason. So dipstick is negative, and when you did a urine protein to creatinine ratio, it came back as 4 grams. You have the diagnosis. It is what protein is there. So it's not albumin, because albumin would have been picked up by the dipstick. What protein is there? Light chains. They will give you, so if you're not looking, your eyes don't see what your brain doesn't know. Your ears don't hear what your brain doesn't know. So if you're looking for the clues are going to be right in front of you. And they will give you this clue. Right? Dipstick is negative, urine protein to creatinine ratio is 5. It is light chains in the urine. Low anion gap. We always worry about high anion gap, right? I'm going to be talking about it soon. But when there's low anion gap, you should be thinking, I don't have time to explain that, but low anion gap should make you think about that there's paraproteins floating around. Total protein to albumin ratio. I use it all the time. Right? If your albumin is 3, what should your total protein be? 6 or 6.2, like somewhere close, right? It's not 2:1 all the time, very close to it. If your albumin is 4, your total protein 7.8, 7.9, 8.0. But if your albumin is 3 and your total protein is 8, it's not 2:1. That is where you should be thinking about, is there abnormal protein floating around? It could be, it could be paraproteins, or it could be polyclonal proteins from inflammation. But this is exactly where you, at least I would order SPEP, UPEP, or SIFE, UAFE, or serum-free light chain assay, whatever you want to order. Back pain in older adults with acute kidney injury, of course, not alone, but in the right setting, along with anemia, should also make you think about it. Yes? I can tell you, based on these, you are going to get 2 or 3 questions. And you will have multiple clues in the same question, but your eyes should be looking for those clues. Okay, nephrotic syndrome. How do I, if it's, you got to be a betting person, young adult and kids, association with NSAIDs and lymphoma, FSGS, African ancestry. Why? Because of genetics. ApoL1 and myosin heavy chain 9 this used to be protective about hundreds of years back against malaria and some other parasites, but that puts them at very high risk. Membranous association with solid cell cancers. There is a blood test. They might ask you about it. Association with solid tumors. We did not talk about MPGN because I don't think they're going to ask you too much about this entity. Just remember, if keep it in the back of your mind, it is also associated with hepatitis C, and this is one disease, MPGN, associated with hepatitis C, and it can present with a combination of nephrotic. Right? It can have high proteinuria, but it can also have blood. Complements are low. Okay, maybe I did not even tell you that. Remove it from your memory. If you have time, I'm seeing some place out. No, okay. Look for, so how to remember all this, look for clues in history and lab results, place the case in a broad category like nephrotic syndrome or nephritic syndrome, and just remember the key features and everything should fall into place. So an 84-year-old with type 2 diabetes and hypertension comes in with severe lower back pain and increasing confusion. 3-month history of 20-pound weight loss. Frail and generally decompensated with normal vital signs. There's some point tenderness over L3. These are the labs. I'm not going to read them. You can take a look at it. I'll just mention, the kidney function is bad. BUN and creatinine is elevated. Urine analysis shows some trace protein. Somebody did a 24-hour urine. I don't know why, but clearance was 18. So pretty marked reduction in kidney function, and the urine protein was 5.5 grams. Which of the following is the most appropriate next step in the patient's care? Okay, most of you, 88% of you are saying urine and serum. That is exactly, there were so many, maybe I should reduce the number of clues. There were so many clues. It was like ridden with clues. High calcium, kidney injury, total protein to albumin ratio was really high. And there was a final clue there too. Urine dipstick didn't show much protein, but the 24-hour or the urine protein to creatinine ratio, whatever, was 5.5. There's so many clues. Yeah, it was the diagnosis was actually screaming at you. Yes? Complement levels are very helpful in which syndrome? Nephritic syndrome, nephritic. Yes? 64-year-old, past medical history of hypertension, hyperlipidemia, osteoarthritis, now has new onset lower extremity edema, recent history of fatigue and tiredness, weight loss of about 5 pounds. Medications are Tylenol, metoprolol, simvastatin. Blood pressure is 122/74. Fundi not visible. There's 3+ spitting edema of lower extremities. Fasting BMP shows creatinine of 1.1, albumin is 2.1, total cholesterol is 314, glucose is normal, UA shows 4+ protein, and micro shows fat droplets. Urine protein to creatinine ratio is 7.5. Hemoglobin is 9.8, and stool occult is positive. What is the most likely diagnosis? So most of you did get it right that it is membranous. There were some which said amyloid and some said minimal change disease. So what was the clue? So again, uh, stool occult was positive. Hemoglobin was low. So this is trying to bring you back between an association between solid cell cancer and membranous nephropathy. So the other clue in this case could have been, that the patient was a 40-year smoker and a nodule was seen in the X-ray. That would have been lung cancer and membranous nephropathy. So in membranous nephropathy, what I would say is don't go wild on screening, doing a PET scan. You should do age-appropriate and risk-appropriate screening. So the right answer would be age-appropriate and risk-appropriate screening anytime you have membranous nephropathy. Amyloidosis, there was no clues towards amyloidosis, right? I did not give you any total protein to albumin ratio elevated, no discrepancy between a urine dipstick and what I'm measuring. So, no clue for amyloid. Yes, that's correct. I would do age appropriate screening, especially if it is membranous. And sometimes you are waiting for that diagnosis. I would at least start an age appropriate and risk appropriate screening. Yes, absolutely right. Any nephrotic syndrome. So that was just telling you that it was nephrotic syndrome. No, no. You cannot tell whether it's membranous, whether it's minimal change, or whether it's FSGS. Here, they're just trying to see whether you know the association and epidemiology. Ultimately, you can still be wrong. You can still find a biopsy and it's totally different, but they still want you to make an intelligent guess. Okay, I'm gonna do kidney stones and then we'll take a break. I know I'm seeing some glaze in the eyes, so just 10 minutes on kidney stones. We'll take a break for 15 minutes after that. Okay, a very important topic, so you gotta listen. Very common, and again, by the end of these 10 minutes, all of you will be kidney stone experts. I can tell you that because there's not much to it. World's largest kidney stone. How many of you? Okay, don't believe me, so don't believe whatever I say. That's not true. Just okay. Uh, Prevalence, very, very, very common. So the boards are going to actually test you on it because it's really common. 12% of men and 6% of women in their lifetime are going to get a stone. So if there were 100 people here, 100 men here, 12 of them would probably get a kidney stone at some point. Women a little luckier, less, but 6% is still a high number, right? And 30 to 50% will have a recurrence. So if you have a kidney stone right now, 30 to 50% will have another stone within 5 years. Crazy numbers. However, the good news is treatment can reduce this risk by 50%, which is a huge, 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 huge reduction. And what I'm going to tell you, the biggest treatment is diet, diet, diet. So that's why I don't even call it dietary recommendation. I call it dietary prescription. People listen to it when I'm like, I'm going to prescribe you a diet rather than I'm going to recommend a diet, right? Most common stone is calcium stones. 80% of the stones contain calcium. But again, if I have to ask you, just take a guess. What is the most common stone? The answer should be calcium oxalate, right? If somebody told you that I had a stone, I'm like, oh, was it calcium oxalate? And the answer most likely is going to be, yeah, how did he know? Right? Because it's the most common. So for me, there's only two types of stones. Either it's calcium-based stones or everything else. Calcium-based, the most common, as I told you, is calcium oxalate. The other one is calcium phosphate. So generally, no stone is a pure stone, right? So even the calcium oxalate will have a little bit of calcium phosphate, and the calcium phosphate will have a little calcium. But how do I call it, whether it's calcium oxalate or calcium phosphate, is the predominant mineral, right? So calcium oxalate is the most common. That means majority of the stone will have the majority of the stone crystals will have calcium oxalate as the main deposition, whereas calcium phosphate is less common. But anytime you see calcium phosphate for board purposes, just mark it there. They love distal renal tubular acidosis. Again, I have no idea why. They just love this diagnosis. So calcium phosphate stones are seen in distal RTA. We'll be talking about RTAs. I need to demystify it for you. Everything else, uric acid stones, 10% of the stones, they're becoming more and more common because of obesity and insulin resistance. Struvite stones are very massive stones. I don't take care of it. Urologist takes care of it because these are so massive, and these are associated with urea splitting organism like Staph saprophyticus, E. coli, Proteus, Klebsiella. They have to be surgically taken out. Cystine stones, why did I mention it? Um, there is a potential they might ask you, but I'm going to tell you what they will ask you about a cystine stone. Now, there are some drugs which are associated with stones which you need to know. Trimetrine, we don't use it very commonly, but used to be used as a potassium-sparing diuretic. Indinavir was a heart part of active antiretroviral, not commonly used. But sulfonamides, we use it very commonly. And how many of you thought about vitamin C as a stone-forming agent? We prescribe this as candy too, right? You've got upper respiratory tract infection, take 2 grams of vitamin C and get a stone too, right? You don't need it. In certain cases, again, if you're not a stone former, vitamin C is fine. But if you have a high propensity to form stones, vitamin C is terrible. Because what is vitamin C? What happens to vitamin C in the liver? Gets converted into oxalate. So I can't even tell you how many times I'm like, oh, I have calcium oxalate stone formers. I'm like, oh, so are you taking any over the counter? Like, yeah, 2 grams of vitamin C in the morning, 2 in the evening. I'm like, okay, we'll make it, the risk is going to totally go away once we stop it. And of course, there's some chemotherapies. So how do you think about stones? So just think about, going back to your chemistry days. If you take a beaker of water and start mixing salt in it, initially the salt will dissolve, right? You keep on adding more salt. Ultimately, the saturation is reached, and then you start forming crystals, right? Because if you add more salt, it cannot dissolve. This is exactly what happens in your urine. So there are some promoters of stone formation. So if you have high calcium in the urine, high oxalate in the urine, and high uric acid in the urine. So these are the 3 promoters. That means if these components are high in the urine, there's a high propensity for them to come together and form crystals. But there are some inhibitors in your urine as well. First is, the biggest one is high volume of urine. Why? It dilutes it's just like if I can dissolve more in salt and more solvent, right? The concentration is going to be low. Saturation is not going to be reached. So the biggest inhibitor is, of course, no matter what the stone is, one of the biggest advices you can give somebody is, increase your fluid intake. But then you have to show them, I show them, like, I've got 1 liter bottles there. I'm like, you have to drink at least 4 of those. It's not easy to do. You have to have a belt where you have a water bottle attached, because we are social drinkers. We don't drink all the time, especially if you're busy, you forget about drinking water, right? So low urine volume is a very, is a high risk, but high volume is going to decrease the risk. And what inhibits the stone, the only other component which we can manipulate is citrate. So citrate in the urine is good because it does not let calcium oxalate come together. Calcium oxalate is not soluble, whereas calcium citrate is dissolvable. So just remember, citrate is good, whereas all these 3 in your urine are bad. They are promoters. So either if you've got high promoters or low inhibitors, you're going to form stones. So what is the most Important two risk factors for stone formation if you have high promoters, right? The two big ones are high calcium in the urine and high oxalate. Of course, high uric acid is also a promoter, but the two big ones are calcium and oxalate. Low citrate is a promoter, right? Because if you have low citrate, high risk of forming stones. Yes? High promoters or low inhibitors. Okay. Now, how do you get, what is high calcium in the urine? So in men, it is defined as more than 300 milligrams per day, and women, it is defined as 250 milligrams per day. But these are not absolute, it's a continuum, right? It's not like, 301 is bad, and, in stone formers, it is like a continuous variable rather than a strict dichotomous kind of a breakout. What is idiopathic hypercalciuria? That means I don't know why the calcium in the urine is high. If your serum calcium is 11, I know why your urine calcium is high, because your serum calcium is high. But your serum calcium is totally normal. You're not taking too much vitamin D. You don't have cancer. You don't have sarcoidosis. Nothing. Your serum calcium is totally normal, but your urine calcium is high. About 30 years back, when I started my practice 26 years back in England, we used to check like, oh, where is this urine calcium coming from? Is it coming from the bones? Is it, the kidney is leaking it? Like, a lot of academic time was spent on and then we figured out it does not help clinically at all. What we know is there's a genetic component to it. It runs in families, this high calcium. And there are certain things which makes it worse. High animal protein diet. And I shouldn't just, last time I said McDonald diet, and some people are like, oh, why? What do you have against McDonald's? I'm like, no, it's because Burger King diet is similar too. So, so it's just a fast food diet, right? So if you have high amount of salt, sucrose and fructose, so calcium goes along with salt. More salt you take, and more salt is being excreted in the urine, calcium follows it. So how do you decrease the calcium in the urine? Do you decrease the animal protein intake, reduce the salt, and reduce sucrose and fructose, so empty sugars, right? There's only one drug treatment. So of course, I'll give them this dietary advice, and I'm going to say, if that doesn't work most of the time, along with the dietary recommendation or dietary prescription, I'll also give them a thiazide diuretic. So now you're on your way to becoming experts in stone, because there's only 3 drugs that we use. So if you have high calcium in the urine, which drug are you going to use? Thiazide diuretic. They'll test you on this. These all 3 are, they've been studied in randomized controlled trials. It's coming. That's going to be one of the 3 drugs. It's coming, right? High calcium. What we talked about dietary advice and thiazide diuretics. Now, let's say you're in your 24-hour urine, your oxalate is high. Where does the oxalate come from? Maybe you love oxalate-containing foods. We'll talk about, anything which is good has oxalate. Nuts, chocolate, rhubarb. I like strawberry rhubarb, like very high in oxalate. Spinach, very high in oxalate. So oxalate-containing food, some genetic disorders which you don't have to worry about because you're not in pediatrics, but most of the time, is low calcium diet. That is strange. Again, I'm going to take you back to when I started, when we were practicing stone in stone clinics. What our biggest advice was like, decrease your calcium in your diet, because the biggest risk factor is high calcium. And what we started seeing was more stone evidence. Why? Because if you decrease the calcium in your diet, the oxalate which you're eating is free to be absorbed. Whereas if you're eating calcium and oxalate together, calcium and oxalate go together in your gut, and they're excreted in your feces. Now your big question would be, oh, should we give them calcium tablets? The answer is big no, because there's huge amount of, the Nurses Health Cooperative study was a very definitive study here where people were taking calcium supplements. How many time will you remember for the rest of your life to take calcium with your meals? No, you're not going to take calcium with I can't even remember to take 2 pills with my meals. Like it is so difficult to, and for the rest of your life. So if you take calcium supplements which are not with your meal, you are going to actually worsen hypercalciuria. So it has to be dietary calcium. So what my recommendation is half of yogurt or 1 cup of yogurt with every meal, or a little bit of cheese, not too much, but a little bit of cheese or whatever calcium containing product you like, but with meals. Because what I'm trying to do is combine calcium with oxalate so that it is excreted in the feces. But do not recommend low calcium diet. It does not. All of them are, you don't need it. You again, if you're using osteoporosis, you're using, so you got to be very careful. My advice in stone formers is to just decrease the calcium in your diet rather than take calcium pills, because that is going to put them at higher risk of stones. So if you have high oxalate in your urine, so my advice would be reduce oxalate containing foods. There are a lot of handouts on Google. You can just put Google and it'll give you, so avoid spinach, rhubarb, beetroot, nuts. Avoid low calcium diet. This is what the boards are going to test you on. What is the biggest advice you're going to give them? Please do not avoid, please do not go to low calcium diet. That is a board testable thing. And this was a study in New England Journal, which it showed that you should at least have 700 milligrams of calcium in your diet, because the risk is that's where the optimal risk profile is. You are reducing your risk of stone by about 32%. Yes, do not advise low calcium diet. In fact, give them some calcium with their diet. The other big stone is, why is it important? It is uric acid stones are becoming very important because, as I told you, with insulin resistance, diabetes, and obesity epidemic, uh, this is tied down with insulin resistance. Uric acid stones are, if you did a plain X-ray, you're going to totally miss a uric acid stone because they don't have calcium in it, so it's not going to be picked up. That's why the CT scan is the first diagnostic imaging of choice for stones, because plain KUB is going to miss a uric acid stone because it does not have calcium, right? And their numbers is increasing. So if you look at this equation, if your pH is less than 5.5, if your pH is less than 5.5 in the urine, this reaction goes towards this uric acid. And uric acid is not soluble. Whereas if you increase the urine pH above 6, the reaction goes towards urate. Urate is very soluble. So when somebody comes in with uric acid stones, I tell my patient, like, this is one stone I can dissolve. In 2 months, the stone will be gone. There's no other stone. I can prevent stone formation, but most of the stones you cannot dissolve. But this one you can. How? By increasing the pH above 6, the reaction will go towards urate. So what is the biggest risk factor for uric acid stones? Acidic pH. It's not hyperuricasuria. Like you would think about, oh, uric acid stones, there's huge amount of uric acid in the urine, so I'm going to use allopurinol. Yes, we use allopurinol if you have hyperuricasuria, but if I have to give you a choice, the choice should be to alkalinize the urine. How do you alkalinize the urine? Potassium citrate. So now your second drug, which I'm going to tell you, is potassium citrate. So one was thiazide for hypercalciuria. Second one is potassium citrate. What am I trying to do? Get your urine pH above 6. How do I do it? Potassium citrate, 20 to 30 milliequivalents 2 or 3 times a day. I have to sit down with them. This is very hard for people to follow. I can't even take one medication once. 2 or 3 times a day. Really, really difficult. But again, very effective. Very, very, very effective. The second drug would be allopurinol if your uric acid in your urine is high. But most of the time, it is a problem with urine pH. Yeah? Does it make sense? And since it is associated with diabetes, obesity and metabolic risk factors, you also want to improve the metabolic risk factors too. So, medical treatment of stones, only two: thiazides if you have hypercalciuria, potassium citrate if you have uric acid stones, or if your citrate is low in the urine, right? And you can use you can add allopurinol if you have hyperuricosuric. Yes. Okay, dietary prescription, more effective than any of the drugs which I've talked about. Urine volume, you want to increase the fluid intake to maintain a urine volume of at least 2 liters. I generally try for 3 liters, but it is very, very hard to do because to have 3 liters of urine, I have to drink 4 liters of fluid, right? Because there's 1 liter of insensible losses. So you got to drink a lot. I give them a belt, fluid belt, where you can have a bottle, reminders that you have to drink water. So a lot of coaching needs to go into place. If you have high urine calcium, that means hypercalciuria. What are you going to advise them? Go off of McDonald's or Burger King's diet. Decrease animal protein intake, reduce sodium intake, reduce sucrose and fructose. If you have high urine oxalate, avoid high oxalate containing foods. So give them, rhubarb, spinach, nuts, adequate dietary calcium. I showed you the evidence where that 700 milligrams of calcium in the diet comes from. Avoid vitamin C supplements. Why? Vitamin C is nothing but oxalate. Well, high uric acid, reduce, of course, reduce animal protein intake because a lot of uric acid comes from red meats, right? Low urine citrate. Where do you get citrate from? Fruit and vegetables. So decrease the animal protein intake, but to increase the citrate in the urine, increase fruit and vegetable intake. And that will, and of course, by decreasing the animal protein intake and increasing the fruit and vegetables, that will improve your citrate. But if it doesn't, what will you add? Potassium citrate. Okay. So key points. Calcium oxalate is the most common type of stone. This is the stone which we see with primary hyperparathyroidism too. But that is, no matter what, is the most common. If you see calcium phosphate stone, think about distal renal tubular acidosis. We talked about uric acid stones are becoming more and more common. They're radiolucent since they don't have calcium. What is the primary treatment? Increase the urine pH. Main risk factor is low urine pH. Struvite or surgical stones associated with urea splitting organisms. They might show a hexagonal crystal. Maybe I'll put a hexagonal crystal next time. If you see a hexagonal crystal as cystine stones, very rarely I've heard that they might check you. I don't know why they would. It's so uncommon, and I don't expect. But I've still put in. If you see a hexagonal crystal, it is cystine. A 50-year-old presents to the ER with right-sided flank pain. CT scan reveals a 4-millimeter stone in the right ureter that the patient subsequently passes. On analysis, the stone is found to be composed entirely of uric acid. In addition to encouraging fluid intake, of course, you should be encouraging fluid intake in everyone. Which of the following is the most appropriate next step? Almost all of you got it right. Increase the urine pH. HCTZ or hydrochlorothiazide would be used if I gave you that the patient had calcium oxalate stone and also had hypercalciuria. Decreased dietary calcium should never be the answer. Increased dietary calcium would also be the answer for calcium oxalate stones. Yeah, and you don't want to recommend high purine diet, right? You gotta, for uric acid stone, it should be a low purine diet. Yes. Yes, I don't think they'll give you pictures for stone. That's why I put, initially I was going to put a hexagonal crystal for cystine. but they're not going to show you, envelope shaped crystal for calcium oxalate or needle shaped crystal for your. I would not. No, I would not. I would not waste my time on. They are not going to show you pictures. We are going to take a break before we start acid base. Okay. So now, acid base. So just a disclaimer that I am going to just run through acid base because there's a separate module for acid base which is already available. So what I am going to be focusing on is just a broad approach and maybe spend a little time on a topic which is not very well understood, renal tubular acidosis. It's uncommon, but it is very heavily tested on the board. So that is going to be the main area which I'm going to focus on as we talk about acid-base disorders. So again, a little PTSD again. Henderson-Hasselbalch formula is the mantra for acid-base. So what I'm going to do is, so this is what it means. It's nothing but ABCD. So if you forget about A is pH, and of course, B is bicarbonate, CD is carbon dioxide. So what it tells you is if you forget everything about acid base, it tells you that A, which is a pH, is inversely proportional to CO2. That means if the CO2 goes up, what is going to happen to the pH? It is going to go down. That means CO2 is an acid, right? All this is helpful for is to know that CO2 is an acid. Because if the CO2, if the carbon dioxide goes up, pH is going to go down. So if the CO2 is going up and pH is going down, this is respiratory acidosis, right? Whereas bicarbonate is directly proportional to the pH. If the bicarb goes down, the pH goes down. That is metabolic. So if the primary insult is in the bicarb, we call it metabolic disorders. If the primary change which is driving the pH is CO2, that is respiratory. But A, B, C, D will, reorient you that CO2 and pH are inversely proportional, whereas bicarb and pH are directly proportional. So there's only four ways things can change, right? So if the bicarb is going up, pH is going up, that is metabolic because it's the primary disturbance was in bicarb, metabolic alkalosis, metabolic acidosis, and of course, pH and CO2 are inversely proportional. So if you forget everything, just go back to ABCD, and that will help you figure out what the primary disorder is, right? Now, why show this slide? Just trying to tell you is bicarb and PCO2 travel together. Look at that. In metabolic acidosis, the pH is low because the bicarb is low, right? But what happens to the PCO2? PCO2 is also going low. So all I'm trying to show is whatever the primary process, the compensation happens in the same direction. So PCO2 and bicarb travel together. So if you have a situation where bicarb is low and PCO2 is high, you already know that there are two disorders going on, right? Because ideally, if it was one simple disorder, both of them should be traveling in the same direction, right? So simple clues, again, to rule something out. Again, you can look at the module. I'm just going to give you the key points. Now, for exam, no matter what, you should check an anion gap. Okay, I'm going to give you an approach, a quick approach, and then we'll go to renal tubular acidosis. No matter if you should be checking an anion gap, and if your anion gap is more than 18 or 20, I don't care what the pH is, I don't care about anything. If the anion gap is more than 18 or 20, you have anion gap metabolic acidosis. If the anion gap is more than 18, I don't care what the pH, like you have anion gap metabolic acidosis. Now, let's look at what your starting point is. Anytime you're looking at the ABG, the first thing what you need to figure out is what? What is the primary acid-base disorder? What is the major driving thing? How do you figure that out? Just by ABCD, right? Looking at the pH and seeing whether it is, if the pH is low, whether it is metabolic acidosis or whether it's respiratory acidosis. How are you going to figure out? Let's say the pH is 7.3. I know that the patient has acidemia, but now I have to figure out whether it's metabolic acidosis or respiratory acidosis. I'm going to look at the CO2. If the CO2 is high, I know that this is respiratory acidosis. So there's only four choices, right? By looking at the first equation which I showed you, A, B, C, D, you should be able to figure out what is the primary disorder. Only 4 choices. Yes? Then you got to look at compensation. I told you bicarbonate and PCO2. That means carbon dioxide and bicarbonate travel together. So I'm not going to go into detail, but these are the formulas which you can use. So if you have metabolic acidosis, that means your bicarb is low, right? Let's say bicarb is 10. I want to see what the PCO2 should be. So if the bicarb is low, what should the PCO2 be? It should be low as well. We use the Winter's formula to predict what the PCO2 should be, right? I can't go into detail because of the time, but this is, you will have a separate module. This is the formula to see if the bicarb is low in metabolic alkalosis, what should your PCO2 be? In respiratory acidosis, what happens in respiratory acidosis? What is the pH going to be? pH is going to be low. What is your PCO2 going to be? High. Okay, so let's say your pH is 7.3, which is low, and PCO2 is 60. Normal PCO2 is 40, but now it's 60. Now, how would I know what your bicarb should be? So the PCO2 is high. What should happen to the bicarb? Bicarb should also go up. Now, what are these two numbers? So I'm going to just give you a rhyme. Up 1, 3, down 2, 4. Right? Makes no sense at all. Up 1, 3, down 2, 4. So up 1, 3, down 2, 4. So what these numbers are telling you is, if you have acute respiratory acidosis, that means you were sitting right in front of me, you were telling me you were in pain, and I gave you 10 milligrams of Dilaudid. What's going to happen? You're going to stop breathing. It happened acutely. So your PCO2 is going to, since you're not breathing, your PCO2 is going to go up by, let's say 20. Your PCO2 went up by 60. What should happen to your bicarb? It should go up. But it is acutely how, kidneys are, this is the only time I'll admit that kidneys are slow. In acute setting, kidneys can't actually quickly raise your CO2. So in acute respiratory acidosis, your bicarb is only going to go up by 1. So that means if your PCO2 has gone from 40 to 60, your bicarb will go within the next 24 hours up to 2. Awesome. So from 24, it will go up to 26. Whereas if it was chronic respiratory acidosis, that means you had COPD and you lived on a PCO2 of 60. Now kidneys have more time to compensate. So they will increase their bicarb by 3 for every 10 mm increase in PCO2. Does it make sense? That means if your PCO2 is 60, what should my bicarb increase by? 6. So normal bicarb is 24, it should be 30. So why is it up 1, 3? Because PCO2 is going up, my bicarb is also going to go up. So 1 is for acute, 3 is for chronic. Whereas in respiratory alkalosis, let's say if I told you today that you have to take your ABIM board exams in the next 3 hours, you're going to go into a panic attack, right? So if you go into a panic attack, right now your PCO2 is 40, is going to go down to 30. So if your PCO2 goes down from 40 to 30 because you're hyperventilating, what should your bicarb go down to? Because it just happened right in front of me. Your bicarb is going to go down by from 24 down to 22. What if somebody is pregnant? They are in chronic respiratory alkalosis. They run at a PCO2 of 30 because progesterone is stimulating your respiratory medullary center. Your normal PCO2 is 30 when you're pregnant. in your second semester. Pregnancy is not an acute condition, right? You're in second semester. So it's chronically your PCO2 is 30. So now the kidneys have more time. What is going to happen? Their bicarb is going to go down from 24 to 20. So when you see your patients who are pregnant and their bicarb is 20, don't assume that it is metabolic acidosis. It is most likely a compensation from respiratory alkalosis. Does it make sense? Okay. Now, if you have metabolic, we already checked an anion gap earlier, but here, especially if you found out that the patient has metabolic acidosis, you got to look again at the anion gap. And there's only two choices. Either you have a normal anion gap or you have a high anion gap, right? There's no other choice. You check an anion gap, either it is elevated or is it normal. If the anion gap is elevated, there are two steps you have to do in addition to checking the anion gap. One is to check an osmolar gap. And the other one, you have to figure out, is there any other hidden metabolic disorder along with anion gap metabolic acidosis? And that step is, there are two ways to calculate it. Bicarbonate prior or delta-delta. I think the delta-delta approach is given in the acid-base module, which is provided by the MET study. And this will kind of find you a hidden metabolic alkalosis or a hidden non-anion gap metabolic acidosis along with an anion gap. So these two steps, determining the osmolar gap and doing the delta-delta, should only be done if you have anion gap metabolic acidosis. These two steps have no role if you don't have anion gap. On the other hand, if you have acidosis and if you have normal anion gap, you check a urine anion gap. And this is what I'm going to focus on. If you check a urine anion gap, for now, just remember it. If the urine anion gap is positive, they are taking you towards distal renal tubular acidosis. And if it's negative, it's either diarrhea or other types of renal tubular acidosis. But if it is positive, they're taking you towards distal RTA. Just, for now, just memorize it, and I'll explain it. Yes? Okay. Now for the boards. Metabolic acidosis is what they like quite a bit, right? For any time you have metabolic acidosis, what are you going to check? Anion gap. If the anion gap is high, it has a differential diagnosis, which we'll talk about. If it is normal anion gap, metabolic acidosis, what boards are trying to test you on is whether you can differentiate diarrhea from renal tubular acidosis. Like, of course, take a history, but no, they're not going to give you like, oh, maybe the patient is taking laxatives or whatever. And then we'll also talk about metabolic alkalosis. So high anion gap. How many of you remember this from your med school? Mud piles. My problem with, and then there was an article in Annals or JAMA. They were like, oh, mud piles is old. We need to come up with a mnemonic for the 21st century gold mark. Of course, that's great. But my problem with mnemonics, if I have nothing against you if you like mnemonics. That's why I put in the mnemonics here. But my problem with mnemonics is you remember what the mnemonic, but you don't know what it stands for. I'm like, okay, what is O for? So I'm not a big mnemonic fan, but here are the mnemonics if you love mnemonics. But if you don't like mnemonics, this is what I like. All you have to remember is 4 things. Very clinically appropriate, right? If you have high anion gap, I'm like, what could be going on? One is ketoacidosis. What are you going to check for ketoacidosis? Which beta hydroxybutyrate. And then you got to stretch your mind. Of course, what can cause ketoacidosis? It's either diabetes, alcohol, or starvation. That is all history. But only one test, beta hydroxybutyrate. And these 3 mnemonic things are gone. Diabetes, alcohol, starvation. Now, the second one is, I'm going to check if there's increased anion gap, I'm going to check a lactic acid. Right? Of course, lactic acid could be type A, B, and D. Type A is the most common one, which we see in sepsis, where supply and demand issue. Type B is what you see with thymine deficiency, or if there's any problem with mitochondrial oxidation chain, like with metformin or certain drugs. So, but what are you going to check? You're going to check a lactic acid. The three is renal failure. To check a BUN and creatinine. As your kidney function worsens, you cannot get rid of, on a normal American diet, me and you are consuming about 1 milliequivalent per kg of acid every day. Where does the acid come from? It comes from meats. 1 milliequivalent per kg. So that means if you're 60 kilos, you're consuming 60 milliequivalent of acid every day. And your kidney is the organ which gets rid of this acid. If the kidney is not working properly, you will start accumulating sulfuric acid, phosphoric acid. That's why your phosphate goes up. So just check a kidney function. And the fourth one is toxins. Now you have to, I'm like, oh my God, toxins. Now you have to stretch your mind a little bit to what toxins can cause high anion gap. Of course, the board loves methanol and ethylene glycol, right? Methanol will cause high anion gap, but it will also, they'll also give you, they won't ask you to calculate an osmolar gap. They'll give you an elevated osmolar gap. Elevated osmolar gap is more than 10. So if you have high anion gap, high osmolar gap, and there's some eye findings that the patient is not seeing blurry vision, it is methanol poisoning, right? Moonshine. Whereas if you have high anion gap, you have a high osmolar gap, and they're giving you crystals in the urine, oxalate crystals in the urine. It is ethylene glycol, antifreeze, right? I have a patient who comes in every Christmas with drinks antifreeze, so very well known to our service. Suicide attempt, but not, is on dialysis now. Salicylates, the clue is going to be what? The clue is going to be a combination of high anion gap and respiratory alkalosis. So, combination of two disorders: high anion gap metabolic acidosis and respiratory alkalosis, because salicylates increase or activate the medullary respiratory center. And propylene glycol is a solvent. Yeah, where do you have you? What do you guys know about propylene glycol? How would you get propylene glycol? So propylene glycol is a solvent in a lot of medications which we use: Ativan, etomidate, uh, Dilantin or phenytoin. All of these are mixed in propylene glycol. So if you're giving high doses of these medications in the ICU, it is mixed. All these medications are mixed in propylene glycol, and you're like, oh my God, I don't know why the anion gap is increasing. Is because along with these medications, the solvent is propylene glycol. That is what is causing the high anion gap. Okay, but that was not the point. For the first time, I've added something about acid-base. Earlier, I used to only talk about renal tubular acidosis because there's a separate module for ABG, so I would want you to go and take a look at that. But when should renal tubular acidosis should be suspected for the boards? So if you have normal anion gap metabolic acidosis, that means you checked an anion gap totally normal, and the patient has acidosis. Of course, how would you know that the patient has normal anion gap? Just sometimes the quick clue is just look at the chloride. Chloride will be high in normal anion gap acidosis. That's why the anion gap does not change. Bicarb goes low, chloride goes high, it balances out each other, the anion gap remains same. Right? So the clue, if you don't want to check an anion gap, the clue for normal anion gap is going to be hyperchloremia. The chloride is going to be high. But for board purposes, when they give you normal anion gap acidosis, I don't know why, but they want you to know distal renal tubular acidosis. So suspect renal tubular acidosis in a patient with normal anion gap when there's absence of GI losses. If there's no diarrhea and you have normal anion gap acidosis, the boards is trying to take you towards renal tubular acidosis. This is the place where I told you if I have normal anion gap acidosis, you should be checking a urine anion gap. Oh my God, like you were tired of normal anion gap, now you're checking. So this is how you check, I'm going to make it simple, hopefully. So this is how you check a urine anion gap. sodium plus potassium minus chloride. If they give a urine, if the, if you look at the question and they're giving you urine sodium, urine potassium, urine chloride, why would anyone give you that? Do they, if they give you these three, they want you to calculate a urine and iron gap, right? You got to understand their psyche too. Why else would somebody give you urine sodium, urine? Like, why are you checking this, right? So, if, okay, so this is how you calculate it. Now, I'm just going to give you an example. So, let's say somebody here drinks, like I decide I'm going to drink a lot of acid right now. I'm going to drink acid. What is going to happen with my kidneys? My kidneys are very smart. They will figure out that I'm eating a lot of acid. They would want to get rid of that acid. How do my kidneys get rid of the acid? They secrete that H plus of the acid in the distal part of my nephron. In the distal part of the tubule, all the acid which I'm eating is going to come out because my kidneys are working fine. H plus combines with ammonia in my kidney and it becomes NH4 plus. It becomes NH4 plus, but you don't have sparks in your kidney, right? So you can't have a positive charge. It has to combine with something negative. So what this NH4 plus combines with is chloride. So if I drink a lot of acid, what is going to happen? My NH4 plus is going to go up. Along with NH4 plus, since it has to combine with something, chloride is going to go up. If the chloride goes up, what does the anion gap become? Negative. So that means if the urine anion gap is negative, my kidneys are fine. My distal part of the nephron is totally fine. Does it make sense? That means my distal part of the nephron, where I get rid of the acid, is totally fine. It's doing what it's supposed to. A negative urine anion gap tells me that the distal nephron is functioning fine. Yes. But you need something to combine with ammonium. Does it make sense? Okay. Now, if it doesn't make on the other hand, if the distal part of the nephron is not functioning fine, which is distal RTA, right? It's distal, right? Distal part of the nephron, that is where my kidneys get rid of the acid. If that part is not functioning fine, can I get rid of H plus? No. If I cannot get rid of H plus, can I make NH4 plus? No. Chloride, since there's not enough NH4 plus, I don't need too much chloride to combine with it. My urine anion gap is going to be positive. So if you can't forget, just come up with some visual aid. If you just forget all the reasoning behind it, RTA is just, this is distal RTA is positive, diarrhea, I made it up, now you won't forget it. Okay. Does it make sense? Okay. Now, what does the board love? They love Sjogren syndrome, I already told you. And Sjogren syndrome is associated with distal RTA. So what they will give you is a patient who has distal RTA, right? We already talked, when we were talking about stones, what do you remember about stones? Distal RTA is associated with stones. What kind of stones? Calcium phosphate, right? Urine anion gap is going to be what in distal RTA? Positive, because you can't get rid of H plus, right? So the urine anion gap is going to be positive, and distal RTA is classically associated with Sjogren syndrome or SLE, but Sjogren syndrome more commonly. So what they'll give you is somebody who has keratoconjunctivitis, CCUS kind of symptoms, dry mouth, dry eyes, and now you do a lab. They have normal anion gap metabolic acidosis, urine anion gap is positive, and these patients are very hypokalemic. What about how would you differentiate distal RTA from proximal RTA? In the proximal RTA, the urine anion gap is going to be fine. It is going to be negative because distal part of the nephron is fine. in the problem with the proximal RTA is that you cannot reabsorb bicarbonate. This happens most commonly with multiple myeloma. So in both proximal RTA and distal RTA, both of them will have hypokalemia, but how will you differentiate between these two? Urine and ion gap. Type 4. Oh my God, dreaded type 4. How many of you remember type 4? Like, oh, you don't know anything. Oh, it's type 4. So type 4 is nothing but low renin, low aldosterone. Just remember, type 4 is absolutely nothing but what? Low renin and low aldosterone. If you have low aldosterone, what happens? So what does aldosterone do in your distal nephron? It reabsorbs sodium, right? So it's reabsorbing sodium from the urinary side to the blood side, right? Aldosterone, that's what aldosterone does. And since it's reabsorbing urinary sodium to the blood side, what happens to the charge on the urinary side? Urinary side becomes negative. And you don't have you seen sparks in your urine? No, you don't. So to balance that charge, what comes out is potassium and H+, right? So you reabsorb sodium back into the blood and you excrete potassium and H+ in the urine. Now let's say you don't have aldosterone. There's low aldosterone because of low renin. Low renin causes low aldosterone. Since you don't have aldosterone, can you get rid of H+ and K+? If you can't get rid of H+, what is going to happen? You will become acidotic. If you can't get rid of K+, what is going to happen? You'll become hyper. That is exactly what type 4 RTA is. What causes type 4 RTA? Diabetes, 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 diabetes. Type 4 RTA, for me to call somebody as having type 4 RTA, you have to be hyperkalemic. So how would you separate type 4 RTA from type 1 and type 2? Type 4 has hyperkalemia. Type 1 and type 2 have hypokalemia. What about urine and ion gap? Urine and ion gap is positive in distal. It is also positive in type 4. Why? Because you can't get rid of H+ in the distal nephron. But now your question will be, oh, now you're really confusing me, that you initially told me that the urine and ion gap was only positive in distal RTA. Well, type 4 RTA is kind of a distal RTA, but it is slightly different. Why? Because it is because of low aldosterone. How would you differentiate between distal and type 4? By potassium. I'm sorry, it is confusing. On ABG, so the question for the people who are listening online, like, is the ABG module totally different? It is totally different. So I'm just, my focus here is purely mostly on RTAs, renal tubular acidosis. So again, I've given you a little framework on ABGs, but it's just so that I can put you in the right thought train. So the module will also talk about how to calculate an ion gap and everything in detail. Type 4 is mostly associated with diabetes, HIV, and obstruction. HIV can be associated with it more than hepatitis. Yes. That is a really good question. So because what happens in proximal RTA is you're losing a. So the question for the audience is, what is the mechanism of hypokalemia in proximal RTA and distal RTA? Proximal RTA, the mechanism is you're losing bicarb, right? You're losing bicarb in the urine. So that bicarb needs to combine. Bicarb is negatively charged. It needs to combine with something. It combines with potassium. Okay, I'm going to move on in the interest of time. A 26-year-old woman is referred for further evaluation of hypokalemia and acidosis. She was in her usual state of excellent health until 4 months ago when she developed dry mouth and muscle weakness. She was found to have a serum potassium of 2.8 and a bicarbonate level of 15 during her lab check. She was treated with oral potassium and bicarbonate supplements. Then she stopped taking these medications 6 weeks later. She developed myalgias and collapsed due to profound weakness. She was found to have a serum bicarbonate level of 14 and a serum potassium of 2.0, really low. ABG shows a pH of 7.29, which is acidemic, PCO2 of 30, oxygen level is fine. Oh, urine potassium is 46. Urine sodium is 36. Urine chloride is 42. Urine osmolality is 580. And there's nothing else seen on the urine. And urine pH is 6.8. Which of the following is the correct diagnosis? Is it type 4 RTA? Is it diarrhea? Is it type 1 RTA or distal RTA? Is it renal tubular alkalosis or is it proximal RTA? That's not a choice. So a lot of you answered distal RTA. This is, I've been telling you again and again, the board loves Sjogren syndrome. So I told you this patient had dry mouth and dry eyes. This sometimes the initial presentation of Sjogren syndrome is distal RTA. So if I go back quickly, if you look, the patient probably, I should have given you an anion gap, but I'm assuming that this anion gap, just based on the history, the anion gap would have been normal. And if the anion gap is normal, why would they give you urine potassium, urine chloride, and urine sodium? To calculate the urine anion gap. So if you calculated the urine anion gap, what is the urine anion gap? 46 plus 36 minus urine chloride. It is positive. The only place where your urine anion gap is going to be positive is where? Distal RTA or type 4 RTA. But type 4 RTA should have high potassium, not low potassium. There's no other answer which would be fitting. Does it make sense, or am I? You'll have to review this material again. But it's just very, very logical. It was normal anion gap metabolic acidosis. And urine anion gap was positive. Only two things caused urine anion gap to be positive. There's some problem in the distal nephron. Either it's distal RTA or it is type 4 RTA. But how would you differentiate distal RTA from type 4? Potassium. This patient was actually on the ground because of low potassium levels. Was weak because of hypokalemia. And this patient probably had, if you check their Rho and La antibodies, it would be positive. This patient has Sjogren syndrome. Board loves Sjogren syndrome. I don't know how many times I can tell you that, but that's true. Okay. Just a little word about metabolic alkalosis. So what is metabolic alkalosis? Your pH is going to be high, and your bicarbonate is going to be high. Let's say your pH is 7.5, and your bicarbonate is 30. The patient has metabolic alkalosis. So in metabolic alkalosis, the best test to order is urine chloride. Why? So the metabolic alkalosis can happen from either volume depletion or from primary hyperaldo. Why is that? In volume depletion, what gets activated? Which system gets activated? Renin, angiotensin, aldosterone. What does aldosterone do? Aldosterone is going to reabsorb sodium, and what is it going to get rid of? Potassium and H+. So you will become a little hypokalemic, and you'll also be losing H. If you're losing H+, you become alkalotic. So volume depletion causes metabolic alkalosis, and you can also have a aldosterone secreting tumor. because aldosterone secreting tumor is also going to do that, right? Aldosterone secreting tumor is going to reabsorb sodium. And since you are reabsorbing sodium, what happens to the charge on the urinary side? Becomes negative. You can't have negative charges. What gets out? Potassium and H plus. So you will. That's why these patients are also hypokalemic and alkalotic. So these patients are going to be slightly hypokalemic and alkalotic. These patients are going to be hypokalemic and alkalotic. But how would you differentiate between these two? One is volume depleted, and these patients are not volume depleted, they're volume high. Why would you, if and initially when I started the talk with acute kidney injury, I told you that when you are pre-renal or volume depleted, the best test to use is, fractional excretion of urea or urine sodium or fractional excretion of sodium. But why don't I want to use urine sodium here? Why am I using urine chloride? Because this is what I know, if you understand it, it's very simple. Why you would want to use urine chloride here is because if your bicarb is high, right, in metabolic alkalosis, your bicarb is going to be 30, 32, 35, 36. My body does not like a high bicarb. It's going to try and get rid of this bicarb in my urine, trying to normalize the bicarb. And bicarb is negatively charged. It can't go alone. It goes along with sodium. So I might have an elevated urine sodium level not because it's just because it is combining with bicarb. So urine sodium is not very helpful in metabolic alkalosis. What would you use? Urine chloride. So if the urine chloride is low, I know that these patients are volume depleted. If the urine chloride is high, I know that this patient is not volume depleted. Most likely will have a primary hyperaldo. I'll be coming back to this concept again. It'll become more clear, I promise. Okay, I do want to move on. Clues to acid-base disorders. If you have a normal ABG and increased anion gap, think about mixed metabolic acidosis and alkalosis. If you have low anion gap, I had already mentioned it, you should be thinking about paraproteinemia. If your osmolar gap is more than 10, think about methanol and ethylene glycol. With methanol, you'll have I changes. With ethylene glycol, you'll have crystals in the urine and AKI. Isopropyl alcohol. Does anyone know what is isopropyl alcohol? That's your rubbing alcohol. It does not cause anion gap metabolic acidosis. Does not. It causes osmolar gap without acidosis. So if they give you that the patient has an osmolar gap and is confused, but then you don't find any high anion gap acidosis, they're talking about isopropyl alcohol ingestion. Okay. Hypertension. Very, very, very high yield. Okay. Not funny. Yeah. Classification of BP. So JNC7 was published in 2003, but JNC8 came out in 2014. How many of you remember that time? It was chaotic. It was chaotic. Some people call it JNC late. That it took them 14 years and there were no major recommendations which came out of it. One of the most controversial recommendations. A lot of AHA, a lot of people didn't even believe anything which was published. But having said that, we'll still, ACP still wants you to know about that. So what they did was they did not change the definition of blood pressure in JNC8. 140/90 was your limit, right? Anyone more than 140 systolic or more than 90 diastolic was called as hypertensive. What they said was, which still holds true, that beta blockers should be a second-line agent, right? Beta blockers became second-line agents for hypertension. And then they were like, you know what? Your goals of treatment should depend on your age. Oh my God, that was the most controversial part. They're like, everyone should have a blood pressure of less than 140/90. But if you're more than 60 years of age and you don't have diabetes or kidney disease, it's okay to have a blood pressure goal of 150/90. It was based on 2 Japanese studies. The data was really poor, and I don't know how it made it to the recommendations here too. Very, very, very controversial. Um, and I'm going to build the slide. So, of course, lifestyle interventions for all were encouraged. But then this is another controversial part, which is still controversial, but you still need to know it. Then I'm like, oh, if somebody is in front of you and you are choosing therapy for them, they wanted you to ask 2 questions. The first question was CKD. So if you are in front of me in my clinic, I'm like, oh, do you have CKD? Do you have chronic kidney disease? If you have chronic kidney disease, they were like, does not matter what the race is, what the age is, does not matter. You need to be started on either ACE inhibitors or ARBs. But if then the second part was, if you did not have CKD, if you did not have chronic kidney disease, they're like, oh, you should look at the race, which we've already, the controversial part is this is not a biological construct. It's a social construct. They're like, they're like, okay, look at the race. And if you're Black, you should preferably be started on thiazides or calcium channel blockers, which I don't fully agree with. I think, it the evidence is not very good, okay, but I'll keep my views separately. Patients who are not Black, they're like, oh, they can, of course, beta blockers had become second-line drugs. They're like, oh, you can use either ACE, you can use calcium channel blockers or thiazide. Why ACE or ARB was not included in patients who were identifying as Black was based on one study, which was not, it's controversial, right? Now, then came ACC/AHA guidelines in 2017. They were very heavily influenced by one study called SPRINT. What I'm going to tell you is just this. All you need to remember is 130/80 became the new 140/90. So 140/90 it was gone, and everything was decreased by 10. Right? So the new 140/90 was what? 130/80. Primarily based on SPRINT, one study. Right? You look at the targets. Everyone is 130/80. They have, again, if you are a low-risk person with very low cardiovascular risk, that was the only group which they were like, oh, 140/90 would be fine. But for me, everything is now 130/80 in clinical practice. Now, ACC/AHA guidelines also came up with compelling indications. So this is something new too. So they said, well, we agree with everything what was published previously, but if you have stable ischemic heart disease, beta blockers should be first-line agents in those patients along with ACE and ARB. So beta blockers were totally thrown away by the previous group, but now beta blockers made a resurgence, especially in stable ischemic heart disease. Chronic kidney disease, the recommendation remains the same. First line is ACE or ARB. They're pretty similar. Yes? Now, controversial part. JNC 8 said 150/90 was appropriate if you were elderly. I'm like, oh my God, more than 60? I'm going to be in that category pretty soon. But there was no evidence about that. SPRINT showed us that adults who were more than 65 still benefited, even up to age of 80, still benefited with a goal of systolic blood pressure less than 130. So now the recommendation is, as long as you can tolerate it and you're not actually institutionalized and you're not having falls, 130/80 should be the same target for anyone, at least the evidence is for anyone between 60 and 80, right? 130/80. Okay. Some other caveats. Chlorthalidone was recommended over HCTZ. I don't know why in US we use HCTZ very commonly because that's how our attendings practiced and everyone still uses it, but it is less potent than HCTZ. Majority of the trials have used chlorthalidone, and The only side effect, which is you gotta worry about, is slightly higher incidence of hypokalemia with chlorthalidone, but more effective than HCTZ. Loop diuretics, if you have GFR less than 30, or if you have heart failure, of course, you might have to switch them to long-acting loop diuretics like bumetanide or torsemide. Please do not use, they will check you on that. There's no indication for ACE and ARB together. Do not use these drugs together. There's been a study which showed that the risk of death, hyperkalemia, acute kidney injury is higher with this combination. We, as nephrologists, used to use ACE and ARB together prior to 2009. It was based on a study published in Lancet. It was a made up study. It has been retracted. It was totally, the whole data was made up. Uh, so there's no indication for combining ACE and ARBs. Secondary hypertension, uh, when do you have to worry about secondary hypertension? If somebody's blood pressure was very well controlled, suddenly becomes uncontrolled, somebody has malignant or hypertensive emergency, you got to think about secondary hypertension. If you have bruise on your exam, you got to have to worry about. But what the board loves to test you on is, oh my God, a combination that you are hypertensive and then you have two abnormal findings on your lab results. There's slight hypokalemia. It doesn't have to be florid hypokalemia. It could be a potassium of 3.5 or 3.6, low normal, and slight metabolic alkalosis. That means your bicarb is 30, 32, 28, 29. So you have hypertension along with the combination of hypokalemia and metabolic alkalosis. What should you be thinking about? All it tells me is either you have aldosterone floating around or something which acts exactly like aldosterone. Either it's aldosterone or something which acts exactly like aldosterone. Because how do you know that aldosterone is floating around? Because what does aldosterone do? Aldosterone is going to reabsorb the sodium. What is going to happen to your blood volume? Sodium is going to go up, blood volume is going to go up, you'll become hypertensive. And since you're reabsorbing sodium, you cannot have negative charges in the urine, right? What comes out? Potassium and H+. So potassium comes out, so you become hyperkalemic. H+ comes out in the urine, you become alkalotic, right? So either there's aldosterone or something like aldosterone. Now, what are the secondary causes of hypertension? You just have to remember two organs, kidney and the adrenal gland. That's it, right? If you remember kidney, the two big things in the kidney are either you have chronic kidney disease, which is the most common cause of secondary hypertension, because when you have kidney disease, you can't get rid of salt and water normally. Or you might have renal artery stenosis. Renal artery stenosis in a patient who has other vascular disorders like diabetes, hypertension, coronary artery disease, most likely is atherosclerosis. Whereas if somebody comes in with symptoms of renal artery stenosis and you are a 20-year-old female, what do you think about? Fibromuscular dysplasia, right? So totally different epidemiological things. So two things in the kidney and three biggies in your adrenal gland. Rest of them makes like they're not diagnostic mysteries. What is in the adrenal gland? Primary hyperaldo, Cushing's, and pheochromocytoma, right? Thyroid, parathyroid, they're not diagnostic mysteries. We've already, coarctation of aorta, that's the main thing. The first time you're seeing a patient in your clinic for hypertension, don't assume somebody else has checked the blood pressures on all the four limbs. You don't have to check all the four limbs every time, right? Just one time. I've diagnosed coarctation of aorta at the age of 42 because nobody had checked it prior to that, right? So it is a missed disorder. And then, of course, you have to talk about over-the-counter medications like oral contraceptives, NSAIDs, pseudoephedrine, herbals, and sleep apnea as a trigger. So I do talk about over-the-counter medications, sleep apnea in every patient, every visit, but otherwise you only have to remember two things, kidney and the adrenal gland. Now, this is what the board loves. I told you, what does the board loves? high blood pressure associated with hypokalemia and alkalosis. Hypokalemia. Your potassium is low. If your potassium is low and your kidneys are smart, what should your kidney be doing? If I'm not eating enough potassium in my meals, it's very hard to do. Like, it's very hard to not eat enough potassium. But if I was not eating potassium in my meals, what would my kidney try and do? They'll try and reabsorb all the potassium possible. So if it's not a problem with the kidney, your total urine potassium is going to be very, very, very low. So this is what you see in low PO intake, especially if you're anorexia nervosa or if you're having diarrhea. Because your kidney is fine, is trying to hold off on to the potassium. But if I'm hypokalemic, like my potassium is low, and you check my urine potassium, that is high, that means there's some problem in the kidney. I'm losing potassium in the kidney. Why am I losing potassium in the kidney? Your next step should be check a blood pressure and the volume status. If the patient is hypertensive, most of the time they will also be alkalotic. Why? What is the mechanism? Because in hypertensive alkalotic patients, it's either aldosterone or something exactly like aldosterone, right? Why? Because if the aldosterone is high, it is reabsorbing sodium, your blood pressure is going to go up, urinary side becomes negative, you can't have negative charges in the urine, you can't have sparks, potassium and H plus gets dumped into the urine, so you will become hypokalemic because you're dumping potassium, you're dumping H plus, you will become alkalotic. So my clinical pull is anytime you see hypertension, hypokalemia, alkalosis, please check what? Aldosterone and plasma renin activity. Anytime. It is not checked in clinical practice, even in very clear findings. Plasma aldosterone and plasma renin activity is not checked. So board loves it. So you gotta check plasma aldosterone and plasma renin activity. So if the plasma aldosterone is high and the renin activity is low, what is your diagnosis? Hyperaldo. Why is the renin low? Because you have a tumor which is secreting aldosterone. It is reabsorbing aldosterone back into the bloodstream. You become hypertensive and volume overloaded, and high volume suppresses the renin. So the plasma aldo is high, renin is low. What if you have, this is my kidney, and I have a renal artery stenosis, right? This is my kidney. This is the blood vessel which is open, but now it's not open. There's stenosis in the vessel. What is my kidney going to think? My kidney is going to think that it's not getting enough blood supply, and it is a volume depleted state. And whenever my kidney thinks it's a volume depleted state, what is it going to do? Even though I'm not volume depleted, it's thinking I'm a volume depleted state. It'll go and rev up my renin, angiotensin, aldosterone system. Renin is going to go up, aldosterone is going to go up. So you'll have high aldo and high renin. Make sense? But what if you checked your renin and aldo, both of them are suppressed? Oh my God, now looks like there's increased aldosterone floating around, but when I check the aldo and renin, they are very low. That is where you got to think about there's something which is acting exactly like aldosterone, but I'm checking the aldosterone. Aldosterone is suppressed. What is it? It's cortisol. Cortisol has a higher affinity for the aldosterone receptors than aldosterone. But generally, most of us have an enzyme in our kidneys which converts cortisol to cortisone, so we don't see enough cortisol in the kidney. But if your cortisol levels are really, really, really high, my kidney cannot convert cortisol into cortisone, so cortisol is going to replace the aldosterone and start reabsorbing sodium. So if I'm reabsorbing sodium, I'll become hypertensive, and high sodium is going to do what to the renin and aldosterone? It's going to suppress it. Yes? Okay. If you have no idea what I'm talking about, if everything what I said in the last 10 minutes sounds like gibberish, what I want you to do is when somebody is hypertensive, hypokalemic, and alkalotic, please check a plasma aldosterone and plasma renin activity. Okay? Um, you got to do it, right? Because they love primary hyperaldo. You will also learn about this in endo. But this is, endo, I tell everyone, is very easy, right? Endocrinology practice is the easiest practice, right? If something is high, you want to suppress it. Something is low, you want to stimulate it, right? And here, I'm thinking that it is a aldosterone secreting tumor, right? I will start with the screening test. Screening test is plasma aldosterone to plasma renin activity of more than 20. That means plasma aldosterone is high, plasma renin activity is low. If the ratio is more than 20, the screening test is positive. So there, what should be the next test? Please do not rush directly to doing imaging of the adrenal glands, because this could be a false positive too, because it's a screening test. I need to confirm. And how do I confirm? You use what I just told you. Endo is easy, right? Something is high, you want to suppress it. How do I suppress renin, angiotensin, aldosterone system? By increasing the volume. So this is what I tell my patient. I'm like, this is the last time your nephrologist is going to tell you to go wild on high salt diet. Go and, have 3 burgers, right? And then I will check your urine aldosterone levels. What am I trying to do? If you increase your salt intake and volume, what should happen to your renin, angiotensin, aldosterone system? It should be suppressed. But can you suppress a tumor? No. So if in spite of high salt intake, I cannot suppress the aldo, that means there's a tumor. If you don't want to do that, sometimes I'll bring my patients in and I'll give them 1.5 liters of normal saline in the clinic, which is huge amount of salt. And then I'll check their plasma aldosterone and plasma renin. So if I can suppress their plasma aldosterone, they don't have a aldosterone secreting tumor. If I can't, I have confirmed my diagnosis, and that is where I will do CT imaging to see where the adenoma is. If you're less than 35 and I see a lesion, you can send them to surgery. But if you're more than 35 years, even if you see an adenoma, you need to confirm where the aldosterone is coming from, because it could be non-functional. So you gotta do adrenal vein sampling, and you gotta do it at a place which is very well known for doing it, because it's a, um, it's a very highly specialized test. Somebody has to be, you have to go into bilateral adrenal vein and collect the samples. So if your radiologists are not used to doing it, they'll mess it up. So you have to send it to centers which are very well known. Does it make sense? Okay. Hypertensive emergencies and urgencies. So what is severe hypertension? Severe hypertension is systolic blood pressure more than 180 and diastolic blood pressure more than 120, right? These are just numbers. 180 systolic, diastolic 120. So this is what we call a severe hypertension. But again, if you have severe hypertension and you start losing organ function, what is it called? Hypertensive emergency. So this needs to be managed in the ICU with IV drugs. On the other hand, if you have severe hypertension but no acute end organ dysfunction, this is what is called hypertensive urgency. This does not have to even be admitted. These patients can be managed as an outpatient. You don't need to start IV antibiotics. You don't want to start bringing their blood pressure too quickly. You have time. So what makes the difference is whether you have acute end organ dysfunction or no. Now, what are the signs and symptoms of end organ dysfunction? This is just basic. I don't even need to tell you much. Cardiac would be, elevated troponins, ischemic changes, chest pain. Pulmonary would be pulmonary edema. Neurologic would be if you're having TIA and strokes. Kidney injury is an end organ dysfunction. And of course, looking in the eye, if there's retinal hemorrhages and papilledema, this is what we used to call malignant hypertension, right? If you use the word, we don't use that word often. It's part of end organ dysfunction. And of course, if you're having aortic dissection, of course, this is like, what do you do? As I told you, if you have severe hypertension, look for target organ damage. If the answer of anything is yes, these patients need to be admitted to the ICU. And once you've admitted if they have either aortic dissection, severe preeclampsia, or pheochromocytoma crisis, these patients are the only ones where the blood pressure needs to be dropped very quickly within the first hour. If it's aortic dissection, I like to bring the blood pressure down within 1 hour to less than 120 because you don't want to expand the dissection. But if you don't have these three conditions and you have hypertensive emergency, you don't want to be too quick. You want to reduce their blood pressure by max of 25% over the first hour, and then slide, over the next 6 hours, bring it down to 160 over 100, and then normalize it in for 24 to 48 hours. Don't be too quick, because in strokes, if you bring their blood pressure down too quickly, you're going to increase the penumbra and increase the stroke region. Yes? Got to remember that. Okay, if there's no target organ damage, is hypertensive urgency. Don't admit these patients. You don't have to send them to the ER, reinstitute, intensify oral therapy, and arrange follow up in 2 to 3 days. Like, don't panic. They don't need to go to the ER. You can manage them by restarting, reinitiating therapy. This you can read. I'm not going to spend too much time. I've put down some of the drugs for hypertensive emergencies which we use. What are the first line drugs? These are based on the latest recommendations. In pulmonary edema, avoid beta blockers. Nitroprusside is safe generally for everything other than, you want to try it, and since it can increase intracranial pressure, there is some evidence that you might want to avoid it in acute ischemic strokes. All IV medications, right? Mostly all of this is going to be managed in the ICU. 22-year-old woman referred from GYN for BP evaluation. Previous blood pressure was 149 over 92 and 154 over 95. Review of systems was negative. No family history of hypertension. This is the blood pressure right now. These are the labs. 142 sodium, potassium is 2.9, chloride is 104, bicarb is 32, BUN is 10, creatinine is 0.6, CBC is normal. High blood pressure. Which of the following is the most appropriate next step in her management? Okay, I don't even, 100% of you said ratio of plasma aldosterone concentration to plasma renin activity. That is the first step. Based on the last question, which of the following is the most likely diagnosis? So you did that, what you told me just now. PRA came back very high and aldosterone came back very high. Both of them came really high. What is the most likely diagnosis? Is it renal artery stenosis, FMD, primary aldo, bilateral adrenal hyperplasia, or Cushing's? So let's see the response. Oh, this is kind of split, right? So there's some people are saying renal artery stenosis. Well, yes, it is kind of a renal artery stenosis, but renal artery stenosis, whenever we mention it, we kind of think about atherosclerotic, right? This is not a 60-year-old with CAD, peripheral vascular disease. Does not make sense. And then there were a lot of you who said primary aldo. In primary aldo, are both aldosterone and renin going to be elevated? Aldo is going to be high and renin is going to be suppressed in primary aldo, right? In primary aldosteronism, aldo is going to be high, but renin is going to be very low. Okay, go back to that concept again. Yes, I'm going to hold it off. Okay, let it sink in. Some electrolyte disorders. This is very quickly. They love hyponatremia. You probably hate it. What is hyponatremia? Serum sodium concentration less than 135. Hypernatremia is more than 145. These are concentrations, right? Look at this bracket. This is concentration. So Hyponatremia and hypernatremia represent water problems. They're not sodium problems, they're water problems, right? High amount of water is going to suppress the sodium concentration or cause hyponatremia. Low water content is going to cause hypernatremia. And look at what your plasma osmolality is dependent on. Your plasma osmolality is dependent on what? Sodium concentration, and a little bit on glucose and a little bit on BUN. But the major driver of plasma osmolality is what? Sodium. Okay, that is a concept. Now, if you start drinking a lot of water, let's say you went somewhere and somebody told you, you know what, you got to cleanse your toxins in your body and you got to drink a lot of water, right? You got to drink 10 liters of water every day. What is going to happen? You start drinking a lot of water, your plasma osmolality is going to fall, right? You're going to dilute, and your serum sodium is going to fall too. As soon as your plasma osmolality, which is dependent on sodium concentration, goes below 280, what happens? Your ADH should shut off. There should be no ADH, because what is your kidney going to try and do? It's going to try and get rid of that extra water. I'm like, it does not need that water. You're drinking too much water. It needs to get rid of it. How does it get rid of it? By decreasing the ADH. And you pee out. When you look at your urine, it'll look like water, but it cannot be pure water. It can't be mineral water. It still has to have solutes in it. What is the least amount of solute you can have? 50 milliosmoles, right? So you'll be peeing out a urine which is very dilute, but it will still have 50 milliosmoles. You'll get rid of that water and you'll go back to your normal osmolality. Make sense? Now, let's say I take you to a desert and I'm like, you know what? I want to torture you. I'm going to check your serum sodium, 138. I'm not going to let you drink water. What's going to happen? You're going to be sweating. You're going to be losing water. Your serum sodium is going to, after about 6 hours, because of sweating, is going to go up to 144, 145. And your plasma osmolality is going to go more than 290. What is going to happen at this point of time? You will be fighting with me for what? You will be so thirsty. It's one of the worst feeling ever. We don't actually ever experience that feeling because we are social drinkers. You're not even thirsty and you're chugging water, right? We don't ever have that feeling because we are social drinkers. But it is one of the worst feelings ever is to feel thirst. Right? So you will be you will be looking for water, but I'm not going to let you have water because there's no water around. What's going to happen? Your kidney is again very smart. It wants to hold on to whatever water I have. It will increase the ADH level like crazy, and I am going to pee out a very concentrated urine. And what is the most concentrated urine you and I can make? 1200. As you age, I'm sorry to inform you, your concentrating ability goes down. So from 1200, it'll go down to about 600, 700. That's why most of you, once you go into 70s and 80s, have to get up at night to pee because you can't concentrate the urine. It's just not all BPH, right? I'm like, oh, you've got BPH. No. Everyone has to get up because you can't concentrate your urine to 1200, right? And you will normalize. Does it make sense? Now, what causes ADH release? I started my talk with ADH release, right? Whenever you're volume depleted, right? You're having diarrhea, nausea, vomiting, blood loss. Anytime you're volume depleted, what gets activated? Sympathetic system, renin, angiotensin, and what else? ADH. So anytime you have decreased volume, you have ADH release. And I also gave you another example when I took you to the desert and your plasma osmolality went up to 290, 295, or your serum sodium concentration went up to 145, you should be holding on to all the water. So these are two main physiological reasons for my ADH to go up. Low volume, or if my plasma osmolality is high. And of course, there's some nausea and pain can also increase your ADH. That's why patients who are post-surgical, who are having nausea and pain, you don't want to give them a lot of free water because what is going to happen if you give them a lot of free water? Their ADH is activated, they can't get rid of that water, and they'll become hyponatremic. This is why. What happens when you, how many of you have ran marathons? Is anyone a big marathon? So when you're running, what happens? You're sweating a little bit, you become a little volume depleted. And when you're volume depleted, what gets activated? ADH. Now you're running and people are giving you water without electrolytes. They're thinking that they're doing a good thing, but your ADH is really, really, really high. And all the water which you're being given, you can't excrete it because the ADH is running so high, and you have a seizure after about 2 hours. Right? That's why even the paramedics who are around the marathons, they have hypertonic saline in their kit. And they don't even need to talk to a doc. If you're having seizing, if you're seizing during a marathon, they'll give you hypertonic saline immediately. Right? And that's why you want to avoid free water when you can't excrete it. Now, how does hyponatremia develop? Hyponatremia will develop, it's a water problem, right? Either I'm drinking like crazy, but it's very hard to do. I can, you and I can actually drink about 12 liters of water, 14 liters of water in a day, and still get rid of it by diluting our urine. But more than 14 liters, you'll start becoming hyponatremic. That is what is psychogenic polydipsia. People, maybe obsessive compulsive water drinking. I'll change my terms. Some people have, psychogenic might actually, create. Anyways, or either I'm drinking too much water, or there's a problem with my kidney that I cannot excrete water. How can I not excrete water? ADH. There's ADH floating around. How would I know that I have ADH floating around? How would you know that there's ADH in my bloodstream? I don't check a ADH level. What tells you about what the ADH level is? Urine osmolality. If there's no ADH, what should your urine osmolality be? 50 to 100, I told you. Very dilute. But if your urine osmolality is 250, 300, 400, 500, 600, that means there's ADH floating around. Okay, I'm going to quickly move on to, these are the three things which you need to, I'm going to give you a very clear approach. Anytime you have low serum sodium, right, hyponatremia, there are three things you need to check. The first thing which you need to check is a plasma osmolality. Second thing you need to check is volume. And the third thing you need to check is urine osmolality and urine sodium. And I'll tell you why. How do you check the volume? It's a clinical diagnosis, right? Hypervolemic, euvolemic. You need to check a plasma osmolality, and you need to check urine osmolality and urine sodium. Now let's follow why. So I have a serum sodium of 120, right? I have hyponatremia. What is the first thing I'm going to check? Plasma osmolality. I don't care about these two. If the plasma osmolality comes back normal, totally normal plasma osmolality, that means it is a lab issue. It is not real hyponatremia, pseudo hyponatremia. It's either because there's a multiple myeloma or there's hypertriglyceridemia. It's kind of a lab error. If the plasma osmolality is high, I just have to go to the patient's bedside and see, is there mannitol hanging around? But more commonly, is this patient hyperglycemic? It's not a diagnostic mystery. So most of, these are very straightforward. What I'm interested in is low plasma osmolality and low plasma osmolality. Then what am I going to do? I'm going to check their volume status. And there's only three choices, right? Either you're euvolemic, hypervolemic, or hypovolemic, right? If you're hypervolemic, you will have what? High JVD, crackles, edema. They will give you all that. And your diagnosis is what? All the OSIS: cirrhosis, nephrosis, cardiosis, heart failure, cirrhosis, nephrotic syndrome, kidney disease, right? That's hypervolemic. If you're hypovolemic, you need to be, you'll have no JVD. They'll give you orthostatic hypotension. But what they are mostly interested in is euvolemic. That's the major thing they're going to test you on. So in hypervolemia and hypovolemia, how do the patients become hyponatremic? In these cases, what is happening? Your it is what we call as effective arterial blood volume depletion. Your baroreceptors are sensing that it is a low volume state. That's why your ADH is high and you retain water. Of course, in true hypovolemia, of course, you're hypovolemic, your ADH is going to be high and you're going to be retaining water. But why in euvolemia should you have hyponatremia? The biggest cause is SIADH. So, what is SIDH? Syndrome of inappropriate. So, how would you know what is inappropriate if you don't even know what is appropriate? Right? Appropriate, we already talked about what was appropriate. If you're volume depleted, right? If you're volume depleted, it is appropriate. But that's why I'm saying that this patient has to be euvolemic, because if this patient was volume depleted, I cannot call it inappropriate. So I have to make sure that these two conditions are not there. No hypovolemia or no hypervolemia, because both of these are actually effective arterial blood volume depletion, right? So the patient has to be euvolemic. But let's say me and you start having an argument of like, oh, you know what? You are calling this patient hypovolemic. I'm calling this patient euvolemic. You're wrong. Right? How would you break that? How would we break that tie break? So that's why if you have to make sure that you check a urine sodium level. If the urine sodium comes back less than 20, you are right that the patient is hypovolemic. Because in SIDH, your renin, angiotensin, aldosterone system should not be activated. If the urine sodium is less than 20, the patient is hypovolemic. So in SIDH, your urine sodium has to be what? More than 20. If it is less than 20, I cannot call, there is RAS activation, whereas in SIDH, only ADH should be activated. There should be no RAS activation. So part of this is I should, clinically, the patient should look euvolemic, and just to confirm it so that there's some objective evidence, urine sodium should be more than. If it is less than 20, my exam was not right. I missed it, right? And of course, is ADH present should be, so there should be high ADH, but we do not check ADH levels. What do we check? Urine osmolality here. So urine osmolality will be 250, 300, 400, 500, which suggests that there's. And the third part is cortisol deficiency and thyroid disease look very similar to SIDH. Very, very similar. I can talk to you about why, but I don't have time. But that's why these two disorders should be ruled out before you call it. Yeah. What causes SIDH? A lot of psychotropic drugs like SSRIs, phenothiazides, but most commonly they'll give you SNRIs or SSRIs, anything in the brain, anything in the lungs, and malignancies like small cell cancer. Just remember, anything in the brain, anything in the lungs, and psychotropic drugs. All of them can call. The most common one, which they'll still give you, is SSRIs. What do you do? If somebody is having seizures or neurological complications, you just give them hypertonic saline. That's why you don't even need a physician. If somebody is having seizures in the marathon, you don't need my orders. They have 100 cc syringes and they'll give you hypertonic saline if somebody is seizing during a marathon. If you have mild symptoms, then what you want to do is increase your serum sodium by about 6 to 8 milliequivalents in 24 hours. What you can use is free water restriction. You can give them oral urea, sodium chloride. You can give them V2 receptor antagonists like tolvaptan. I've hardly used it. I've used it very, very, very rarely. And Demeclocycline can be used, but very uncommon. Most of these top three are very effective in maintaining normal serum sodium levels in most of the patients. Uh, Nothing new here. What about hypernatremia? This is the easiest diagnosis you will ever make. Easiest. Can you and I become hypernatremic? No. Why? Because as soon as your serum sodium goes close to 145, you are going to be running for water. You, as long as you have access to water, nobody can become hypernatremic. If I can go and find water, because thirst is amazing. Unless I have a stroke and my thirst receptors are gone in the hypothalamus, as soon as my serum sodium will come anywhere close to 145, I will become very thirsty and I will not become hypernatremic. So the only way you can become hypernatremic is very rarely if you have defect in thirst mechanism, very, very rare, or access to free water is restricted. That's why we see it more commonly in intubated patients, patients who can't reach, have a fracture and can't reach the water, or infants, right? People who can't access the water themselves. And once they get confused, they can't even ask for water. So how would you, let's say you are seeing a patient with hypernatremia, let's say serum sodium is 150. How would you know whether, and your question is, does this patient have diabetes insipidus? How would you know? Just one of the easiest tests, check urine osmolality. If the urine osmolality is high, that means access to water is the problem. Me and you are the problem. We are not giving this patient water. It's the patient does not have DI. The patient can't access the water because ADH is working full time. That's why the urine osmolality is high. So most of the time it's access to the water. If the urine osmolality is low, the answer is either central or nephrogenic DI. Central DI could be anything in the brain, tumor infiltration. It's very easy to diagnose. Let's say your urine osmolality is 100. What I will do is I will give them synthetic ADH or desmopressin. If I can increase their urine osmolality from 100 to 500, it is central, right? That means the patient, there's no ADH coming from the brain. Whereas if I give them synthetic ADH and I still can't increase their urine osmolality, then it is nephrogenic. What is the most common cause? Lithium, lithium, lithium. That's what they love to test. There are two electrolyte disorders which can also cause a nephrogenic DI. One is hypercalcemia and the other is hypokalemia. So hypercalcemia, that's why these patients present with polyuria because they can't concentrate their urine. Treatment is thiazide diuretics, which is kind of counterintuitive because you're like, oh, the patient is already, losing free water. Why are we giving thiazide diuretics? It causes volume depletion and increases the proximal water absorption. So the defect is in the distal tubule. So we are bypassing that and reabsorbing majority of the water in the proximal tubules by giving thiazide diuretics. A quick thing about polyuria. So what is polyuria? I get a lot of consults. Polyuria is more than 3 liters of urine every day. And the question is, oh my God, does this patient have diabetes insipidus? And the answer is very easy. Just follow this. Most of the patients, all you need to check is urine osmolality. If the urine osmolality is more than 300, the patient does not have nephrogenic DI. What is the problem? You are giving them normal saline. They're going to get rid of, if I give you 6 liters of normal saline, you're going to pee out 6 liters of normal saline. Right? Your kid, that it is solute diuresis. But if the urine osmolality is less than 250, then you got to actually look at your serum sodiums. If the serum sodiums are higher than 142, the patient could have diabetes. If the serum sodium is 137 or lower, the patient could be drinking a lot of water. Obsessive compulsive water drinking. Okay, I need to go fast because I'm running just a little behind. A 76-year-old male with a history of smoking, admitted with 3 weeks of falling and dizziness, lost 20 pounds in the past 6 months. Blood pressure is 120/80. It's a beautiful blood pressure. You did orthostatics, everything remained the same, so there's no volume depletion, at least on the exam. Sodium is 116, osmolality is 241, urine sodium is 25, urine osmolality is 673. You check the TSH level, it's normal, cortisol level is normal. Yes? Which of the following is the most likely diagnosis? All of you got it right. SIDH, right? So the patient was euvolemic. TSH and cortisol was normal. And look at the urine osmolality. That means ADH is floating around. And what about the urine sodium? Urine sodium was more than 20. If this urine sodium was less than 10, maybe I need to do my volume exam again. Yes? Okay, great. And in SIDH, which of the following would you expect? Now, this is just a recap. If you have a patient with SIDH, what would their urine osmolality be and what should their urine sodium be? Uh, 80 to 90% of you got it right. High urine osmolality because there's ADH floating around, right? There's inappropriate ADH. So high urine sodium because if the urine sodium is low, that means RAS is activated. And if RAS is activated, then the patient is not euvolemic. So the urine sodium has to be higher than 20. Okay. Just few things about hypokalemia. Nothing much other than just I have already talked about this when we were talking about hypertension and alkalosis. Just look at this flow chart, and I think you won't get anything wrong with hypokalemia. So if you're having renal potassium losses, we already talked about hypertension and alkalosis, but let's say you're normotensive, your blood pressures are normal, then you should check acid base. If you have acidosis and hypokalemia, you should be thinking about what? We already talked about type 1 and type 2 renal tubular acidosis. Whereas if you have alkalosis, then you should be thinking about diuretics and vomiting. Forget about Barter's and Gittelman's. They are exactly like Barter's is exactly like somebody is taking a loop diuretic, and Gittelman's is exactly like what you're taking a thiazide diuretic. But these are genetic disorders in the same areas where loop and thiazide diuretics act. Very rarely they might ask, so I did put it in. Hypokalemia, high risk of ventricular fibrillation when your potassium is 3.6. That's why all the CVICUs want to keep potassium more than 4.0. Hyperkalemia, all you need to know is you don't need to memorize hyperkalemia. As long as you know the renin, angiotensin, aldosterone system, that's all you need to know. You can know everything which causes hyperkalemia. Any disruption in the renin, angiotensin, aldosterone system is going to cause hyperkalemia. So what causes low renin levels? Diabetes. That's what causes type 4 RTA because there's autonomic dysfunction in the sympathetic fibers. Low renin, low angiotensin. Let's say renin secretion is fine, but what about angiotensin 1 to angiotensin 2 conversion? That is ACE inhibitors, right? Let's say that is fine. Angiotensin 2 works on the angiotensin receptors. What blocks that? ARBs, right? Let's say that is fine. ARBs act, or the angiotensin 2 works on the adrenal gland. What if the adrenal gland is gone? Adrenal Addison's disease. The gland is gone. There's no aldosterone. You'll have hyperkalemia. Let's say the adrenal gland is fine, but the aldosterone synthase enzyme, which makes the aldosterone, is inhibited. That is what happens when you use heparin and azoles. So ketoconazole, fluconazole, heparin, they block the enzyme aldosterone synthase, which makes aldosterone. So they can cause hyperkalemia. Let's say that is fine. What blocks the aldosterone receptors? Spironolactone or eplerenone. That will cause hyperkalemia. Let's say aldosterone receptor is fine too. What does aldosterone do? Aldosterone increases the sodium reabsorption, right? I've been talking about this for the last 3 hours now. It increases the sodium reabsorption, and that's how it gets rid of this potassium, by creating this negative charge. But what if this sodium channel is blocked? What blocks the sodium channel? Amiloride, trimetrine, these are the potassium sparing diuretics, but there are two drugs, two antibiotics, Bactrim, the trimethoprim, and pentamidine, which we used to use for PJP treatment in patients, right? If you know the whole system, you don't have to memorize anything. Treatment, peak T-Waves, Viden QRS, all I wanted to tell you is if somebody is having EKG changes with potassium levels of higher than 6.5, give them calcium gluconate to stabilize the membrane, acutely give them glucose and insulin to push the potassium inside the cell. You can also give them beta 2 agonists like albuterol to move the potassium inside the cell. And then, since you've bought some time by redistributing the potassium inside the cell, you can use certain agents. We used to use Kyaxalate, but now the recommendation is to avoid it as much as possible because it can cause ischemic colitis. So now the recommendation would be to either use Pteromer or zirconium cyclosilicate. These are the doses. And in certain cases, you can use diuretics. And if diuretics don't work, you might need renal replacement therapy. Calcium. What is the first test you're going to do for calcium? PTH, PTH, PTH. Anytime you have high calcium, the first test what should you do is PTH. And if the PTH is low, then your differential is either malignancy, either granulomatous disease like fungal diseases like histoblasto or sarcoid, or somebody is taking a lot of calcium and vitamin D. All of them will have low PTH. Right? Malignancy, I think about 3 malignancies based on mechanisms. Multiple myeloma causes it by increasing IL-6, but I don't check IL-6. So what will I check? SPEP, UPEP. Lymphomas cause hypercalcemia by converting 25-hydroxy into 125. So what am I going to check? 125-hydroxy levels are going to be elevated because lymphomas convert 25-hydroxy into 125. And solid cell tumors cause it by PTH-related peptide. So you will check PTH-related peptide, PTH-RP. Right? Granulomatous disease also causes hypercalcemia exactly by the same mechanism by increasing 125-hydroxy vitamin D. So 125-hydroxy vitamin D is going to be elevated here, and it will be elevated in lymphomas. If the PTH is high, all the board wants you to know is your differential diagnosis should be primary hyperpara versus FHH. FHH will, both of them will have high PTH, but how will you differentiate these two? In primary hyperpara, you'll have bone stones, bone groans, right? Whereas in FHH, you will have nothing. But you still have to differentiate. So primary hyperpara, you'll have high calcium and low phos, right? Because what is PTH? Phosphate trashing hormone. So calcium is high, phosphate is low. And of course, these patients have high urine calcium. That's why they have high risk of stones. Whereas in FHH, the problem is in the calcium sensing receptor. It is familial. And how would you differentiate it with primary hyperpara? These patients have low calcium in the urine. They do not form stones. So this highlighted part is really important. Low calcium in the urine in FHH, whereas high calcium in the urine in primary hyperpara. Yes? I know there's a lot. I'm sorry. Primary versus secondary hyperpara. Primary hyperpara, we already talked about. PTH is elevated, high calcium and low phosphorus, whereas in secondary hyperpara, calcium is going to be low normal rather than high. And what is driving everything is the phosphorus is going to be high. Most of this, you're going to see it with chronic kidney disease. So if you have chronic kidney disease and phosphorus is high, what is it? Secondary hyperpara. Treatment: saline, saline, saline for hypercalcemia, and after that you can use bisphosphonates, right? Saline is the first. Hydrate, hydrate, hydrate first, and then give them bisphosphonates. A 55-year-old female, past medical history, significant for squamous cell cancer 2 years ago, doing fine, exam is normal, calcium is 11.4, calcium previously was 9 to 10, phosphorus is 2.1, alk phos is 180, PTH is 108. PTH is 108 and calcium is 11.4. Which of the following is the most likely cause of hypercalcemia? Hypercalcemia or malignancy, vitamin D, primary hyperpara, osteoporosis, or FHH? Like malignancy associated hypercalcemia. So majority of you got it right, primary hyperpara. I'd given you squamous cell cancer to confuse you, because if it was squamous cell cancer associated hypercalcemia, what should your PTH be? Suppressed. It was not low. So it was not related to the malignancy. This patient had primary hyperpara. Hypomagnesemia, I don't want you to know much other than that they or can be associated with chronic use of PPI. Remember that. If you have, I don't know why the patient is hypomagnesemic, think about PPIs. PPIs can cause refractory to supplementation, low magnesiums. And the last 3-4 slides on CKD. What is CKD? Structural or functional kidney abnormality for 3 months. Everyone hopefully knows this. The GFR related criteria is still trying to bring in front of you. You got to know the classification of CKD. You got to know that the mortality in CKD is because of heart disease, not kidney disease. They die of heart disease. So you have to be very, very, very aggressive about all the heart failure and CAD management in these patients. Few important points. ACE and ARBs, we already know, right, are really great drugs for chronic kidney disease, especially if you're proteinuric. But now you got to know SGLT2 inhibitors. Oh my God, this is the biggest news story over the last 3 years. Anyone who has got chronic kidney disease should be on SGLT2 inhibitors, regardless of whether they have type 2 diabetes or no, because it slows the progression of chronic kidney disease. We have not seen these kind of results in the last 10 years, what we are seeing with SGLT2 inhibitors, right? ACE and ARBs, you already know. Acidosis should be treated in these patients. Your goal of treating the acidosis should be to maintain a bicarb level of more than 22. How do you treat it? Give them sodium bicarbonate. The question is, what if you don't give them sodium bicarbonate and let the bicarb run 18 or 19? Is there any harm in letting the bicarb run low in CKD patients? Yes. It worsens the progression of kidney disease and it makes your muscles weaker, your bones weaker. So you should be treating their acidosis by giving them sodium bicarbonate. Why do they become acidotic in kidney disease? I told you earlier. We eat acid every day. If you can't get rid of the acid because your kidneys are not functioning, you will become acidotic. We already talked about secondary hyperparathyroidism. It is mostly because inability to excrete the phosphorus, because phosphorus is excreted by the kidney, which increases the PTH. But in addition, kidney is the major organ which makes 125 hydroxyvitamin D. So kidney converts 25 hydroxyvitamin D, which is your over-the-counter vitamin D, to 125. But if the kidney is not functioning, you will have low vitamin D, this active form of vitamin D. So how do you treat the secondary hyperparathyroidism? You start with controlling the phosphorus levels first. Why wouldn't you give them 125 hydroxy level of 125 hydroxy vitamin D first? Anyone? Why am I controlling the phosphorus levels first and then giving them active form of vitamin D or calcitriol? Because if I started with vitamin D, I will worsen the phosphorus levels. So you want to bring the phosphorus levels into the normal range and then start calcitriol. Of course, reduce their phosphorus intake. How do you decrease the phosphorus levels? By giving calcium-based or non-calcium-based phosphate binders. So you have to give these medications with the meals so that they can bind the phosphorus in the meal, and then you start them on calcitriol. Do not anemia, maintain their hemoglobin between 10 and 11. Don't assume that anemia is because of chronic kidney disease. It is a diagnosis of exclusion. Do your iron studies, do your colonoscopy. I can't even tell you how many patients I see. I'm like, oh, and can they get erythropoietin? You check their stool occult, and they have colon cancer, right? So it's a diagnosis of exclusion. Gadolinium, which used to be an MRI contrast, it is not being used very commonly, can cause nephrogenic systemic fibrosis. So FDA recommends avoidance of gadolinium contrast in GFR of less than 30. Okay. American College of Radiology says don't give gadolinium if your GFR is less than 45. It's a very bad disease to have. Very rare, but terrible. And last slide is polycystic kidney disease, and I'm done. I'm sorry I took a little extra time. Um, that's the only genetic disease they're going to ask you. Look at the cyst, tons and tons of cyst. All you need to know is that these cysts can get infected, and which is the best drug to use? Fluoroquinolones. So if you have a patient, I generally give them ciproflox. I'm like, if you start having pain and fevers, start Cipro, because you might not see a urine analysis might be totally negative because these cysts are not attached to the urinary tract. So you can still be infected and the urine could be still negative. So if there's worries about infection, use fluoroquinolones. 40% of the patients may have cysts in the liver. One thing they love to test you is association with cerebral aneurysms. The question is, are you going to screen everyone? The answer is no. But if in my clinical practice, if somebody can't sleep at night, you're like, oh my God, am I, even though there's no indication, to be honest, I've screened them. Like, I want you to be able to sleep at night. But generally, the board correct answer is if you've got a high risk profession, if you're a pilot, if you're a scuba diver, of course I'm going to screen you. But otherwise, the other indication is if there's history of aneurysm in first degree relative or unknown cause of sudden death, either a first degree relative with aneurysm or unknown cause of sudden death or high risk occupation, as I mentioned. With that, I know it was a lot of content, but thank you for your attention.
we're live.
Okay, back from lunch. Hope everybody had a good lunch. Um, we have Dr. Lenny Mankin here. He's going to go over general internal medicine this afternoon rather, and he's Associate Program Director at Legacy Health, IM Residency, and Associate Professor of Medicine at Oregon Health and Science University in Portland. Who else was from Portland? Anyway, so Lenny, Lenny also is particularly interested in what he does. He's particularly interested in evidence-based medicine, medical education, residency training, hypertension, hyperlipidemia, and diabetes. He's the perfect guy for this lecture. So, all right, Lenny, thanks a lot.
All right. Thank you, Tony. Thanks for the nice introduction and thanks for having me out. Welcome, folks. Happy to be here. I've been practicing internal medicine for over 30 years now and kind of in the same boat of you guys. I've got to take these silly research exams and or certification exams. And so, it is obviously very important stuff that we're going through. I have a big challenge today, which is to teach internal medicine section of the review course to internal medicine doctors. You guys know so much, and so it's always a big challenge to me to try and find things that are perhaps new to you. I'm going to go over a lot of different topics. These topics, some of them seem a little fringe, etc., but when you add them all up, they make a lion's share of what you're going to see on the boards. So it is very important stuff. And hopefully I can get you a lot of key points that will help you with the exam. And so let us get started. So first off, we're going to talk about medications and important side effects. If you think about what the boards is there for more than anything else, it's to say you guys are okay to practice medicine and prescribe things. They want to make sure that we're not dangerous, that we're appropriately prescribing medications, that we're paying attention to drug-drug interactions, and also that we know important side effects of these medications. So let's talk about that. Drug-drug interactions account for a fair number of folks actually going in the hospital because of the drugs that we put people on. And generally, it's just a few offenders that keep showing up again and again in terms of causes of drug-drug interactions. And so the first and foremost, the number one on the list always is warfarin. And so we're seeing this a little less now that the DOACs are around, but warfarin is still a major cause of troubles. When you have patients on warfarin, we're measuring their INR, and their INRs can sometimes go up. So warfarin antagonizes vitamin K. Vitamin K comes from the diet, and it's also produced by our intestinal bacteria. When we do things that mess up our intestinal bacteria, then our vitamin K levels are going to go down and our INRs are going to shoot up high. So what do we do to the intestinal bacteria? We give antibiotics. All antibiotics can potentially raise your INR, some more so than others. And one of the biggest offenders is trimethoprim sulfa. And so be aware of that. Other things that will elevate your INR is if you're not breaking down your warfarin due to competition within the liver. And there are a few drugs that compete with warfarin for breakdown. So statins and gemfibrozole, as well as amiodarone. Think of those as heart drugs that are being broken down in the liver and replacing the catabolism of warfarin. So warfarin sticks around longer and causes the blood to get thinner. Azole antifungals and SSRIs round out the group that will increase INR. And then for decreased INR, patients certainly work against us, our use of warfarin if they have too many leafy vegetables. I don't tell patients not to eat salads. That would be against a good internal medicine spirit. But I do say you need to eat about the same amount every day of vegetables. Then I want to point out a medication that is on its own in this, rifampin, actually will increase catabolism. It'll cause rapid breakdown of warfarin, and so it'll actually lower your INR. So be aware of rifampin as the sort of outlier. Warfarin has interactions with analgesics. NSAIDs, not so much a direct interaction causing elevations of INR, but just combining an NSAID with warfarin is too high risk. And so the bleeding risk is huge. And so it's pretty much a no-go. Anyone on warfarin should never take an NSAID. Acetaminophen, surprisingly, can raise your INR, and it does so if you're taking it on a regular basis. So be aware of those patients who are taking 3 times a day acetaminophen. You might not even be aware of it, and then their INRs are going up as a result. And then finally, there's no interaction between opioids and warfarin. The DOACs have nice advantages of having very few drug-drug interactions. There's no drug-food interactions, so people can eat what they want, as much salad or as little salad as they want. And we're not measuring INR, we're taking it on faith that when the patients are taking this medication, their blood is adequately thin. There are some drugs, again, that, like I said, they show up again and again. The azole antifungals and amiodarone, both those drugs can cause increased bleeding risk for patients who are on DOACs. Some other drug interactions that I want you guys to really focus in on. If you see questions where they give you a bunch of medications on the list, look for some of these. So the PDE5 inhibitors like sildenafil, tadalafil, vardenafil, those can cause hypotension, especially in the setting of use of nitrates. And so the boards is going to potentially try and trick you with having you have a patient go on both medications. Lithium is an interesting one. We don't use as much lithium as when I first started practicing, but it's still out there. Lithium is a cation. Hydrochlorothiazide operates by blocking sodium reabsorption in your kidney. So you pee out sodium. The kidney tries very hard to stay neutral electrically, and so it reabsorbs other cations. And if lithium is in the mix, you will reabsorb a lot of lithium if you're on hydrochlorothiazide, and hence you could become lithium toxic. Some other ones, beta blockers. So beta blockers oppose the beta receptor, and so if you have something stimulating the alpha, it's what we call the unopposed alpha effect, where people can get accelerated hypertension. So if somebody's on clonidine, which is just in general a tough medication to be on, if clonidine is withdrawn, then you can have unopposed alpha agonism. And with that, you get a rebound hypertension if they're also on a beta blocker. Same idea with cocaine and use of beta blockers. If someone's on a beta blocker and they use cocaine, they're susceptible to unopposed alpha stimulation. A newer one or newish one that's come, these drugs are not new, but new to the black box warnings on gabapentin and pregabalin is an interaction with either opioids or benzos or both. So if you have patients who are on these chronic medications, opioids or benzos, if you add on one of the gabapentinoids, it can cause significant respiratory suppression. So be on the lookout for that. It's especially profound in older patients or patients with COPD. All right, looking at some of the side effects of some of these medications, hyperkalemia is a super common one. That can be caused by medications that decrease your aldosterone production. And so that's by design. The ACE inhibitors, the ARBs, NSAIDs also do that. And then we block aldosterone sometimes with drugs like spironolactone or eplerenone or finerenone. And so those drugs will also cause elevated potassium. And if you're using them in combination, you're at much higher risk. And then one I want to point out that's different from all the rest is TMP sulfa. And so I don't, when I'm putting a patient on an antibiotic, I look at their allergy list and then I usually prescribe the antibiotic. This is one where you have to be cautious if somebody's got hyperkalemia or is on medications that can cause hyperkalemia. Adding on TMP sulfa can cause very high K levels. So TMP sulfa, hyperkalemia is especially common in folks who are older or folks with HIV, and so use it very cautiously. Amiodarone. So we've seen amiodarone on the list already. Amiodarone and the thyroid, the answer is yes. What does it do to the thyroid? Yes, it does everything. So it can cause hypothyroidism. It has an iodine molecule within it, and that increased iodine load from the amiodarone can suppress the thyroid. And then it can also cause a thyroiditis of sorts. So there's a direct effect on the thyroid that can lead to elevated levels of levothyroxine. And then it's especially troublesome in patients who have an autonomous functioning nodule or who have Graves' disease, because you're just adding iodine fuel to the fire. So for patients who are on amiodarone, it's necessary to monitor their TSH regularly. I have some cardiologists who I share patients with who put the patients on amiodarone, and then I'll see them go a really long time and not check their TSH. So that's where I step in as the internist and make sure that thyroid function is staying in the right range. All right. You have a patient, they're on levothyroxine, everything's great, and then all of a sudden you get a TSH back and it's 30. And you say, what's going on here? They were so well controlled. What could be happening? So the first thing to question is, are they taking their medication? That's the most common thing that we see. They just dropped off that medication. But other things should come to mind. So primarily, are they absorbing their thyroid medication? So if they have underlying celiac disease, that can obviously uh, um, obstruct absorption. But look at the chelating agents. Think about how common they are and how they're all over the counter, or many of them are over the counter, such as iron. The PPIs are now over the counter, aluminum, calcium, and magnesium antacids. Those are things that our patients are taking, whether we know it or not, a lot of the times. And that can bind to your levothyroxine and prevent absorption. There are other medications out there that will slow down your, will increase your thyroid hormone catabolism. And so the seizure medicines are real well known for this. That's phenytoin and carbamazepine. Rifampin is another one. Remember that we saw earlier. This one also will increase your breakdown of your thyroid. Iodine overload on its own can be a problem. And then we talked about amiodarone already as a potential cause of hypothyroidism. All right, statins, super common. Atorvastatin is the most commonly prescribed medication in the United States. And so obviously the internal medicine boards, they're going to want you to know all about statin medications. Myalgias are the most commonly reported side effect of statins, as you well know. It's interesting, though, there was a study called the Heart Protection Study, the largest study of statins ever, 21,000 patients. Half of them were on simvastatin, half of them were on placebo. In the simvastatin group, it was 31% of the folks had myalgias. So these drugs, they really mess with the muscles, right? In the placebo group, 32% of the placebo group had muscle aches. It just tells me muscle aches are super common, and we blame statins. We call that the nocebo effect, where people have this belief that if I go on this medicine, I'm going to have a side effect. They've shown that over 90% of folks, when re-challenged with a statin, either a different one or same, they're able to tolerate. So keep that in mind. Rhabdo with statins is incredibly uncommon, especially since we got rid of the main offending agent about 20 years ago that was doing that. LFT abnormalities are pretty rare, and then when we do find them, if you stop the statin, they tend to go away, and liver failure is more common in the general population not taking statins, so that does not appear to be a worry. All right. Are there drugs that increase your risk for statin-induced myopathy? For sure there are. And so there it is again on the list. If amiodarone is an answer choice, that's a pretty good bet of what to go with. So amiodarone will decrease the breakdown of your statins, as do do the other medications on this list. We see again the azole antifungals. Um, Clarithromycin is a medication that we hardly ever use anymore. It's probably number one in drug-drug interactions. If we were using it a lot, it would be on the top of the list. Patients who take statins can eat grapefruit, but no more than half a grapefruit a day. Fibric acid derivatives can mess with statins, so we're not using these medications as much as we used to because we found that they really don't impact cardiovascular events. Importantly, it's more about the statin medications and then some of the other medications we're using for lipids nowadays. Calcium blockers is very interesting. They have a specific interaction with one and only one of the statins, which is simvastatin. So simvastatin, which we're using less of these days, if you have that combined with either amlodipine or diltiazem, the simvastatin levels will go up and increase your risk for statin-induced myopathy. So, and then if someone is having statin-induced myopathy, things to do, try a different statin. So if they're on atorvastatin, switch them over to rosuvastatin or pravastatin. It's a different P450 breakdown mechanism. Oftentimes it takes care of the problem. And then, as I mentioned before, reintroducing even the same statin, patients are able to tolerate on a second go very frequently. So don't give up on statins unless you've given it a really good try. All right, the dreaded QT interval prolongation. This is always a tough one because a lot of medications can prolong QT and they can sneak up on a patient's med list without us always recognizing it. So it's typically not a single agent unless it's in a major overdose. But oftentimes when people are on 2 or more QT prolonging agents, that's where we get into trouble. We are at risk for torsade de pointe. I don't speak French, but I think it means impending death. And this can happen in the setting of either low magnesium or low potassium. So be aware. The common agents involved here, the antiarrhythmic agents, amiodarone, again, choose amiodarone. Antipsychotic medicines are notorious for this. Certain antimicrobials, so you might have someone who's on chronic antipsychotics or on an antiarrhythmic, and then you add on a quinolone or a macrolide, and lo and behold, their QT goes up. Antidepressants, the tricyclics, trazodone that we use for sleep, methadone, so we see a lot of patients on methadone, and triptan medicines. A lot of medicines that are for different indications that we might not think so much about, and when we combine them, then this dreaded event can occur. I had a patient come in, they were followed by a psychiatrist. They had run out of their very complicated regimen of a couple of different antipsychotics, antidepressants. They were also on methadone, and they said, "Can you please refill my medications while I'm awaiting my new psychiatrist?" I waited 5 hours at a psych emergency department a week ago, and they gave me a week's worth of medicines. I'm running out. And the mom was a former nurse at our facility, and so I said, "I will give you that, but you need to connect with the psychiatrist." I gave the refills. The next day, I get a call from an alternate hospital where the patient had gone into torsade and full arrest. Thankfully recovered, but it was, again, a stark reminder of these medicines are really dangerous, and we can't be cavalier about it. Serotonin syndrome is another one that just kills me because there are so many different medicines that can lead to this, and it just takes a couple of them. So the classic triad for serotonin syndrome is where people will have agitation, confusion, so mental status abnormalities. They'll get hyperactive autonomic systems, so they are sweaty and they have high temperatures. They can be tachycardic and hypertensive, and then they can get hyperreflexic. And so that's your classic serotonin syndrome that the boards may ask you to recognize. And then, very importantly, looking to the drugs that can cause this. So, SSRIs are incredibly common, and SNRIs, incredibly commonly used drugs. When you have those used in combination with things like, oh, let's put you on some trazodone for sleep and tramadol for pain relief, all of a sudden, serotonin syndrome can arise. I can look at a lot of med lists, including med lists of my patients, and say, ooh, that doesn't look great. Should we stop one of these medications? And then certainly I try not to put too many patients on cocaine or methamphetamine because that can cause problems. All right. Hyponatremia, you learned a little bit about in the renal section earlier today. And there are certain drugs that can commonly cause hyponatremia. The most common one I think about is hydrochlorothiazide. I will treat people with hydrochlorothiazide, measure their chemistries, and typically I'll let them go down to about 130 before I start getting real uncomfortable with that medication and looking for alternates. SSRIs, carbamazepine, and then again, remember TMP sulfa can drop your sodium. Uric acid. So people at risk or who have gout, diuretics are one of the biggest offenders for this, as you're probably well aware. The thiazides increase about 2.5-fold your risk for a gout flare in someone with known gout. Niacin, I hope that none of you are really using niacin anymore because it's a pretty useless medication, although it does give that fun flush that the patients can freak out about. But it can increase your uric acid and cyclosporin in rare cases where patients need to be on that medication. All right, that brings us to wake you up. It's after lunch, and I want to keep your attention. Audience response question time. So we have a 66-year-old man experiencing homelessness who's diagnosed with tuberculosis. He started on a 4-drug regimen: isoniazid, rifampin, PZA, and ethambutol. He has a medical history of atrial fibrillation, hyperlipidemia, hypothyroidism, and depression. His medications include warfarin, metoprolol, atorvastatin, levothyroxine, and citalopram. Which of the following adjustments would be most appropriate for his medication regimen? Should we increase warfarin, increase levothyroxine, increase warfarin, decrease levothyroxine, decrease warfarin, increase levothyroxine, decrease warfarin, decrease levothyroxine? All right, so the correct answer here is A, and most of you did a good job picking up on that. So remember that this was the outlier drug when we talked about warfarin that will actually decrease your INR. It'll increase your catabolism of warfarin. And so you need to up your dose of warfarin. And then this is one that will antagonize or speed up your breakdown of levothyroxine. And so you need to increase your amounts of levothyroxine when patients are on rifampin. All right, next question. You get called with a panic value, an INR of 5.8 in a 52-year-old woman with a history of hypertension, diabetes, and atrial fibrillation. When you review the records, her INR has been very stable for the last 8 months. She says she's just finishing a 7-day course of some antibiotic that an ED physician prescribed for bronchitis. So we see she takes warfarin, metformin, and hydrochlorothiazide. What do you think that antibiotic was? Was it a linezolid, azithromycin, cefixime, cephalexin, or TMP sulfa? Okay, so the correct answer I've indicated here is the TMP sulfa. Any of these antibiotics has the potential, as we talked about, to raise the INR, but some do it better. And TMP sulfa is one that really knocks out the gut bacteria and prevents them from synthesizing the vitamin K. And so the INR the warfarin overpowers and the INR goes up. Yes. Like I said, all of the medications have the potential. The TMP sulfa is the one that's going to be most prone to doing that. All right. Our next question, a 60-year-old man comes in complaining of aching in his shoulders and thighs. He's currently taking benazepril, amlodipine, warfarin, omeprazole, simvastatin, and loratadine. Which of these drugs is most likely contributing to this to the symptoms of myalgias? All right, and I heard whisper of that's a trick question, and it is a little bit of a trick question. You guys were automatically looking for the statin, and it wasn't on there. But if you remember, I mentioned that amlodipine, when combined with simvastatin, it prevents the breakdown of simvastatin and puts you at higher risk for myopathy. All right. We have a 73-year-old man with bipolar disorder, CAD, hypertension, and systolic heart failure. And he presents for syncope. They do a rhythm strip, and it looks like this. Looks very French. Something, or call the coroner, something like that. I never really studied French. Which of the following medications most likely contributed to his arrhythmia? Was this related to taking metoprolol and clonidine? Was this a problem with lithium and hydrochlorothiazide? Is this a result of taking amlodipine and simvastatin, quetiapine and methadone, or sildenafil and isosorbide? So the correct answer here is D. Quetiapine and methadone fit very nicely on the list of medications that cause QT prolongation. And so recognizing that when patients are on 2 or more of those medications, you're at higher risk for having cardiac arrhythmias. All right, next question. We have a 63-year-old woman with bipolar disorder, hypertension, CKD, and hyperlipidemia who has blood pressures that are consistently quite high. Her most recent labs show a potassium of 5.3 and a creatinine of 1.9. Her medications currently are atorvastatin, lithium, and metoprolol. Which of the following medications would be reasonable to add for her hypertension? Do you want to add on clonidine, lisinopril, spironolactone, amlodipine, or hydrochlorothiazide? So the correct answer here I have is amlodipine, which the majority of you got correct. Some of you wanted to go with hydrochlorothiazide. So why would we shy away from hydrochlorothiazide in this situation? So not necessarily the creatinine, but because they're on lithium. And so remember that hydrochlorothiazide added on here would cause you to retain lithium and put the patient at risk for lithium toxicity. If you had to use it, you could lower your lithium dose and check it, but it's easier to avoid that. Why not clonidine? It's on a beta blocker, right? And so that if the patient didn't stick with it all the time, it would put them at high risk for unopposed alpha agonism and very elevated blood pressures, potentially fatal even. Lisinopril we're not using because the potassium, it's they're hyperkalemic to start, and same reason with spironolactone we'd avoid. Good job. All right. So that's enough of drugs, right? Let's switch on to something different. We're going to talk about geriatric syndromes. So rule number 1 for geriatrics is polypharmacy is a problem. If you could stop a medication, it's generally a good idea. So always look to deprescribe when appropriate. And then rule number 2, if you can't stop the medication, it's always physical therapy, right? Behavioral approaches, things like that. Okay, so there was a look at what drugs cause the most problems in older folks. And really high on that list were NSAIDs. So almost this was about 1 in 12 hospitalizations in older people were related to adverse drug reactions, and NSAIDs topped that list. Older patients, when we use these, they have fragile guts. They're at higher risk for having ulcer disease. They have kidneys that are fragile and are at risk for having worsening of kidney function. It accelerates hypertension. It can worsen heart failure from fluid overload. So in general, NSAIDs do not mix well with older individuals. Try and avoid them whenever possible. If you need to use NSAIDs, perhaps using a topical NSAID. So the diclofenac gel has become widely available now and might be a good workaround. There's minimal absorption. There's still potential absorption, but it's pretty small amount compared to taking an oral NSAID. If I do have a patient on chronic oral NSAIDs, they refuse to not take it, then I'm putting them on a PPI at minimum for gastric protection. Falls is a leading cause of morbidity and mortality in older folks, and the risk goes up the older you are and the more comorbidities you have. The AGS recommends a risk assessment in any older adult with 2 or more falls in the past year, or 1 fall if they already have some gait disturbance. So what things put people at risk for falls? I think you guys all are quite aware. Prior falls lead to more falls. People who have decreased sensation, so peripheral neuropathies, decreased vision. If they have an unsteady gait or have weakness from a stroke, if they're cognitively impaired, if they're on medications. So all these different things lead to this potential for falls, and our job is to do the best we can to prevent our patients from getting injured. Probably the top offender that we're thinking about, especially for boards, is trying to avoid medications that contribute to falls. So in older people, trying to avoid the sedative hypnotic medications. So benzos are the enemy. We try not to prescribe those. Antihypertensives for their orthostatic effects. Antidepressant medications, especially the older ones, the tricyclics, put people at high risk for orthostasis and falls. Antipsychotic medicines, opioids, and then the dreaded sleep medications that are sometimes hard to avoid, but put people at risk for confusion and falls. So on a board exam, feel good about saying no to the patient that you're not going to prescribe the benzo or the zolpidem or whatever. A little harder in real practice, right? All right. So what to do for assessing someone for falls? Start with the history and physical, getting at all those things we talked about. A get up and go test is helpful. Have the patient stand up out of the chair, see how long it takes them, see if they can do it without using their hands. Measure their gait speed. Gait speed is now a good clue to one's risk for falls and overall mortality. It's well known in geriatric circles that the Grim Reaper walks at 2 feet per second. So you've got to outpace them. The best intervention to prevent falls is exercise. They've looked at studies of all these different methods for reducing falls, and they're all effective, including things like Tai Chi, dance classes, things that maybe you can motivate your patients to do. You want to minimize the medications that we talked about on the last slide, treat their vision, avoid too many orthostatic medications, make sure that they're eating and drinking appropriately. These are folks who you're sending in the home assessment team to try and minimize their fall risks and put grab bars on things and pull up carpets, etc. And then we don't know, there were some early signals that vitamin D, we were hoping it would decrease fractures. And when they looked at it, they say, well, it didn't really reduce fractures, but it did reduce falls. And that seemed to be an anomaly. And then later studies have come out and have not shown any benefits to vitamin D in terms of fall prevention. So it's no longer recommended as a means for reducing falls. We don't know if walkers help. Restraints are always the wrong answer on the boards. They don't help, and they probably cause more agitation, delirium problems. Osteoporosis. So how do we prevent people from losing their bone strength? So the use of calcium and vitamin D in people who do not have osteoporosis yet is very controversial. It's not clear that taking a 55-year-old woman and saying, here, take supplements, this will help keep your bones strong. We don't know that that actually works. Recommends against using calcium and that's how that's pronounced, right? Recommend against using calcium and vitamin D unless the patient's institutionalized, doesn't get out in the sunshine, is having poor nutrition, etc. The National Osteoporosis Foundation still recommends supplementing. So controversial from an evidence-based standpoint, there's not a lot of great direction for calcium vitamin D supplementation for prevention. There was the Cochrane review that I mentioned there that did have a suggestion early on of less fractures. So I'll leave it at controversial. So what are the risk factors for osteoporosis? Age over 65, any history of a fragility fracture, both individually or in a first-degree relative, if they are slight build, if they are smokers, if they drink more than 2 drinks a day, if they experienced early menopause, they didn't have estrogen promoting bone health into later years, if they've been treated with steroids. This is super important. Think about your patients who have accumulated 3 months worth of steroids in their lifetime. For a lot of asthmatics, it doesn't take much to get over this threshold, and that puts them at higher risk. Or anyone taking more than 5 milligrams of prednisone on a fairly regular basis. And then malabsorptive syndromes, things that are going to keep you from absorbing calcium. So who gets a DEXA? So the general agreed upon who insurance is going to pay for to get a DEXA is any women 65 and over, or if you're postmenopausal below the age of 65 and have additional risk factors, you can make an argument for getting a DEXA earlier. The National Osteoporosis Foundation also recommends getting DEXA in men over age 70 or over age 50 who have risk factors, and men and postmenopausal women over age 50 if they've ever had a fracture. Harder to get insurance companies to pay for that. The USPSTF does not have a recommendation for or against screening for osteoporosis at all in men who have not had a fracture, I should add on. So what medications can stimulate osteoporosis? So probably the biggest offender I've underlined on the list, glucocorticoids. So one of the many reasons we don't want to overprescribe glucocorticoids is because it really leaches the bone of calcium. The older anti-seizure medicines are notorious for causing osteoporosis. And so these are folks, if they've been on it for years and years, which many of these patients, many of the epilepsy patients have been doing, they need to be screened for osteoporosis. Any drug that decreases your sex hormones, your testosterone or your estrogen, will promote bone loss. And so if patients are on medicines that block those, um, including opioids, then that puts them at higher risk. Thyroid over replacement. I used to work at this ridiculous scenario where I took care of people. It was a moonlighting job. I took care of people in Hollywood who were in different guilds. And they would come in and they all wanted to be super thin. And many of them were getting thyroid replacement extract from other countries and taking it. And they were hyperthyroid. And what were they doing? They were leaching their bones of calcium. So those people are at high risk for having osteoporosis later on. Cyclosporin, lithium, PPIs. PPIs, think about that in patients who are on PPIs for their heartburn. Some of them need to be on PPIs, otherwise they have troubling heartburn. About 40% of those folks, you can dial it down to putting them on PRNH2 blockers or PRN acids. And that's kind of a trend we want to push away from chronic PPIs, at least give people trials off of their PPI. If you don't have acid, you don't absorb as much things like calcium and iron. And so you need healthy amounts of acid to get good calcium absorption and bone health. All right. What diseases should we screen for osteoporosis? Kind of a lot of diseases that make sense from what we've been talking about thus far. So any of the GI diseases that promote malabsorption. So if you've got uncontrolled inflammatory bowel disease, celiac disease, if you've had a gastric bypass or a gastrectomy, you're not absorbing as much of the calcium from your diet. And so these people might need to be on supplements, and you would tend to screen them earlier. Endocrine diseases. So primary hyperparathyroidism is super common in older folks, and the parathyroid hormone, its job is to take calcium out of the bones and put it in the bloodstream when it's signaled to be secreted. Cushing syndrome, so too much steroid. Hypogonadism, so not enough sex hormone. And then endogenous hyperthyroidism. Chronic kidney disease is one that puts people at very elevated risk for osteoporosis. People who are bedbound, who don't exercise, don't have weight-bearing exercise specifically. The inflammatory conditions. Almost anyone with active rheumatoid arthritis has periarticular osteopenia at minimum and are at very high risk over time to become osteoporotic. Plus, they're often treated with steroids in their flares. And then people with eating disorders, so malnutrition. All right. How do we categorize people with their DEXA screening? So this is the one where we have to remember that we measure this in standard deviations, comparing it to someone who's 25 years of age. Kind of unfair, right? But unfair standard. But we're looking at anyone who's got the same or greater than, it's always hard to say, -1, a T-score -1, so below the standard, that would be the normal range. Osteopenia is -1 to -2.5, and then anyone who's 2.5 standard deviations below is considered osteoporosis. And if you have a fracture, they categorize that as severe osteoporosis. This is the FRAX score. You guys have probably all seen this. This is World Health Organization website, and it helps us calculate when someone has osteopenia, -1 to -2.49, which of those patients are at accelerated risk for fracture, who we should treat with agents for osteoporosis. And so when I get reports from my DEXA scans, they've already pre-populated in mine. Hopefully you guys are getting that. it'll say your patient has osteopenia with a FRAX score of. So who should receive drug therapy? So any postmenopausal women and men who are over the age of 50, who have had a hip or a vertebral compression fracture should be on therapy for osteoporosis. Anyone with a T-score less than minus 2.5. Or, as I mentioned, if you've got osteopenia, then you're using a FRAX score. And the current standard for that is if on the FRAX, it calculates to a better than 3% 10-year risk for hip fracture or a better than 20% risk for any fracture, then you would put that patient on therapy for osteoporosis. What are the therapies? For someone who has osteoporosis, the controversy is really not there anymore. We treat all these people with calcium and vitamin supplements. We recommend weight-bearing exercise, and we try and reduce all reversible risks for falls. We target about a gram to 1,200 milligrams of calcium daily and 800 to 1,000 units of vitamin D daily. And that includes dietary intake. And then USPSTF recommends against the low-dose supplements for these folks. And then the core of our therapy is the bisphosphonate medication. Alendronate is the most commonly used medication. It's available in weekly formulation as well as monthly formulations. If a patient is unable to take a bisphosphonate because of esophageal issues, then you consider zoledronate, which is an IV form of bisphosphonate. Calcitonin is an old medication for osteoporosis, really has minimal effect on bone strengthening, and it's mainly been shown to have effect in decreasing pains associated with acute fractures, so it's still used for that. Teriparatide is giving subcutaneous parathyroid hormone. And so for people who are very high risk, who cannot tolerate the bisphosphonates, denosumab is a hormonal treatment. It's an anti-rank L therapy. Problems behind it: one, when you go on it, it's basically you have to be on it for life. If you stop it, you get a full reversal of the process, and it's extremely expensive, so it's hard to get coverage. Raloxifene can be used to a lesser degree in patients, especially if they've had breast cancer. And then estrogens. Estrogens promote bone health, no question, but because there's so many risks to estrogen, we no longer recommend use of estrogen as a means for either preventing or treating osteoporosis. If a patient's on them for their hot flushes, vasomotor symptoms, it's probably promoting good bone health, but we wouldn't target an estrogen as a treatment. All right. How long do we keep people on their osteoporosis therapy? What is the half-life of a bisphosphonate? It's measured in years. And so it gets incorporated in the bone and it stays there for a really long time. And so do we need to treat these people forever is a big question that's out there, and it's still not fully answered. So if we continue to use bisphosphonates, there have been a couple of complications that have arisen that I want you to know about. One is people are getting transverse fractures of their long bones, specifically their femur just snaps in half. And it happens at a much lower frequency than all the fractures we're preventing, but still, we don't want to bring about problems. And then the second thing is osteonecrosis of the jaw, which I'm sure you're all familiar with, and battling with the dentists over, whether they can have their dental procedure if they have to go off their bisphosphonate. Bisphosphonate therapy, it's generally agreed, should be kept on board for at least 5 years. And then at that point, they give us the option of continuing bisphosphonates, or we can stop it if they appear to be pretty stable, if their bone mineral density is staying the same on their DEXA, if they haven't experienced fractures during the time of being on the bisphosphonate, you could opt to stop it and give them a drug holiday, and then you would follow them every year or two with DEXAs. And then if you're seeing a sharp decline, you'd get them started back on a bisphosphonate. Same risk factors, and then if they're having fractures on therapy, yeah. The- So how long does it take to develop osteoporosis in women who get early menopause? I don't have good figures on that, quite honestly. I know that they're at much higher risk and probably developing it probably 10 or 20 years earlier, depending on how soon they had their menopause, how early they had it. All right, that brings us to some more audience response question times. Questions. So, a 56-year-old woman with obesity who is postmenopausal presents with concerns for osteoporosis because her 50-year-old sister-in-law just fractured her hip. Patient has never been on hormone replacement therapy. She does not smoke, has no underlying medical problems. She has no perimenopausal symptoms yet. She has no family history of osteoporosis. What would you recommend for this lady? Would you get a DEXA scan on her? Would you get her started on estrogen and progestin therapy? Would you put her on alendronate? Would you encourage her to use weight-bearing exercises, or would you start raloxifene? All right. And the majority of you went with the correct answer here of encourage weight-bearing exercise. So remember, this woman's sister-in-law had a fracture at age 50, but not, well, at least from the parts I'm from, that doesn't count as family. So this person really doesn't meet any criteria for osteoporosis screening just yet. That was a bit of a trick question. Seeing if you're awake. All right. We have a 65-year-old woman who has a screening DEXA scan. She has no family history of osteoporosis. She drinks alcohol occasionally. She does not smoke. Her medical history is negative except for a DVT while she was on oral contraceptives. She takes calcium and vitamin D. Her DEXA is minus 2.7 at the hip, minus 1.8 at the vertebra. What would you recommend for this woman? Starting teriparatide, alendronate, raloxifene, calcitonin, or estrogen progestin therapy? Oh, 100%. Awesome. You guys are getting smart, and it's because of the water you're drinking. All right. A 72-year-old woman with history of osteoporosis presents to follow up on her DEXA scan results. She's taken alendronate 70 milligrams weekly for the past 6 years. Initially, she had a DEXA scan with a T-score of minus 1.8 at the hip, minus 1.6 at the spine, and then had a 10-year risk of hip fracture of 3.5%. So her FRAX score is what put her over the edge for getting her initial treatment. Her current DEXA shows a T-score of minus 1.9 at the hip and minus 1.7 at the spine. So what would you recommend? Would you keep her on the alendronate? Would you switch her to raloxifene or to teriparatide or to denosumab, or would you stop the alendronate? All right, and my correct answer here is stopping the alendronate. If you did put A and said, I want to continue this patient on alendronate, I would give that credit too. This would be too controversial a question to put on the boards. But I'm giving this as an example of somebody who you could consider a drug holiday on. They've been on it for 6 years. It's going to stay in their system for quite a while, years. And so you might be able to get them off the medication, decrease their risks for those transverse femur fractures and jaw problems. A 63-year-old woman with a family history of osteoporosis presents with a vertebral fracture. She has a workup that reveals no complicating causes other than the osteoporosis. She has a history of type 2 diabetes, a prior DVT, and severe reflux esophagitis with stricture in her past. Her exam is unremarkable except for spinal tenderness over T7. What would you recommend for her? Would you have her go on teriparatide, alendronate, estrogen, zoledronate, or have kyphoplasty? Okay, so my correct answer here would be to have the patient go on zoledronate or zoledronic acid. They get a one-time infusion every year to year and a half. And so the preferred treatment in someone with osteoporosis is bisphosphonates. This person has erosive esophagitis with a stricture. So that's someone where it's too risky to put them on alendronate. Remember, alendronate's the pill that if it doesn't make it through the esophagus, it causes a pill esophagitis. It can burn a hole in that area. And so it would be too risky. So we still want to use a bisphosphonate if possible. And so that's where we would reach for the zoledronate. Some of you were thinking about teriparatide. It's more expensive and not as well proven, so it's not a terrible answer, but zoledronate would be preferred. And then some of you were looking at doing kyphoplasty. That's often done. The randomized trials of kyphoplasty compared to placebo do not show additional benefit with using kyphoplasty. So it's a procedure that we probably shouldn't be doing in the majority of patients with the vertebral fracture. That's where you put cement directly, you inject it into their vertebrae. All right, switching topics a little bit, let's talk briefly about elder mistreatment. This is something that they want you to recognize on boards. So it's defined as an intentional action, such as being abusive towards an older person or failing to act on their behalf, aka neglect, that's doled out by a caregiver or family member. It's most prevalent in folks who have dementia. You can see it, or you might see it in the form of just poor care for the individual, skin tears, lacerations, bruises, etc., pressure ulcers, while not 100% preventable, are also big red flags when we see them. And it's mandatory that we report any suspected elder abuse. Nutrition, another brief topic to go through. So malnutrition is pretty common in long-term care facilities, again, especially in people with dementia. Low BMI and rapid weight loss are associated with increased mortality rates, as well as increased morbidity, long hospital stays, etc. So if we're thinking about malnutrition in older folks, especially if they're having unexplained weight loss, then you're going to do your history, physical exam, figure out if there's some kind of underlying problem going on. Is it pain with eating? Is it a malignancy? Is it severe depression that's keeping them from going out? Is it bad dentures? Things like that. If patients have poor nourishment without obvious cause, you can use protein calorie supplementation as a means for reducing overall mortality and hospitalizations. I find these to be expensive and sometimes hard for families to afford, and insurance doesn't often cover them in my experience. Dysphagia is worth talking about in older folks. Very common problem and can lead to all kinds of downstream issues, including especially weight loss. If someone's having dysphagia of solids initially, that then progresses to dysphagia of solids and liquids, you want to think about mechanical problems. The most common mechanical problem being stricture from long-standing GERD. Also think about things like anatomic abnormalities like webs and rings, and then esophageal cancer would be the dreaded worst case scenario. Dysphagia of solids and liquids at the same time, then we start thinking about motility disorders. And so especially in older folks, we think about, do they have Parkinson's disease? Do they have a prior stroke that's affecting their swallowing mechanism? Could they have achalasia? If we're thinking about working these folks up, if someone's having dysphagia primarily of solids, then we're going to want to do an EGD right off the bat, looking directly at what's going on. If they're having liquid dysphagia, that's where manometry can come in, and we can see the pressure waves going through, and could they have some kind of motility disorder? And then finally, if you're uncertain on that, you could do a barium swallow and or the other study that hasn't been done if you still don't have a diagnosis. I talked to some of my GI colleagues, and they can't give me a straight answer as to which one to do when. And then treatment's going to be dependent on your cause. If you have a peptic stricture, we're going to, if it's bad enough, dilate the lower esophagus. That comes with risks of perforation, tears. If they're having just problems swallowing certain types of foods, incorporating your speech language pathologist can be very beneficial for coming up with the appropriate diet for the patients. Insomnia, it's a tough topic, right? No one's sleeping, and they want you to fix it. So you always want to look for underlying conditions that could be responsible for the insomnia. So are they having pain that's keeping them awake? Are they waking up 10 times a night to pee? Do they have restless leg syndrome that's going unrecognized? Are they having orthopnea perhaps? Are they wakening themselves multiple times a night due to their sleep apnea? Or do they have an anxiety disorder that's not controlled? Remember that certain medications, lots of medications, contribute to insomnia. SSRIs and SNRIs are tops of that list. And so if somebody, especially if they're starting new on one of these agents and they're developing insomnia, think about, should we change that medication up? Are they taking things that are keeping them awake? Stimulants, diuretics, corticosteroids. If patients are going on a course of steroids, always have them started in the morning. That's part of your natural rhythm. When patients start taking it in the evenings, they go nuts and they can't sleep. And then avoidance of caffeine, alcohol, nicotine, too much fluid at night, and then the big dreaded screens that we're all addicted to, reading on our phones at night. How do we treat insomnia? For the purposes of the boards, CBT for everyone, right? And then in real life, it's pretty hard to get your patients, one, to accept it, and two, to find a CBD program. But that, in comparison studies with zolpidem, has been shown to be equivalent for improving insomnia. Try and avoid medications at all costs, especially on your boards. The benzodiazepine and the other Z drugs like zopiclone and zolpidem are associated with increased risk for falls, sleepwalking, sleep eating, sleep sex, all kinds of bizarre stories that we like to collect as internists, and they become habituated and need more and more in order to get satisfactory sleep. And they're not getting deep sleep. They're not getting the REM sleep that gives them the restoration the next day. So if you're going to use a medicine, I generally try and avoid the habit-forming medicines and opt more for the medicines that are, you know, at least not habit-forming, like trazodone. Sometimes gabapentin can be helpful. Some of the over-the-counter things, mainly they're anticholinergics, so those come with their own side effects. Ramelteon is a melatonin based drug that's an alternative. It can help. Melatonin in itself can help, kind of variable. There seems to be probably a placebo effect in my view with melatonin. Remember that alpha blockers can be useful for PTSD, nightmare patients. Not nightmare patients, PTSD patients with nightmare. Maybe nightmare patients. All right. Restless leg syndrome. When I was training, this didn't exist. And then I really felt like the commercials came out like, we've got a drug and now here's a reason to use it. So these are patients who have leg discomfort and paresthesias, numbness, tingling, feeling like they need to get up and roam around at nighttime, mostly at night. They just need to move their legs. And when they walk around, they feel better. It's the older you are, the more common this becomes. It's strongly associated with iron deficiency. And so you want to think about that. And then antidepressants can set this off. And so be aware of that. So for all patients complaining of restless leg syndrome symptoms, you want to check for iron deficiency. If they're iron deficient, treat their iron deficiency, and hopefully the restless legs will go away. If they are not iron deficient, treating with iron does not help, so don't do that. Eliminate any meds that could be in the mix causing this. And then there's a couple of different options for therapy. Traditionally, we've been using dopaminergic agents. The ropinirole and pramipexole are the more common ones used. They have two big problems associated with them. First is augmentation. People take them, they get some symptom relief, great. And then all of a sudden, the symptoms start happening earlier. They become more severe. They start involving their arms and their legs. So this augmentation happens. What's our knee-jerk reaction? Go up on the medicine. We go up on the medicine until we're at the max dose of medicine, and then they're still having these intolerable symptoms. So some experts are saying, oh, and then the other downside of these medicines is they're disinhibiting. And so use of these dopaminergic agents have been associated with people who've never gambled before in their lives, who live in a nursing home, getting on the bus, going to the casino, and blowing all their retirement savings. So you have to be on the watch out for this sort of compulsive behavior. So a lot of experts have been turning now to the gabapentin and pregabalin classes of medicine to try and treat restless legs as a first line to avoid the problems associated with the dopaminergic agents. It's an annoying problem, but not a life-threatening problem, and you don't want to add more misery to these people's lives. All right, dementia and delirium. This is a huge topic. We'll try and hit the highlights. This is definitely something that will be on the boards. So dementia is a chronic progressive deterioration in your mental function. Most patients with dementia we classify as having Alzheimer's disease, although we don't usually do diagnostic testing on them. They just fit the pattern. If we do imaging, sometimes we'll see multiple infarcts, and then we call it multi-infarct dementia. Lewy body dementia is one associated with Parkinsonian features, disturbed sleep, and hallucinations. Parkinson's on its own causes dementia over time. And then remember that depression can give someone the appearance of having a dementia. And so sometimes severe depression, I haven't seen it, but if you treat their severe depression, all of a sudden they come out of it. Maybe I've seen a little. Treatment for Alzheimer's, the cholinesterase inhibitors have been around for about 20, 25 years now. Donepezil, rivastigmine, galantamine's another one. Those are first-line agents in general for people with some cognitive decline, usually a mini mental status or MoCA in the 20 to 25 range. You would think about using these medications. And what they've been shown to do is slow progression of decline. So we're not bumping up their cognition, we're slowing the rate of decline. If you look at these different scores, the clinical dementia rating score, if they're losing a point over time, it takes 10 months for a patient not on this medication. It takes 12 months to reach that point on this medication. It's the best way I can explain it. So it's a very, ever so slightly affects the slope of decline. So they're not magic medicines, as you're well aware. Sometimes they're helpful at some of the behavioral disturbances that go along with dementia. And so oftentimes we'll add these medications on when the patient's, wandering or yelling at night, that type of thing. You have to be careful. I don't have it on the slide, but you have to be careful with the cholinesterase inhibitors. They increase the amount of acetylcholine in your brain, but it's not specific to the brain, so they also increase your body's acetylcholine. Acetylcholine in your body, that's your rest and digest hormone. And so it causes acid to be produced in your stomach, causes peristalsis. About 30% of folks on these cholinesterase inhibitors get GI side effects. And then occasionally we'll see the patient show up in the ER and their heart rate is 30 and it's just too much acetylcholine, and so it slows down their heart rate. So be aware. There are some newer agents. There are two that are FDA approved now, lecanemab and aducanumab, that target beta amyloid and take the beta amyloid out of the brain. And they've also been shown, mainly lecanemab, to slow the progression of dementia. That one by about 6 months over an 18-month period. Too soon to be thinking about that on the board exams. It's only available in specialized centers, and the data is just emerging now. Memantine is an NMDA receptor antagonist that can give benefit at later stages of dementia, and can be added on to a cholinesterase inhibitor. For people with severe dementia, it's more about keeping the patient safe, out of harm's way, trying to minimize medications and behavioral disturbances. And then remember that in a lot of these patients, if we use an antipsychotic medication, that has been shown to increase their overall mortality risk. It's a, benefit risk discussion that we have with the patients' families, saying they're having uncontrolled behaviors. We can put them on these medicines and that will calm the behaviors, but there is a increased risk of mortality as a result. I find that most families want to control the behaviors. Pressure injuries. So this is related to having too much weight on a particular area of the body for too long, either from the patient's own body weight on one of their susceptible areas like the ankles, or from an external device like a brace that's pressing down on an area and the patient doesn't have the awareness to move and adjust the brace or things like that. And so this is mainly in patients who are very immobile, who have poor sensation, oftentimes poor cognition. How do we prevent these pressure injuries? Good luck. Ambulation, mobility is the most important thing. And so you get them moving as much as you can up and out of bed. Have the caregivers turn them as frequently as possible. There are devices that are helpful for this. The egg crate mattresses and the expanding, contracting air mattresses, etc., can be very helpful. And then their main limitations are costs. I did not show pictures of the stages of pressure injuries after lunch. You're welcome. I think you guys have a vague recollection of this. The stage 1 is just where you have a non-blanchable erythema in an area of pressure. So over the sacrum, you'll notice a discoloration, a redness, where a pressure ulcer could likely form. And then when we start losing parts of the anatomy, that's where we advance the stages. So if it goes to expose the dermis at stage 2, if the fat is exposed at stage 3, and then full thickness is called stage 4. So treatment, again, redistribution of pressure is the mainstay for treating these folks. Wound care in general, you want to debride wounds. If there's excess eschar, you want to get rid of that. There are different devices that we use and wound vacs that sometimes help to create a better healing environment. When we initially cleanse wounds, it's fine to use whatever agent, but continued use of things like iodine, or I'm blanking on the name, the peroxide, things like that, that actually poisons the fibroblasts that are trying to lay down granulation tissue. And so you want to avoid use of those kind of chemicals when you have these chronic pressure injuries. Control infection, only treat these people if they have gross cellulitis, osteomyelitis, or systemic infection. Just having an ulcer on itself is not a reason for antibiotic use. You want to optimize their nutrition, although things like vitamin C and zinc are not necessarily proven to be the right answer here. And then you want to manage pain, because these folks often have pretty severe pain. All right, that was a whole potpourri of topics in geriatrics. Notice my use of French there, getting better at this. We've got a 76-year-old woman who's brought in for evaluation of several recent falls. She lives in a nearby nursing home. She spends much of her day in bed, getting up for lunch and dinner. She has type 2 diabetes, hypertension, coronary disease, and reflux. She's on omeprazole, nortriptyline, hydrochlorothiazide, calcium, and vitamin D. So the question is, in addition to doing some physical therapy, exercise training, which would you recommend? Would you want to do a 24-hour Holter monitor on this woman? Do you want to do an event recorder? Do you want to stop her nortriptyline, begin her on some alendronate, or get her on some soft restraints while in bed? How are we going to prevent her next fall? A 100% again. You guys are still drinking the water. Good. So, yeah, we want to, in any case we can, we want to avoid use of medications that put patients at risk for confusion and falls. We have a 72-year-old woman who reports discomfort in both lower extremities. This discomfort is present when she is seated, and it occurs in both her calves. It improves when she's walking. She describes it as a deep ache, sometimes with an itching or pulling feeling. She has increased symptoms when she's lying in bed at night. She has a history of diabetes and hypertension. She takes hydrochlorothiazide, lisinopril, metformin, and her exam is unremarkable. Which is the most appropriate next step for this lady? Should we start her on daily iron supplementation? Should we start her on pramipexole? Should we check her iron levels? Should we start her on gabapentin? Or should we measure ankle brachial indices? All right. Most of you clued in to the idea that anytime that this woman has restless leg syndrome, and anytime that's the case, we're going to want to check iron studies as uh, a first step to make sure that we're not dealing with an iron deficiency state. And if we are, then we would give iron supplementation. Answer A here is wrong because we wouldn't do it without proof that we already have iron deficiency. And then answers B and D, we wouldn't want to start therapy just yet. We'd want to initially check for the iron deficiency. And then letter E, this doesn't sound like a peripheral arterial disease because it's present at rest and improves with walking about. It would be the opposite if we were thinking about arterial problems. Next up, we are called to evaluate a 74-year-old man with Parkinson's disease. He has been hospitalized twice in the last year for urosepsis. Because of incontinence, he's required a chronic indwelling urinary catheter. He's currently afebrile. He has no abdominal pains. He's had no mental status changes or recent falls. There were labs obtained 2 days ago in his nursing home. His white count is 8,000. He has what appear to be normal sodium, potassium, BUN, and creatinine, but his urine culture returns with greater than 100,000 colonies of Enterococcus. Which therapy would you recommend for this older man with Parkinson's disease? Would you put him on ceftriaxone, ampicillin, vancomycin, imipenem, or hold off on therapy at this time? All right, beautiful. So, won't belabor the point. You guys probably see this an awful lot. We get calls from the nursing home, and somebody has some kind of change. They seem more irritable today. They threw their food at me. Can I get a urine? And the last thing we want to do is check urine in people who have chronic indwelling devices because it's always going to come back positive. We're always going to grow out organisms. And then when given a positive culture, as a physician, you feel pretty ill at ease to not treat that patient. And so our whole idea here is to try and avoid checking in the first place. And then if it does get checked and this patient doesn't meet criteria for sepsis or acute infection, then ignore the culture and don't treat with antibiotic. All right, that brings us to urology and sexual health. So urinary incontinence, it's amazing to think about how well things go with urination. It's a really complicated process. It takes your cortical, your cerebral cortex to be thinking about it, your brainstem to activate things, your sacral nerves being intact, and then the coordination of your kidneys and bladder and urethra and all that to make all this happen. So next time you use the restroom. So urinary incontinence, we break down into reversible causes for incontinence. We also think about functional incontinence. And then we think about all the lower urinary tract causes. For functional incontinence, what do I mean by that? I mean people who don't recognize they need to urinate because of cognitive deficiency, or people who, I've got to pee, but I've got such a bum hip or leg that I can't make it to the bathroom on time, and so I have an accident. So that's functional incontinence, and we try and do behavioral things, schedule them to go to the bathroom regularly to avoid that. For reversible causes, what are they? One is somebody's got an acute UTI. So if this is acute onset urinary incontinence, you want to check a urine and rule out a UTI, frequently the culprit. For postmenopausal women, think about atrophic vaginitis and urethritis as a cause of incontinence, and by giving topical estrogens, intravaginal estrogens, that oftentimes can reduce this problem. Other areas, so stool impaction can cause urinary incontinence. And so think about that, especially in people with autonomic problems, spinal cord injury can get severe stool impaction. And then drugs can cause urinary incontinence. And so we want to discontinue any kind of offending agent. Which drugs cause urinary incontinence? I thought you would ask me that. Diuretics, of course, especially a lot of patients get confused and take these before bedtime. So I'm always careful to check, when do you take your diuretic? Caffeine in a similar light. Anticholinergic medicines. So they can impair the bladder's ability to contract properly and cause retention of fluid, which can cause overflow. We'll talk in a moment about how anticholinergics can also be helpful in treating incontinence, but they can be a cause on their own. Sedative medications and opioids can contribute to urinary incontinence. So let's talk about the main types of lower syndromes that cause urinary incontinence. The first and most common is what we call urge incontinence, the overactive detrusor muscle that produces chronic spasms that cause you to leak out low volumes of urine. These are folks who have to go immediately and sometimes can't make it to the bathroom on time, not because their limbs don't work, it's just boom, they just leak. Stress incontinence, this is where the bladder is functioning very normally. It goes when you contract, but your sphincter is weak and is unable to retain the urine, and so increases in intra-abdominal cavity pressure through a cough, a sneeze, jumping, laughing, etc., causes loss of urine. This happens especially in multiparous women. I learned about this when I was a young parent, and my wife kept sending me into the bouncy house. And I said, "How come none of the moms go in the bouncy house?" And then she educated me. Mixed incontinence is when you have a combination of both urge and stress incontinence. And then we have what's called overflow incontinence. And this can either be due to a hyperactive bladder with an outlet obstruction, someone most commonly with BPH. And so the bladder's contracting, but you can't expel the urine, it overflows, and eventually you get leakage. And then underactive bladders, so where the bladder just fills up like a balloon, but doesn't have the proper cholinergic stimulus to expel the urine. And so that's common in advanced diabetes, especially in patients with MS or spinal cord injuries, Parkinson's disease. How do we treat urinary incontinence? For people with functional issues, we give them bladder training. We talk about going on a scheduled basis, set an alarm, or in the nursing home, every shift, take the patient to the toilet. Kegel exercises can be helpful in all of these conditions. For patients with urge incontinence, so detrusor instability, they're just having too much bladder spasm, you can block that acetylcholine stimulation of the bladder with anticholinergics. Oxybutynin and tolterodine are the main drugs there. Beta agonism also has effect on the bladder, and so use of mirabegron can help to stop an overactive bladder. For stress incontinence, we don't really have medications that affect this, and so it's mainly Kegel maneuvers and then a surgical approach if it's bad enough. And then for overflow incontinence, you do your best to treat the underlying cause of that. Oftentimes that's not really fixable. The nerves aren't working unless it's a BPH situation. And intermittent catheterization. I have patients who do caths 4 times a day, and they get very good at their sterile technique. Let's switch gears and talk about erectile dysfunction. This is most commonly a disorder of vascular dysfunction. And there was an interesting study looking at patients who had recent reports of erectile dysfunction, recently got that on their diagnosis list. And then they looked back, and then they looked at those patients and found that they had an incredibly high rate of subsequent heart attacks compared to people with age matched who did not have erectile dysfunction. So they're calling it sort of a canary in a coal mine. So if a man is presenting with erectile dysfunction, think about other vascular problems they may be having. Neurogenic erectile dysfunction happens with diabetes, peripheral neuropathy, hypogonadism, severe hypogonadism, lack of testosterone can cause erectile dysfunction, but usually also you'll note the patient has very low libido going along with that. Certain medications can cause ED. The SSRIs are the ones that come to mind the most. Antihypertensives have been blamed for erectile dysfunction at times, although if you think about it, one of the number one causes of erectile dysfunction is uncontrolled hypertension. So you want to treat the blood pressure. And then psychogenic can be a common cause of erectile dysfunction. And the medications for erectile dysfunction are surprisingly good in people with psychogenic ED. And so don't hesitate to prescribe those medications. So how do we treat ED? The most common treatments are the PDE5 inhibitors. Remember that these are all contraindicated if a patient's on a nitrate. These can cause some visual changes, color vision changes. They can get a non-arterial, how does it go? NAION, non-arterial ischemic optic neuritis, where they can get loss of vision. So any visual changes, they need to stop the drug and go to see the ophthalmologist. Remember that tadalafil now has an indication for BPH. And so where these medications are sometimes hard to get coverage for, you can prescribe it for BPH, and oftentimes the companies will say, okay, that's fine. Vacuum devices, I remember talking with a urologist once, and they say, we can get anyone an erection. One of the ways they can do that is through vacuum devices. They're not very convenient, not very, spontaneous, let's say. Intraurethral alprostadil is a medication that patients inject a pellet into their urethra, and that can stimulate erections. It's effective, but not very comfortable. Penile injections, doesn't sound like the greatest thing in the world, but again, it can stimulate erections. And then for patients who are just absolutely fixated on this and you've tried everything else, you can consider penile implants. Other sexual dysfunction to mention, dyspareunia in women. It's almost always due to postmenopausal atrophic vaginitis. And so treating with lubricants and or vaginal estrogens can be very helpful as a first step. Obviously, you want to look for some kind of physical problem as well. Decreased libido. Think about hypogonadism. Think about medications, especially the SSRIs. SSRIs, remember, are oftentimes implicated in patients who have delayed orgasm. Common report, and you can actually use that to your advantage if somebody's having problems with premature ejaculation. You can get them on an SSRI. Let's do some more audience response questions. Make sure you guys are still with me here. We have a 26-year-old man presenting with sudden onset scrotal pains that began 3 hours ago. On exam, the scrotum is diffusely tender and swollen. The right testicle sits higher than the left and lies in a horizontal plane. There's a tender knot that rests just above the right testicle. The cremasteric reflex on the right side is notably absent. Which is the most likely cause of his scrotal pain? Are we dealing with acute epididymitis? Is this a strangulated inguinal hernia? Does he have Fournier's gangrene? Is this testicular torsion? Or does he have mumps or orchitis? All right, most of you picked up on this as a case of testicular torsion. Let's talk about the acute scrotum. So there are a few different things that can cause acute scrotal pain. Epididymitis is probably the most common amongst them. Testicular torsion, hernias, in severe cases, Fournier's gangrene, and then testicular cancer. Torsion is an emergency. It has to do with the testicle not being fixed at the base of the tunicovaginalis, so it's not bound down there, and so it's kind of hanging on a string. And if that string starts to twist on itself, it can cut off the blood supply. When it does so, the patient gets acute onset of pain. The testicle oftentimes turns on a horizontal axis. They call that a bell clapper anomaly or deformity. And when you do the cremasteric reflex, that's where you just do a light scratch in the inner thigh, the testicle is supposed to go up, and it does not do so, which is one of the hallmarks of torsion. Torsion is an acute onset emergency. It's not something that goes on for days or weeks. If you suspect it, you want to get an ultrasound right away, or potentially even try and manipulate the testicle, try and untwist it in essence. Early recognition is essential for saving the testicle. 90% save rate if you can diagnose this and get them to treatment within 6 hours. Drops off to 50% if you're out to 12 hours, and pretty low rates of testicular salvage at 24 hours or beyond. So this is something you've got to recognize and jump on right away. Talking about the other etiologies, acute epididymitis. This is the most common cause of acute scrotal pain. GC and chlamydia are the leading factors in younger adults. In older adults, and always mad at when I look at the Sanford guide, it says if you're 35 years and over, then you're likely to have E. coli or coliform organisms. And it's just, okay. So think about STIs, think about the coliform organisms. These patients will have palpable tenderness of their epididymis on exam, and then that you would couple with a positive urine culture or test for GC and chlamydia and treatment accordingly. BPH, incredibly common. The older you get as a man, the more likely you are to have prostatic hypertrophy. These are folks who are troubled by most often nocturia. That's the most bothersome symptom. They get hesitancy, a weak stream, they dribble. It's truly a clinical diagnosis. A man coming in with BPH symptoms, that should not prompt a workup for prostate cancer. You can work up prostate cancer if you want to or screen for it, but it's a whole separate conversation. This should not influence that. For BPH, we usually start with behavioral therapies first, meaning limit your fluids at night, double voiding, so pee, brush your teeth, go back and try and pee again, avoid caffeine and alcohol. If behavioral therapy is not cutting it, you can try saw palmetto and herb for very mild BPH symptoms. The most effective medication therapy are the alpha blockers, tamsulosin, terazosin, doxazosin, prazosin. those medications are mainly affected or can cause orthostasis. So usually we give them at nighttime before bed and tell the patient, hold on to the dresser as they're getting up. Don't just jump out of bed because you might fall. If patients are not getting satisfactory results on an alpha blocker, you can consider addition of a 5-alpha reductase inhibitor, finasteride, dutasteride. Those take months to have effect. They're, in essence, shrinking your prostate. You shrink your prostate up to 50% of its original volume, but that takes sometimes 6 months to achieve. And remember that as you're doing that, your PSA should subsequently drop. So if you see someone who's on this medicine and their PSA is rising, that should trigger uh-oh, they're having a fast rise in PSA. We might need to look for prostate cancer. If all these medicines aren't effective, generally if they're peeing 3 or 4 times a night despite being on a high dose of an alpha blocker plus or minus an alpha reductase inhibitor, off to the urologist to have some kind of procedural manipulation. All right, another audience response question. We have a 79-year-old woman who reports problems with urinary incontinence on a daily basis. She has to void many times during the day and leaks urine frequently before she can get to the restroom. She has not had hematuria or dysuria. She's on omeprazole, sertraline, and enalapril. Her urinalysis is normal. Which is the most likely cause of this woman's incontinence? Does she have a hypoactive detrusor, sphincter hypoactivity, detrusor hyperactivity, side effect of sertraline, or a side effect of enalapril? And so we talked about the most common cause, and you guys nailed it perfectly. Detrusor hyperactivity. This is someone who's having unstoppable bladder spasms. Next, we have a 76-year-old woman who's evaluated for urinary incontinence. She reports a 6-year history of incontinence occurring when she laughs, coughs, or sneezes. Recently, she has had incontinence with standing. Her urinalysis is normal. Her BUN, creatinine, and glucose appear within range. Which would you recommend for this woman? Would you start her on oxybutynin, doxazosin, Kegel exercises, imipramine, or mirabegron? Oh, God, I can't fool this crowd. Perfect. You guys are on it, paying attention. So there are no medications, as we talked about, for stress incontinence. It's Kegel maneuvers. And if that's not working, then surgical approaches. A 76-year-old man presents for evaluation of urinary frequency and decreased urinary stream. The symptoms have been present for the past 3 years, but have worsened in the last 6 months. He's now getting up 4 times a night to urinate. On exam, his prostate is enlarged without nodularity. What do you recommend for short-term relief of symptoms? You guys are perfect. I don't think you've missed a question. 74-year-old man with diabetes reports increasing problems with sexual function. He reports normal sexual desire but inability to sustain an erection sufficient for intercourse. It's been slowly worsening over the past 3 years. His testicular and prostate exams are normal. He takes metformin, insulin, atorvastatin, famotidine, and ginkgo biloba. What is the most likely cause of his erectile dysfunction? right. Perfect. Next one, we have a 67-year-old man who presents for treatment of ED. He has had problems sustaining erections for the past year. He's got a normal libido. Testicular and prostate exams are normal. He's on simvastatin, omeprazole, isosorbide, lisinopril, and aspirin. What would you recommend for his therapy? Would you put him on intraurethral alprostadil, start him on sildenafil, get him on testosterone patches, testosterone injection, or would you refer him for a penile implant? All right. The majority, you got the answer that I was going for here, which would be use of intraurethral alprostadil. You would not go for the sildenafil in this case. How come? He's on a nitrate, right? So that is contraindicated from the standpoint of the boards. We wouldn't get him started on the testosterone therapies. You guys were good to stay away from that. And then this would be pretty early for a penile implant referral without first trying some of these other things. All right. Excessive sitting. There have been numerous studies now showing sedentary behavior is linked to all-cause mortality, cardiovascular mortality, cancer, and diabetes. I've also taken a couple of education fellowships, and in those they say the human mind cannot pay attention for more than about 40 minutes at a go. And here we're an hour and 45 minutes in. So I'm failing on that regard. So what I would like you to do is stand up. We're going to do a little yoga. I have done yoga twice at the insistence of my wife and have not gone back to it. But we're going to do something called a tree pose. So we're going to take one leg, put it up against the other. And we're going to take our hands and put them above our head. We're going to try and balance. Got to be a little bit coordinated. Exactly. I used to coach my kids' soccer teams, and I used to have them do things like this, and I would just see them all drop. It's really fun. Okay, switch legs. We're going to do the other side. Do your best. Well, if you need to, just touch down on something. All right. Good. Excellent. Okay, we're going to keep going for a little bit, and then we'll take a bit of a break. But let's charge on because we have so much material to get through. We got one of you in a side pose. If you want, we can get the picture to you afterwards. I won't say who that is. You know who you are. All right. Let's talk a bit about ethics. So this is a challenging topic. There will be questions on the boards about ethics, and usually it's about using your common sense, good judgment. What would I do in this situation? This makes the most sense. But let's just talk about some of the general overarching principles. So there are 4 main principles that guide us as we're practicing medicine. There's respect for patient autonomy. There's the principle of beneficence, which is trying to do things to help our patients. Non-maleficence, meaning primum nocere, do no harm first. And then finally, trying to treat people with equity. And so those are the guiding principles within our profession. When we're thinking about ethical dilemmas, you just really have to boil it down to what's going on here. What would make me weigh one side versus the other in the decision? Which of these principles are at stake? Are there cultural aspects that are important here? If you are uncertain of which way to go, consultation with colleagues is what I find to be the most helpful. If need be, I will get an ethics consult, which can take a little while. Um, Although we do have a hotline kind of thing, but still it takes a while. And then court decisions are incredibly slow. So whenever possible, you want to sort things out with the patient, with the family, with your colleagues around you. Respect for patient autonomy is pretty absolute. So if a patient has a particular belief and it's, it goes against what you believe, but you just can't force them to undergo a treatment if it's against their particular religious or cultural preferences. Paternalism is sort of the opposite of that, where we just take charge and do things for the patient, again, ignoring their preferences, and that's generally considered improper from an ethical standpoint. There are rare extenuating circumstances that would cause us to override a patient's general consent. Decision-making capacity is one of the leading factors that we think about. Does this patient have decision-making capacity? Do they have the ability to understand what's at issue here, what the options are in terms of treatments or diagnoses, et cetera? And, that's always going to be very dependent on the situation. But do they understand? And if they're making choices, do they understand the benefits and risks of the choices out there? It's different from competency. That term is used by a court to determine if someone's able to make their own decisions. But we are assessing decision-making capacity on a daily basis, patient to patient. Does this patient understand what they're getting into, what they're deciding about? If a patient is unable to make their own decisions due to an incapacitating illness, we'll oftentimes look to a surrogate to help with that, or proxy decision maker. And so, um, depending on the state you're in, you would look to the spouse, the parents, the children, etc. And each state has their own sort of um, hierarchy for that. Durable power of attorneys are things that will uh, help sometimes. So the patient designates a representative to make healthcare decisions in their stead if they're unable to do so. And that surrogate really should be presenting things in the sense of this is what the patient would have wanted, not necessarily what they want, but this is how the patient thinks and this is what they would want. You had a question? It's usually deciding like larger issues of, does this patient have capacity to control their own destiny and their, like, all aspects of their life. We're looking at the immediate medical situations and saying, do they understand the choices I'm offering them, the medications, the treatments? You need a surgery or you need to be hospitalized, etc. And then we're deciding, does this patient really get it? And are they able to make these decisions? Or do we need to involve others to figure this out? So advanced directives are tools that can help us. They're not perfect, but they allow a patient to designate, here are things generally how I would like here are ways that I would like my care to go if for some reason I became unable to make decisions in a particular situation. Most states now have something called the POLST, which is where we sign an order and the patient makes designations about whether they want acute resuscitation, whether they would want aggressive treatments, including intubation, whether they would want tube feedings. And there are some more extensive versions of this. Keep in mind that these don't require lawyers, they don't require any notaries, they require the patient and you and a witness, and that's it. Durable power of attorney, make sure it's for healthcare. Some people come in saying, I'm the DPOA, and that's for their finances, but not for their health care. So it has to be for health care. And then that person becomes the legal surrogate, proxy, or decision maker. And their decisions supersede the living will, supersede other family members if they've been designated as the DPOA for healthcare. We obviously want them to take into account what the patient has said on their living will because that's the spirit of it. But it's ultimately that DPOA's decision as if they were the patient. Palliative care is um, a discipline that helps us talk about helping patients when they've got a very serious illness. Most often we think about this in terms of cancer, but we should be thinking about it for any serious or incapacitating illness. It really emphasizes use of home care over hospitalization, uh, relief of symptoms over cure of the disease. Palliative care has been shown to reduce mortality. So getting palliative care involved early, even if the patient says, yeah, I've got a cancer and I want to go forth and with the treatments they're suggesting, palliative care referral so that they're involved with each step of the process. Hospice is really the end stage of that palliative care cycle for patients with less than 6 months to go. Other ethical issues, we talk about confidentiality. Doctor-patient confidentiality is mostly absolute, but not all the way there. If a patient is saying, I want to off myself, or I want to, get rid of this neighbor who keeps, throwing their leaves on my lawn, we have to report things like that. It has to be a specific, but yeah, you have a responsibility to the safety of the patients and the safety of the public. That also extends to if someone's posing a risk. I've got HIV and I don't want to tell my relatives, etc. That's somebody you'd want to report usually to the health department so that they can reach out to these individuals and test and or warn them. I think this goes pretty much without saying. Physician-patient sexual relationships are a no-go, really under any circumstance within the immediate time that you're involved in a patient's care. Is there a statute of limitations? Yes, I guess. But in general, this is frowned upon, and on the boards, you're not going to be condoning this kind of thing. And that goes for people who are involved in the patient's care. So the physician should not be getting involved with parents or children, etc., of a patient. Disclosure of medical errors, yes. It's kind of the bottom line. The culture now is to reveal any errors that occurred, including near misses. So even if something bad didn't happen, the idea is to talk about this, disclose it with the patient. Errors don't necessarily mean there was something negligent or unethical happening. There were errors, but if you don't disclose the error, that's where you can get into trouble. And they found in studies that patients who sue because somebody's trying to hold back something from them rather than somebody who's openly communicating even about an error. Patients want acknowledgement of the error, and I found they most importantly want to know what's going to keep this from happening again. Is there some system approach going on? Are you guys meeting about this and talking about the Swiss cheese that went into the error that occurred? All right, let's do some questions rather than have me ramble on more about ethical stuff. So we've got a 29-year-old woman who presents with hematemesis. Her hematocrit is 20%, which is low. She receives IV fluid and has a type and screen ready for transfusion. She has a repeat hematocrit 2 hours later that's down to 14%, critically low. When a blood transfusion is recommended, the patient refuses because of her religious convictions. Her husband is in the room with her, and he says, yeah, she doesn't want the transfusion. She has another episode of hematemesis while you're talking with her. What should you do? Should you A, obtain a court-appointed representative? Should you B, get an immediate hospital ethics consult? Should you C, give her blood because she's in a life-threatening situation? Should you D, give her blood because of the principles of beneficence? Or should you E, expedite endoscopy and consider non-blood volume expanders if she becomes hypotensive? All right, and everyone went with the choice that I felt was most correct. So great. We have a 21-year-old college student who's brought to the ED by her roommate for symptoms of headache and fever. She's got a stiff neck, and it's all going on for 6 hours. She's somnolent but arousable. She's got a temperature of 39.0, quite elevated. Blood pressure's low, heart rate's high. She's got nuchal rigidity on exam, and her white count is 24K. She consents to a lumbar puncture. You get some CSF, you send it off to the lab, and you order antibiotics. As the nurse starts to hook up the IV bag, the patient starts to scream and says, I won't allow it. When asked why, she says, you guys are trying to poison me with pesticides. You carefully explain the high risk of death from untreated meningitis. The patient continues to scream, everyone here is trying to kill me. What should you do? Should you treat with IV fluids only because the antibiotics carry a risk and should not be given without her consent? Should you treat with antibiotics because the patient has questionable decisional capacity? Should you obtain a court order urgently for treatment? Or should you obtain consent from the patient's roommate and give antibiotics? Oh, gosh. Most of you are there with the treating because she has the questionable decisional capacity. So this is where you've got an emergency going on. You're deciding whether this patient is able to rationally approach the situation, understand the consequences, etc. And it's clear from her responses that we're giving her pesticides and trying to kill her, that that's not a rational approach, that the meningitis is affecting her ability to make appropriate healthcare decisions. We're not going to reach out to a roommate or, this is something we've got to do in the moment. As physicians, we would say she does not have decisional capacity, and this would be a case where we would override what she's saying and give the medication. We have a 44-year-old woman who presents to clinic upset because she was found to be HIV positive at a recent health fair screening. Her husband, who's also one of your patients, doesn't know about her HIV status. She refuses to tell him because she is afraid that disclosure will destroy their marriage. HIV is a reportable disease in your state. In addition to encouraging the patient to disclose, which of these should you do? Should you honor her request for confidentiality? Should you tell the husband immediately and recommend HIV testing? Should you recommend the husband be HIV tested at next visit as part of his routine screening? Would you test the husband for HIV without his knowledge? Or would you report her illness to the health department? Perfect. Take the easy way out. Get it off to the health department, make sure they're on it right away, and maintain your relationship with the patient and her husband. Next question. We have an 86-year-old woman who lives in a nursing home and who is admitted for severe aspiration pneumonia. She's unconscious. She has a fever of 40 degrees. She has an ABG showing an acidemia, hypoxemia, high CO2. She's been started on IV antibiotics and fluids. Her nephew is her durable power of attorney for healthcare. Patient has never completed a living will or advanced directives. The nephew meets with you, says that his aunt has become demented over the past few years. The nephew would like IV fluids and antibiotics withdrawn and comfort care initiated. You understand that the patient's son is also present in the waiting area. Which of the following statements about the nephew is true? A, because the patient has not left specific advanced directives, the nephew's instructions to discontinue IV fluids and antibiotics should not be carried out. B, the patient has a son who is next of kin, and therefore the nephew cannot make medical decisions. C, the nephew's request to discontinue IV fluids and antibiotics is within his capacity to act as her durable power of attorney for healthcare. Or D, the nephew's instructions can be carried out only if it is determined that he had discussed the specific situation with his aunt and is carrying out substituted judgment. All right, perfect. These are hard questions to write, by the way. A 56-year-old man with type 2 diabetes is hospitalized for treatment of cellulitis. He is given 100 units of NPH insulin instead of the 10 units that he usually takes. This is discovered 15 minutes after he receives the dose. He's placed on a D10 drip. What should the physician tell the patient? A, he is at risk for low blood sugar, so he will be receiving a drip with glucose in it. B, a dosage error was made and he received 10 times the insulin dose he was supposed to receive. He's receiving glucose to help prevent low blood sugar. C, he may have too much insulin on board right now, so he's being put on a glucose drip to avoid low blood sugar. D, you are concerned that he could develop low blood sugar today, so you'll be monitoring him closely and will have him on a glucose drip. Or E, you will discuss it only if he asks about it. Perfect. You guys are on it. So disclose all errors in very plain English. Okay, we're going to switch over to some perioperative care pearls. So preoperative cardiac risk assessment, the basic ideas. So the very first question you should ask yourself, is this emergent? If it's emergent, go to surgery, right? You're not going to stop. You're not going to do other things. If there are ways to mitigate risks, you'll do so. But basically, emergent surgery, you do emergent surgery. If it's non-emergent, then you look at a patient's overall risks. You look at their risk of a major adverse cardiovascular event or MACE. And one of the popular ways we do that is by using the revised cardiac risk index. This is not the only risk index out there. You can use other ones, but it's just a general idea of how to do this. So the RCRI looks at predictors of major adverse cardiovascular events when a patient's having a surgery. You can see them all there. If a patient has history of MI, they get a point. If they have a positive exercise test, they get a point, etc. And so you go down, you tick off the list, you come up with an overall score for this patient. And then if the score is less than 1%, then you would recommend proceeding to surgery. If their MACE risk is above 1% for an acute cardiovascular event, the next question you should ask is, what is the functional capacity? So functional capacity, usually we divide it by METs. So they either are able to do 4 METs or they are not. And if they're able to do 4 METs or more, then that's generally a good predictor that they're going to do really well during surgery and that they're still overall a pretty low risk. And so proceed with the surgery. If they are not able to participate in activities or do things that require 4 METs, that's where you might do some other workup, stress testing, possibly revascularization procedures prior to going forward with the elective surgery. What is 4 METs, you ask? So 4 METs corresponds to walking at a decent pace, about a 4-mile-an-hour clip, doing light housework like washing dishes, golfing without a cart, doing some ballroom dancing or mowing a lawn, or swimming at a relatively mild pace. Some key ideas of pre-op cardiac risk assessment. Patients with active heart disease, you generally want to address their acute anginal episode or their unstable angina, et cetera, first before going towards an elective surgery. For patients with chronic heart disease, their exercise capacity really helps guide you. And so if they've got a decent exercise ability, then you don't need to do other cardiac workup first. And there are certain surgeries that just don't pose a risk to the cardiovascular system in general. So if somebody's having a cataract done, they really don't need to come see us for their pre-op clearance, as they call it. I don't clear anybody because it implies that we're giving the okay. And so I evaluate them and give them an overall assessment of their risk. And so just from a medical legal standpoint, try and change the terminology. Should we use beta blockers for patients going to big surgeries? It's pretty controversial. In general, if someone's on a beta blocker to start, we keep them on the beta blocker. And we certainly don't abruptly withdraw the beta blockers. The question of starting a beta blocker, it seemed like a good idea from some early studies, and subsequent studies haven't quite shown that. So it's still kind of in the controversial range of whether somebody who's not on a beta blocker should be started on one before a surgery. What labs do we need to check? Generally, not necessarily any labs. And so it depends on the patient, their health situation, and maybe the surgery. So hemoglobin hematocrit, if someone's older, if they're undergoing a major vascular procedure or some kind of procedure where they're expected to lose a lot of blood, but for sure we want to get a baseline hemoglobin hematocrit. Creatinine, you don't necessarily need to have going into a surgery. If they're over 50 and having major surgery, generally you want to know what their baseline is. These are not absolutes. These are just general ideas about what labs we need. You could avoid the CBC if your hospital allows just H&H if that's cheaper. You don't necessarily need electrolytes unless they've got some significant kidney disorder or they're on lots of medicines that affect their electrolytes or they have past anomalies. You don't necessarily need glucose or LFTs or PT, PTT, INR, urinalysis, etc. Again, unless the patient's clinical scenario dictates that they need it. All right, all that's nice to say. What do we get? We get a form from the surgeon saying, I need all these things or I won't do the operation. And so, we're a little stuck there from a purist standpoint. We really don't need these things. If you can have a conversation with surgeons and say, this patient doesn't need these things and will do fine going forth with surgery, you might be able to do it that way, but we all have tons of time to reach out with each surgeon and do this, right? EKG, patients don't need it for low-risk surgeries. If they have coronary risks, then certainly get an EKG baseline if they haven't had one. Age on its own is not a reason to get an EKG. Chest x-ray is rarely needed prior to operation unless we're operating on the chest. So if they have suspected cardiac or pulmonary disease, especially if we think it might be unstable, getting a chest x-ray is worthwhile. But if they've had a normal history and physical and they don't have lung disease, you don't necessarily need an x-ray. PFT only if they're having ongoing unexplained dyspnea as part of the workup, or if they're having lung-specific surgery. Patients who have stents, so they've had a cardiac procedure, they've had a recent stent, and now they need another procedure. What do? They're on dual antiplatelet therapy. You can stop that if it's been just a single balloon angioplasty without stent. If they've had a bare metal stent placed, it's 1 month before you should have elective non-cardiac surgery. And if they've got a drug-eluting stent in place, then you want to wait usually 6 months before elective surgeries. For antiplatelet agents, remember that aspirin lasts for about 10 days in the system. And so if somebody's undergoing a major surgery where they're at risk for blood loss, stop aspirin about a week before surgery. For clopidogrel, again, about a week before surgery. NSAIDs and COX-2 inhibitors, you can stop a little later and they'll be fine. Their platelets will be functional. Remember, those have reversible binding to your platelets. And a lot of patients are in a lot of pain going up to surgery, so you don't have to stop it too early. For anticoagulants, if someone's having a minor surgery, even with a therapeutic INR 2 to 3, there's really no increased risk for significant bleeding if they stay on their warfarin. For major surgery, then you would think about taking people off their warfarin. And depending on their underlying condition, you have to decide whether you bridge them or not, which we'll talk about, I think, on the next slide. So for major surgery, for IV heparin, you stop it 4 to 6 hours before the surgery. Low molecular weight heparin, you stop 24 hours before. DOACs, you stop about the same, 24 to 3 days before. And then generally about 5 days if you're stopping warfarin. So heparin bridging for patients with, let's say, AFib, and they're on warfarin, stop the warfarin. They have incremental risk over the few days. For patients who are at accelerated risk of clot, they've had a history of embolic stroke, they have a cardiac stent, they've had a recent thromboembolic event, they have a clot in their atria, something like that, then you want to bridge them. And so what we do is we have them go onto heparin. We stop their warfarin and have them go on to heparin, carry them up to about 6 hours before the operation, dial off their heparin drip, do the operation. Once the operation's over, restart heparin, and then restart warfarin, overlap the two until the patient's therapeutic on their warfarin. For cardiovascular perioperative management, continue beta blockers. For other medications, calcium channel blockers, nitrates, statins, a lot of the times you can keep those going. Diuretics are often held because of the volume, so most anesthetic agents are hypotensive agents, and so they don't need to be on a diuretic. ACE inhibitors and ARBs we worry about a little bit because they have a high risk for being pre-renal during their surgical time, and so that might increase their kidney risk. In general, we want to stop estrogens and preferably weeks before the surgery because of their propensity for causing intravascular clotting. What about diabetes agents? So patients coming in, they're going to get an operation, and they're on insulins, what do? Generally, long-acting insulins, that's what you need day to day, whether you eat food or not. And so if you're on long-acting glargine, you should stay on the long-acting glargine, usually at that very same dose, or if you want to decrease it ever so slightly, you can. Remember, surgery is a major stress event, and so your sugars are going to be high. For the short-acting and medium-acting insulins, usually you don't need those during the day of surgery, so you either drastically reduce their dose or just hold them. You hold the oral hypoglycemic agents. So for the most part, just keep them on their long-acting insulins. Remember, you have a friend in the operation room, which is the anesthesiologist, who can check sugars on a minute-to-minute or even more frequent basis and provide insulin or glucose as needed. So less of an important thing. Yes? Yeah. That's a great question. I think it's too soon, too early for prime time for boards. But could we see questions about GLP-1s and surgery? Maybe. So yeah, those would also be agents that are not immediately necessary during surgery. And there is a little bit of worry, although not proven yet, of this gastroparesis that can go on with the medication that may not be reversible. So good question. All right. So that's diabetes during the operation. Psychiatric medicines depends on the medicine they're on. MAOIs, does anyone use those anymore? I guess if you have a patient still on them, you'd want to hold them for a couple weeks before. SSRIs, they suggest holding, although that can really destabilize matters, so I don't necessarily do that. But during neurosurgery, they suggest holding the SSRIs. Antipsychotics, I never stop for anything pretty much. Tricyclic antidepressants and lithium, they recommend continuing those. For neurologic medicines, keep them on their seizure medicines, keep them on their Parkinson's medicines. The Alzheimer's medicines that we talked about before, they can only complicate matters. They're not necessary in the acute setting, so withholding them probably makes sense. All right, a couple questions. A 78-year-old man with history of hypertension and diabetes falls and fractures his hip. He's going to need hip surgery. Prior to his fracture, he could mow the lawn without any troubles. His blood pressure is a little elevated, heart rate's 90. Exam looks pretty darn normal. He's got sinus rhythm with left ventricular hypertrophy on his EKG. Hemoglobin and hematocrit are a little low at 11 and 33%, and his glucose is 148. What would you recommend for this gentleman? Would you do a nuclear medicine stress test ahead of his hip fracture repair? Would you do an echo? Would you say go on to surgery right away? Would you do pulmonary function testing prior to surgery? Or would you transfuse him a couple of units of blood? All right. And so most of you went with getting immediate surgery. This is a guy who has good functional capacity going in, didn't have any major red flags to say that his cardiac risk would be elevated going into a hip surgery, and so he could proceed without further testing. All right. That gets us into preventive medicine. We're at about the halfway mark. I think this would be a good time to do a quick break of about 10 minutes. So right now I've got the big hand on the 8. When the big hand hits the 10, we will reconvene. Sound all right? All right, we're back. Hopefully, you all got up and moved around and reset your minds for the last part of this. You're in the home stretch, which is good. We're going to talk about preventive medicine, which is why many of us got into this game. We're trying to prevent bad things that happen to our patients. As a moment, I'm going to stop and say thank you. So, because our patients never do, right? We spend all this effort controlling their lipids and their hypertension and diabetes, trying to prevent the bad things that can happen down the line. And no one comes in and says, thank you for preventing the heart attack that didn't happen, right? So, thank you. All right. So, things to do, things to screen for, blood pressure. It's pretty straightforward. They recommend that we check blood pressure pretty much on everybody at every visit, at minimum every 3 to 5 years in younger age group. And targets of blood pressure is a whole big topic, but generally trying to keep the blood pressures lower than the 130 mark in general. AAA is something that we've been screening for now for about the last 20 years. The recommendation is for ages 65 to 75, only in men, with any history of current or past smoking. By history of smoking, 1 pack or more in their life counts. And then the evidence just didn't pan out when they've looked at this for women for screening for AAA. Screening is usually a one-time ultrasound. If the patient's had a CT scan or MRI that's had good detail of their aorta, that can count too. Screening for diabetes. The recommendation currently is to start at age 35, regardless of risk, and then to screen earlier. They don't designate when. If you have a patient who is overweight, BMI greater than 25, and has at least one additional risk factor, and that additional risk factor could be as simple as physical inactivity here, or having hypertension or a family history with a primary relative with diabetes. How do we screen? We screen with a fasting glucose or a 2-hour oral glucose tolerance test, or using an A1C. All 3 are acceptable screens. If your screening is normal, the recommendation is check it every 3 years to make sure that people aren't sliding into diabetes. They have this new category of risk enhancers, this high risk race or ethnicity that's listed at the bottom there. Cholesterol, we should be measuring lipids every 5 years in adults age 40 to 75, according to the USPSTF, and looking to get patients on statins for primary prevention if they are in the ages of 40 to 75, who are have a calculated 10-year ASCVD risk of better than 7.5%, or if you're a follower of ACP and AAFP, greater than 10% risk. So, secondary prevention, ASCVD, any event, statin. Primary, quasi-secondary prevention, if they've got familial hyperlipidemia, so LDL greater than 190. If they're diabetic and their risk factor is less than 7.5%, you could start on a moderate dose. And then for all others, if they have a greater than 7.5% risk, put them on a statin. Cancer screenings. Remember that, first off, don't do screenings for people who have a less than 10-year life expectancy. For breast cancer, it's a moving target, right? There have been 3 recommendations out there for a long time, and so you're kind of right, whatever you do. The USPSTF just recently suggested that we start screening now at age 40, going all the way up through 74. That's still in the draft stages, so it's not official. Certainly other groups recommend starting at age 40 as well. So the boards isn't going to ask you about anything controversial. In general, start screening women age 40, go up through 74, provided they don't have other conditions that are going to limit their lifespan. Prostate cancer, another controversial. USPSTF recommends against PSA screening. ACP says have shared decision making ages 50 to 69, as does American College of Rheumatology and the American Urologic Association. You choose. Talk to your patients. Colorectal cancer, this is another one in a bit of a flux. The USPSTF recommends screening colonoscopies, ORFIT, or the DNA testing. The colonoscopies every 10 years if normal, FIT every year, DNA testing every 3 years. And they put a grade A recommendation on ages 50 to 75. And then, as many of you are aware, a couple of years ago, they gave a grade B recommendation saying we should be starting earlier at age 45 because we're seeing about 10% of new colon cancers now in folks under the age of 50. So younger cancers, they're saying let's screen more. There are detractors to all these screening statements out there. But these are generally what's accepted out there. If you're following New England Journal, this week, there's a study looking at a blood test for colon cancer, DNA based blood test, showing very high sensitivity and specificity. So there's hope in the future that we might be able to target more who goes on to colonoscopy. Too early for prime time, not for your boards. Okay, cervical cancer screening. Another one that's in flux. HPV testing has really evolved to the point where it's starting to replace our need for pap smears. They're finding that doing primary HPV testing alone is actually superior to HPV testing plus the pap smear. So you don't get added benefit from having the pap smear, you actually get more false positives. So the ACS recently came out with their own guidelines suggesting different screening. I'll show you on the next slide what that looks like. But they say we should be starting later at age 25 and trying to remove our emphasis on cytology, getting rid of the pap and really focusing on high-risk HPV strains. If someone's had their cervix removed, they're now officially saying we don't need to be screening in the area looking, as long as it was removed for benign disease, we don't need to do any further screening. And then, as you're probably well aware as well, the bimanual exam has fallen to the wayside. We're no longer recommending that as part of a well woman visit. So here is lining up the traditional USPSTF ACOG guidelines on the left from 2018, and then the new 2020 American Cancer Society guidelines. So what you've been used to is starting at age 21, doing PAPs every 3 years without HPV testing, starting at age 30, doing PAPs with HPV every 5 years, and then stopping at age 65. And now looking at 2020 ACS guidelines, they're saying don't screen these younger women, start at age 25, and then just do HPV, high-risk HPV every 5 years. And then quit at age 65, provided you've had successive negative HPV screens. This will be further impacted by the HPV vaccination, which came out in 2007. We've already been seeing a huge decline in cervical cancer rates, and that should decline even further, provided vaccination rates stay at good levels, which is questionable these days in the anti-vax world. Another thought, and again, not ready in any way for prime time, there have been a lot of studies looking at HPV self-swabs. So getting rid of the pelvic exam altogether and having a woman do a self-swab HPV, they're finding it's about as accurate as a physician-obtained sample for HPV. So again, not ready for prime time, but I think if we fast forward 10 or 15 years, we're going to be doing that and having a lot less pelvic exams. All right, lung cancer screening. This is one that's come about in since about 2000. The studies have shown that there's a significant reduction in lung cancer mortality if we screen high-risk people with a number needed to screen of 320 over 3 years to prevent one excess lung cancer death. There is a high false positive rate. That's the sort of the downside of this screening. Most of those false positives get just followed along with excess screening, but occasionally we need to go and do excess biopsies. The USPSTF recommends this as a level B, which means it's supposed to be covered by insurance, and they recommend annual screening between ages 50 and 80 who have had 20 pack years or more of smoking history, or who are currently smoking or who have quit within the past 15 years. So it's a very specific, based on the study that was done, the PLCO, it's a very specific set of criteria to undergo the screening. Immunizations, I've listed a table here. I'm not going to get into a lot of nitty gritty about it. The new thing on this is the Hep B vaccine is now recommended for all adults aged 19 to 59, not just screening for it, but they're recommending we vaccinate our entire middle year population versus Hep B. Other things that are relatively new, the zoster combination or two vaccine series is now recommended for all adults over age 50. So that's maybe new to you, I don't know. And then, yeah, just these are things that don't change a whole lot, and the boards can test you on pretty easily without a lot of controversy. Yes, you have a question? If they've already been vaccinated, then no, but if they don't, so they're recommending screening patients, and if they don't have immunity, vaccinating all patients from ages 19 to 59. Question is about hepatitis B vaccination. Pneumococcal vaccination, can they make this more confusing? And like every year they change things, right? It's just, I think they do it to mess with us, quite honestly. But things have gotten a little bit more straightforward of recent. So it's recommended for all adults over age 65. It's recommended in adults 19 to 64 with anything on this list, which is, there's a lot of things on this list which qualifies lots of adults. So how has it become easier? It's become easier because the strains have changed, and now they've locked down this PCV20 as the gold standard one-time deal. And so that will hopefully end a lot of the confusion that's gone on with pneumococcal vaccination. So for anyone who qualifies, you can do a one-time PCV20 and done until they change the recommendations again, right? So, but at least that's how they're wording it now. If you get it in the 19 to 64 age range, they're not recommending a booster at age 65 or over. They're just saying get it once and you're done. If you have the PCV, the other option is PCV 15 followed by 23 later. I can't see any reason to do that unless you're just out of 20. And then there's a few caveats for these people who have received one dose of a 13. They're supposed to get 23. I don't think they're going to test you on that nitty gritty kind of thing. They're really trying to get at bigger picture stuff. And so I think if anything, they're going to be saying PCV 20 one-time shot for, and maybe who qualifies. So when you hit 65, you could just, when they're due for their second, you do the 20. Yeah, is an easy way to do it. So 20 is pretty much the answer for everything right now. That's what I would go with. Pregnancy, there's a recommendation of not giving live attenuated vaccines to pregnant women. I never remember which they are. I always have to look it up, but here they are for you. It might be something to glance at before, like the morning of the boards, to remember which ones are live vaccines. Pregnant women should still get the flu vaccine every year. They should get Tdaps. HIV patients, they're supposed to avoid MMRs and VZV live attenuated if they've got severe immunosuppression. So CD4 is less than 200. All right. The boards loves this kind of thing too. Like, oh, somebody's had their spleen out. What should we do? Someone's had, it uses illicit IV drugs. What do we recommend? So again, this table might be useful for you the day of kind of thing, or the day before, to just glance at and say, okay, somebody's a healthcare worker. What do they need? And yes, you can do PCV 20 now. Thank you. All right, let's test out some of these concepts. A woman comes in for a physical exam when she turns age 65. She hasn't seen a physician for 12 years, and her last visit was for a skin rash. She's not had a regular doctor because she lacked insurance. Appropriate preventive care at age 65 for this woman should include A, pap smear and mammogram, B, abdominal ultrasound, HPV, mammogram, and FIT, C, HPV, FIT, and mammogram, D, pap smear, CBC, and FIT, or E, no screening is indicated. All right, and virtually everyone locked in on this one. So this woman hasn't been seen for a dozen years. She needs to be updated on her cervical cancer screening with use of the high-risk HPV strain. Some kind of colon cancer screening is reasonable, and then breast cancer screening. So answer C would be correct. Which of these patients meets the guideline criteria for AAA screening? Is it the 50-year-old man who's coming in with chest pain, 55-year-old woman who presents with a stroke, a 60-year-old woman with a 100-pack year history of smoking, 75-year-old woman with a 100-pack year history of smoking, or a 66-year-old man with a 60-pack year history of smoking who quit 10 years ago? Perfect. So these things are all pretty formulaic. It just look at the recommendations, kind of seal them into your memory. Boards loves things that are not controversial. You got a TB test and you were in prison and it is X number of millimeters. What do you do? That kind of thing. Doesn't change, hasn't changed in 20 years, and they just want to make sure that you're familiar with it. In November, a 34-year-old G1P0, I have no idea what that means, comes to see you at 24 weeks of gestation. She reports no history of chickenpox. She received all regular immunizations growing up, with her last immunization received prior to college 16 years ago. Which immunizations would you recommend for this pregnant woman? So, no vaccinations, varicella and Tdap, varicella influenza PCV, varicella Tdap influenza, or Tdap and influenza. Thank you for adding that. So perfect. So remember to avoid the live vaccinations. Next question, we have a 61-year-old man in good health who comes in for a first visit. He's not seen a doctor since 50. In addition to the seasonal flu vaccine, which immunizations would you recommend for him? Okay, you guys are okay. So this one, the patient should be getting Tdap to update his tetanus and pertussis if he's not had it. He should be getting his zoster vaccination. Because he's only 61 and he's otherwise in good health, he doesn't qualify yet for any of the pneumococcal vaccinations. So that's why answer C is correct. Did you guys put down answer D? Okay. I was talking so much about PCV20 that you guys just went with it, but he doesn't yet qualify because he's not of age. All right. An influenza epidemic strikes a nursing home at which you are the medical director. The patient received the influenza vaccine yesterday, but cases began appearing 5 days ago. You now have 11 confirmed cases of influenza A. What do you recommend? Should you treat patients with oseltamivir as soon as the symptoms of flu arise? Should you isolate all your patients without symptoms, put them in a separate wing of the nursing home? Should you begin all nursing home residents on a 14-day course of rimantadine? It's on a 14-day course of oseltamivir. All right, we're all over the map here. Correct answer on this one is answer D. So in the case of an outbreak of influenza A, the recommendation is for other patients at risk, they can go on prophylactic dosing of oseltamivir to reduce the risk of. I would have to double check that. I wrote this question a little bit ago. So we can double check that if you think it's 10-day. But the idea is using a prophylactic course of oseltamivir if there's an outbreak. All right. You guys ready for another? All right. What are we doing? Do we have any yoga instructors out there? And you just stand up at least. What, oh, I like it. Oh, okay. So we should have started with that one. All right. So we're going to do one foot in front of the other in a lunge position, hands above the head like this. All right. If you're not participating, there's a good chance you're going to fall asleep in the next section. So encourage y'all to do that. I don't know the name of it. All right. And then we're going to switch legs. This is good. At a certain point, probably around 30 years ago, I lost the ability to touch below my knees, basically. I've become so inflexible. Okay, that's a good reset. Let's talk about toxicologies, overdoses, things that hopefully we don't deal a lot with, but might show up on the boards that we're expected to know. So in general, for in toxicology, you want to do the basics, protect the airways, think about things that can make people have loss of consciousness. Big ones nowadays. The number one cause of death in young people now, which is so sad, is opioid overdose, the fentanyl epidemic. And so the whole push for naloxone, having that on hand and administering in any case where you're not sure, D50 or giving glucose in some way, and then thiamine. Assessing everything about the person with the tox screens and blood gases, etc. Make sure you're looking at anion gap and osmol gaps to see if there's been some kind of poisoning going on. think about acetaminophen. If there's ever a question of somebody overdosing on anything, get acetaminophen and salicylate levels, because we can act upon them early and prevent further damage. And then in cases where people have ingested within the last 4 or so hours, using charcoal and or lavage can be helpful. Charcoal does not help for certain things. It's not going to harm generally, but it doesn't help for certain types of poisonings, and so it won't make the difference. That being said, generally you err on the side of giving charcoal in case they've co-ingested something that would be affected by charcoal. Remember that if you should always be calculating anion gaps on your patients with suspected overdose. And if they have an elevated anion gap, then think about your mnemonic from medical school that just you come upon in your sleep sometime, mud piles, and just remember all the things that those stand for. And then if the gap is elevated, then you'd be testing for these different things. So we're going to review just a few different specific toxins that show up in emergency rooms as well as on the boards. So anticholinergic overdoses, a lot of our medications are anticholinergic, and then that's the classic red as a beet, dry as a bone, hot as a hair, etc., that you will see as a result. The antidote for anticholinergic overdoses in general is physostigmine. TCAs, which do have some anticholinergic properties, are a little bit different. TCAs are common causes of overdose death on board exams, and so important to think about. TCAs affect your cardiovascular health. They prolong your QRS. A recommendation is that anyone on a TCA who's over age 50 should have an EKG and periodic monitoring of their EKG. TCAs can affect your CNS and they have, as I mentioned, the anticholinergic effects. First thing to do if there's been a TCA overdose within the past couple hours is charcoal and lavage. The antidote for TCA is a little different from an anticholinergic on its own, and it's sodium bicarbonate that will help stabilize the cardiac membrane, and it will prevent the arrhythmia that can go along with a TCA overdose. If patients are having seizures, you can use benzodiazepines, and drug levels are not always reliable in TCA overdose. Let's talk about acetaminophen briefly. So different stages of acetaminophen toxicity. The important thing is for the first 24 hours or so, a lot of patients have no symptoms whatsoever. So you're not going to recognize an acetaminophen overdose based on symptomatology. And you might think, oh, this person's drunk, or did they take something? And the acetaminophen's not going to manifest. So you have to be suspicious for it. And then test for it. And if positive, then start treating. Patients don't start decompensating till much later. Here's what the acetaminophen nomogram looks like. And so you look at how many hours out from the time of ingestion, and then it very simply tells you based on this level, there's a high risk for toxicity depending on the patient. And then if they're in the toxic range, you start administering the antidote medication, the antidote being N-acetylcysteine, either oral or IV. Activated charcoal, again, if you catch these people within the first 2 to 4 hours after ingestion. So N-acetylcysteine can be life-saving, liver-saving. Carbon monoxide is another poisoning to know about. It is odorless, tasteless, colorless, and it binds to hemoglobin with incredible affinity. Binds, yes, 240 times greater than oxygen. So it's going to take over your hemoglobin. Oxygen can't bind on there. This is in the setting oftentimes of cold weather and people trying to heat their homes with improper equipment, bringing stoves inside, uh, inhaling too much smoke, etc. You're unable to deliver your oxygen to your tissues, and so you get ischemic damage to your important organs, including your brain and your heart. The symptoms early on are pretty nonspecific. It's like having the flu, perhaps without the fever, or they can go all the way along to being, lethargic, comatose. Diagnosis is looking at a blood gas and finding the elevated carboxyhemoglobin levels in someone where you suspect it. Remember that your pulse ox will not demonstrate an abnormality. You can't tell the difference until you look at the blood gas results to see if you're dealing with carboxyhemoglobin. If someone has poisoning, you want to get them out of the environment for sure. Initiate oxygen as soon as possible. Non-rebreather will speed up the process a great amount. And then if patients are severe enough and or if you have the facility available, get them into a hyperbaric oxygen chamber, and that can even further expedite the removal of carbon monoxide. And it can be pretty devastating if it's left to go too far. Nitrites or poppers are things that are out there. I don't get any of this drug stuff, but parties and they do this and get a high from them somehow. They present with sped up everything. And these are the folks who get methemoglobinemia from this. They get a cyanosis. You can give them oxygen and it doesn't matter because the hemoglobin can't bind it. MDMA intoxication. These again, it's a party drug where people become euphoric and lose inhibitions, increase sexual arousal. This, like one of the outstanding features of MDMA is bruxism. People will grind their teeth a lot. They also get hyperadrenergic, so accelerated hypertension and temperature. And so look for, and then hyponatremia is also a real common finding with MDMA. So look for that. Methamphetamine is the scourge of the planet, as best I can tell, with no obvious way to get people to stop using. Methamphetamine is a major stimulant, so you get hypertensive and tachycardic and diaphoretic. And these people can get very agitated and psychotic and have all these weird hallucinations and delusions of parasitosis. And we have a number of them who come into our resident clinic who are there on a weekly basis, bringing in bags of belly button lint and saying, look, here's the bugs, treat me. It's tough. They get meth mouth, which I think I have a picture of, from going large amounts of time without brushing their teeth, and it's very drying of the mucosa of the mouth. And they also consume a lot of, I think, high beverage sodas, etc. All right, here's a handy table to remind you the day before the boards of what to do if you have any of these particular toxins involved in a case. So acetaminophen and acetylcysteine. They're narcotics. You're going to use naloxone for reversal. Benzodiazepines are a little controversial. If someone's on chronic benzos and you give them flumazenil, they will seize. So it's not a terribly useful drug. If it's a one-time overdose of a benzo, you can consider using it. For nitrites, that's where you get the cyanosis. You can use methylene blue to help overcome the methemoglobinemia. For iron overdose, deferoxamine will help to scavenge the iron. Methanol, ethanol, we can use fomepizole. Organophosphates is the 2-PAM. And then cyanide, we use sodium thiosulfate. which in itself can be a poison. All right. So, some questions. The agent of choice for treatment of the arrhythmia associated with tricyclic overdose is which of the following agents? Oops. Ah. All right. Testing you to see if you're awake, and you are wide awake. Perfect. So, sodium bicarbonate. Next, we have a 20-year-old woman who presents to the ED, tearful and agitated. She reports taking a bottle of extra strength Tylenol 2 hours ago in a suicide attempt. Her physical exam is normal. Hemoglobin hematocrit look okay. White counts okay. Acetaminophen level is in the toxic range at the 4-hour mark. What is the most appropriate management for this patient? Should we do gastric lavage and some deferoxamine, activated charcoal alone, activated charcoal and N-acetylcysteine alone, or deferoxamine alone? All right. Oh, I thought we were going to get 100%. So this is one of those, if it's early on enough, use the activated charcoal. There's virtually no harm, only benefit. Patient's going to look like they ate a lot of Oreos. Ate a lot of Oreos as a kid. 29-year-old man is brought to the ED by friends. Patient was at a party with his friends when he became confused and then unresponsive. He's severely hypotensive, tachycardic, low temperature. He's satting 88%, and he's noted to have marked extremity cyanosis, and he's got blue lips. His labs, he's got a very low white count. ABG is shown there, and his electrolytes are shown. He's placed on 100% oxygen mask without improvement in his cyanosis. What therapy should he receive? Should we give him amyl nitrite, methylene blue, bicarbonate drip, naloxone, or IV alcohol? Awesome. So just about everyone locked on to this being a popper, a nitrite poisoning with methemoglobinemia treated with methylene blue. Good job. A 45-year-old patient of yours calls you on a Sunday afternoon. He's been having nausea, vomiting, and diarrhea. He also has a headache and some dyspnea. He went out and shoveled snow, and that seemed to actually improve things. But now the symptoms have returned. He said his wife has been sick in bed with the same flu-like syndrome. What do you recommend? Should you have him come to clinic if the symptoms persist tomorrow? You'll come out to his house today and take a look at him. Have the patient call 911 for emergent evaluation and transport to the ED, or prescribe oseltamivir for both the patient and his wife. All right. Looks like most of you clued in that this is carbon monoxide poisoning in the setting of cold weather, patient having flu-like syndrome, getting better when he goes outside and shovels snow, and gets worse when he goes back inside, someone else sick within the home. All right. Moving on. Let's talk about eyeballs. I'm not an ophthalmologist. 36-year-old woman with obesity presents for evaluation of headaches. She's had increasing problems with headaches over the past 6 months. She's had no visual symptoms, occasional nausea, and no focal neurologic symptoms. Headaches keep her home from work. Her blood pressure normal, heart rate normal, skin is normal, fundi. I will show you a picture. And the neuro exam is otherwise normal. She takes calcium and OCP and fluoxetine. So here's a picture of her fundus. You guys all look at the fundus on every patient, right? Okay. So based on that information, what is our most likely diagnosis? Do we think this is a glioblastoma? Is this idiopathic intracranial hypertension, formerly known as pseudotumor cerebri? Is this tuberous sclerosis, Prader-Willi syndrome, or a headache due to her oral contraceptives? All right. We just want to answer pseudotumor cerebri, right? She's obese, she's having headaches. They showed us a retina, so of course it's got to be that. So I did show you showed you a retina. That is a beautiful retina. That is as normal as they come. Normal cup to disc, normal vessels, very clear, no papilledema. So all those things would suggest that she does not have intracranial hypertension, and she instead has a headache from oral contraceptives. Common things being common: oral contraceptive associated headaches, 600 per 100,000. The idiopathic intracranial hypertension, 3 per 100,000. So I kind of tricked you there. Yeah. Why do they change the names of these things? It frustrates me. I think it's just to make us feel old so that we'll get out of the way, retire or something, you know? Yeah. They just changed the name of C. diff. It was small, but still, it's now Clostridioides difficile. It's like, why? Stop changing the name. All right, so let's talk about IIH, formerly pseudotumor. 90% of patients are young, female, obese, and they all get headaches that are typically worse in the morning as the CSF pressure rises to the highest levels. These people get visual disturbances, sometimes can get tinnitus, and a real key here is they get papilledema, which this patient did not have. They can get nerve palsies. We make a diagnosis by doing the CSF and looking at the opening pressure, which tends to be extremely high. And then we treat these people with acetazolamide to decrease the amount of CSF production. Papilledema, you basically lose focus of everything. You don't have a clear disc margin, or in this case, I can't even tell that there's a disc there. The vessels are obscured. When you're doing your retinoscope exam, you should be able to take a vessel and follow it from the extremity of the eye all the way into the optic nerve and still be able to keep a good focus on it. It still should be clear. And so looking for that disc margin, looking for the clarity of the vessel all the way through helps to rule out papilledema. I try and get my residents to look in the eye a lot. I don't have a lot of success. It's a hard exam. Let's talk about ophthalmologic emergencies. If you get a base in your eye, then water irrigation, get them to an ophthalmologist, but usually not much to do there. Central retinal artery occlusion, that's the acute, painless, unilateral loss of vision. You look in the eye and you see the classic cherry red spot. The boards loves this because it's like a very, very specific physical finding that they can show and say, what is this? Unfortunately, there's almost nothing you could do if you have that visual loss. The cherry red spot is a marker of you've got an infarction there and you're probably not going to get back your vision. The things that they recommend doing are putting patients in Trendelenburg, having them breathe into a paper sack, and doing ocular massages. I think that's to make us feel good that we're doing something, but I don't think any of those things have been proven to work. Angle closure glaucoma is something to be very aware of. That means someone has a closed angle. It's pretty rare, but usually comes about. Most people with glaucoma, you know about it, and they're on treatments, and this doesn't happen. So it's mainly like certain medicines, like antihistamines can bring this on. Dilating drops can bring it on, where people will have acute loss of or change in vision, sometimes loss of vision, eye pain related to blocking of the flow of the aqueous humor. Penetrating injuries of the eye, yes, that's an emergency. If there's a spear sticking out, send them somewhere else. Endophthalmitis and people you generally who are immunocompromised and or IV drug users, um, especially the fungal. Retinal detachments, people get the shades, changes in vision, the curtains that come down, showers of black dots. This is one that's kind of cool. You can diagnose by the POCUS. And so with a very high level of accuracy with POCUS, you can rub it on the eye and see the changes in the retina. That being said, a lot of us don't do POCUS or don't have access. And if you have acute symptoms like this, get them to an eye doctor or at minimum the emergency department right away. Orbital cellulitis, pain with eye movement is a big red flag, and sometimes double vision. There are a few different types of conjunctivitis, 4 flavors. One is bacterial conjunctivitis. It tends not to be a subtle thing. The picture on the far left there shows just a goopy, messy eye. And so that's bacterial conjunctivitis. That needs antibiotic eye drops. For viral conjunctivitis, it's most commonly adenovirus, but doesn't matter which virus. It's pink eye, usually starts in one eye, spreads to the next eye. Treatment for that is not antibiotic eye drops, despite the fact that so many patients walk away with an antibiotic eye drop. So the boards doesn't like that and would like you to not treat those patients with antibiotics. Most infections of the eye shouldn't, superficial eye structure should not cause pain. If you have a red eye with pain, with photophobia, if there's decreased visual acuity, or if the patient has ciliary flush, think about something going wrong with the internal structures of the eye. Iritis, keratitis, iridocyclitis, acute glaucoma. Ciliary flush is a rim of red coming from the limbus, from where the cornea meets the sclera. There will be redness emanating from that area, and that should clue you in. The eyeball itself should never hurt, so that's a direct to ophthalmology, and shining a light in the eye shouldn't hurt the patient. Again, get him to the ophthalmologist. And then subconjunctival hemorrhage, you guys have all seen. Those are fun ones because the patients come in, they're super, freaked out by it, and you're like, nothing. Check their blood pressure, make sure it's not 200 over 100, and they probably just like rolled over on their fist or something. Allergic conjunctivitis is another cause of the red eye. You get redness, itching, burning, and it's usually seasonal or related to some exposure, like your Aunt Shirley's cat. God rest her soul. The diagnosis, you think about viral conjunctivitis. Dry eyes can do this. Rosacea tends to look very similar, but doesn't respond well to the typical treatments for allergic conjunctivitis, the antihistamine drops. And then episcleritis and scleritis tend to be more painful, more deep red involvement of the sclera. Treatment for allergic conjunctivitis is pretty straightforward. Topical antihistamines work really well with decongestants. The nefazoline phenyramine combination is found on all the drugstore aisles. Or you can use the mast cell antihistamine drops like azolastine or olopatadine. Never, ever, ever steroids. If a patient gets a steroid drop because they're having an irritated eye in the urgent care and they say, "Can I go home with that bottle?" The answer is absolutely no. Steroid drops lead to corneal ulcers and bad things. And so the ophthalmologists are 100% do not give your patient drops unless they're telling you to give them steroid drops. The ophthalmologists do not use them. 67-year-old woman comes in with 1 hour of unilateral right eye pain. The pain started while she was watching a movie at the theater. Her past medical history is notable for hypertension, osteoporosis, and migraines. She takes alendronate and hydrochlorothiazide. Her left eye is normal. Right eye has some mild conjunctival injection. The cornea is slightly hazy. Pupil is 6 millimeters and poorly reactive to light. She reports halos around the light during your exam. In addition to calling an ophthalmologist, what treatment would you recommend? Would you give her sumatriptan subcutaneously, IV ketorolac, timolol eye drops, acyclovir IV, or oral gabapentin? Awesome. So the majority of you keyed into this being acute angle closure glaucoma. Oftentimes, the stimulus for this is people going from a light environment to a dark environment. When the pupil dilates, that causes restriction of the flow of aqueous humor from the trabecular network. And so it causes an increased elevation in your intraocular pressure. And so it's a medical emergency. You got to get these people decompressed, usually starting with things like timolol, um, and potentially other therapies. But yeah, getting them in right away. So acute angle closure glaucoma. Epistaxis. So most nosebleeds come from the front part of the nose. There's a huge plexus in there that is susceptible to mostly irritation from excessive nose blowing or nose picking. Oxymetazoline spray can be helpful at constricting the blood vessels, and then using tamponade, having the patient pinch right below the ridge or the brim of their nose. For more severe bleeds that aren't stopping in a relatively quick amount of time, you can do anterior packs with different products, different tampons or gauzes or catheters. And then if they're having ongoing or recurrent episodes of epistaxis, either doing it yourself or getting them to an ENT for some ablation of the area. For posterior nosebleeds, that's a little bit more complicated. That's beyond my comfort zone. That's usually where I get them to the ED. And they can do posterior nasal packing. They use a balloon catheter and pull it up through there and compress the area until the bleeding stops. Most of these patients require hospitalization and observation. And just be aware that when you do the packs, especially the posterior packs, there have been a bunch of reports of toxic shock syndrome, especially if those are left in there too long. It's controversial whether antibiotic prophylaxis helps to reduce that or not, but these are folks that you have to monitor very carefully. And generally, I get them off to the ENT physician. Hearing loss is a tough one. Acute, most people get just general hearing loss, presbycusis with age, but hearing loss you want to evaluate for conductive causes of loss. So infection of the middle ear, a perforation of the TM, a blockage of the eustachian tube, chronic otosclerosis from prior infections, or just simply cerumen impaction, hopeful. Sensory neural hearing loss is where the air conduction is better than the bone, but still compromised. That can be just from time, rarely from drugs. Meningitis and mumps can do this. Meniere's disease, acoustic neuromas are some of the scarier things that can do this. If you have someone with sudden sensory neural hearing loss, you got to get them into an ENT doc right away, and they recommend, for lack of better things to do, starting them on pretty good dose steroids. I've done it a few times. I've never seen it restore people's hearing, but that's what the manual says to do. Has it personally, or you with patients? You personally. So you've had acute onset hearing loss, and then steroids, and the hearing came back. Oh, okay. Thank you for sharing that. All right. I think this is one you will be familiar with. A 63-year-old woman with diabetes presents with right ear pain and right facial nerve palsy. She's had a fever for the past 24 hours, and she's got this very ugly, draining ear. Which is the most appropriate treatment for her? Would you put her on a MOX, vancomycin and Clinda, ciprofloxacin otic, piperacillin tazobactam and ciprofloxacin IV, or isoniazid and rifampin? Okay. So you guys are brilliant. You all picked up on the fact that this is an otitis externa caused by Pseudomonas, so a malignant otitis externa. This is most commonly seen in people with diabetes or other severe immune compromise. And Pseudomonas is a pretty tough bug in that area and can cause some serious damage. It can invade into the mastoid. This used to be a surgical condition until we discovered medicines that penetrate the area well and fight off Pseudomonas, mainly the quinolones. And you recognize here that there's two answers with quinolones. This is one where you would want to use an IV preparation to make sure that it doesn't continue to burrow and cause an osteo. So Ramsay Hunt, you're going to basically get a facial nerve palsy, and then you should see evidence of the zoster. Yeah. And you wouldn't see the diffuse erythema like that. All right, you guys ready? What? You guys aren't game? Oh, man. Is there anyone here who thinks they can do this? Okay. Kudos to you. I don't think at any point in my life, like my highest point, could I have done this. All right. We are in the home stretch, so that's a good thing. All right. A quote from Hattie McDaniel in Gone with the Wind: "I don't know nothing about birthing no babies." Okay, so I'm just going to say that straight out. I did deliver 30 babies in residency. I did it in an inner city hospital, and they just put us on overnight and just said, "Here, medical student, just deliver the babies," And I was all alone. And so when my wife was in labor with our third child, and the doctor was getting ready, I said, "I've delivered 30 babies." She goes, "Get some gloves on." And so I got my gloves on. My wife's like, "What's going on over there?" I'm like, "Just hold on." And so I got to deliver my youngest, which is cool. All right, let's talk about pregnancy and women's health. Start with a question. A 29-year-old G1P0 female with type 1 diabetes presents at 22 weeks of gestation with increasing pedal edema. Her blood pressure is 170 over 110. Urinalysis reveals 3+ proteinuria. She has no headaches or neurologic symptoms. Which treatment would you recommend? Would you get her on hydrochlorothiazide, lisinopril, labetalol, nitroprusside, or spironolactone? Okay, awesome. So you guys are doing great. Labetalol is considered the treatment of choice here. There is basically a list of antihypertensive medications that are recommended in women with high blood pressure during pregnancy, and labetalol is one of those medications. Let's take a look at those. So, hypertension in pregnancy, it's kind of weird. They have a very wide range of acceptable blood pressures in pregnancy. So, they recommend treating high blood pressure only if systolics are greater than 160 or diastolics are greater than 100. So, they're a lot more liberal than we are in our general practice. And they recommend treatment whether or not preeclampsia signs are present. Goal is getting them to 140 to 150, so less aggressive than us generally, over 90 to 100. This is for all pregnant women with hypertension. And then they have a list of preferred medications because these have been shown to be both safe and effective for treatment. Remember that certain drugs are toxic during pregnancy to the baby, to the fetus. Those are the ACE inhibitors, the ARBs, and spironolactone. So you want to never use those. And in general, if I have a young woman I'm treating for high blood pressure, I'm avoiding those agents. So I'm not choosing ACE ARB or spironolactone. Hyperthyroidism in pregnancy. So mild hyperthyroidism is pretty normal, generally doesn't require any treatment, and you're just trying to prevent fetal hypothyroidism, and you're trying to control maternal symptoms. So if the woman is symptomatic, you might start with a beta blocker. And then if needed, there's that thing where you can use PTU in the first trimester, and then you switch over to methimazole after that. Remember, these women should not be treated if they have Graves or something like that with radioactive iodine due to the fear that you're going to wipe out the fetus's thyroid cells. Hypothyroidism in pregnancy is fairly common. Your need for thyroid hormone goes up by about half during pregnancy. So your body expects more thyroid, and you're feeding the fetus and providing it the thyroid hormone until it can make its own. And so you need the extra thyroid. So it's really important. Otherwise, the fetus can develop severe neurocognitive deficits. And so for any woman in pregnancy, you're screening them with a TSH. If it's above 4, you're treating them. There's no asymptomatic hypothyroidism in pregnancy. So thyroid hormone is an absolute necessity. And then you're going to monitor these women very frequently, like every 4 to 6 weeks, you're going to be checking their TSH. A 36-year-old woman who's G3P2 comes to see you regarding her blood sugars. She was diagnosed with gestational diabetes during her first pregnancy, and then subsequently she was diagnosed with diabetes. What goal would you recommend for her glycemic control? Do you recommend that she get her post-meal sugars below 240, pre-meal sugars below 180, pre-meal sugars below 150, below 120, or below 90, and get her A1C less than 6%? What do we think? All right, so the majority of you knew this. This is one when I asked the residents, they have no idea. So sugars have to be incredibly tightly controlled during pregnancy to avoid risk to the mom and the fetus. Risks of macrosomia, so large babies, large heads, shoulder dystocia, increased fetal mortality, increased maternal mortality, all those things if sugars aren't well controlled during pregnancy. So aggressive management, usually in the hands of a high-risk OB or an endocrinologist, unless you got a lot of time on your hands. Screening for gestational diabetes should go on at the 24 to 28 week mark. They recommend using the 75-gram oral glucose tolerance test in the form of an orange soda. And in any woman who does not have known diabetes. Women with diabetes, as I mentioned, tight control, they recommend the tight control start before conception. So a woman with diabetes who's considering pregnancy, you really want to get them going on this regimen before they become pregnant with that goal A1C less than 6. Nutrition in pregnancy, obviously encouraging a normal BMI at the start of things. Avoid under as well as over nutrition. Avoidance of alcohol, tobacco, excess mercury, limiting caffeine. Could not convince my wife to quit, I was not going to say anything. Too dangerous. Starting supplementation with folic acid is super important. Probably the most important of all things that we know about in pregnancy to prevent neural tube defects. And then making sure that they keep up on their other vitamins and minerals that can become deficient. And then avoidance of high doses of vitamin A. Drugs to avoid absolutely during pregnancy. And so this is a list that you should kind of have in your head anyway. But if you don't, this is a good thing to just remind yourself of before boards. So medications for acne. We use spironolactone, we use retinoids. We use both of those in young women with acne, and that can cause disastrous consequences. ACE inhibitors and ARBs, so young women with hypertension. Benzos are generally not favored. Quinolones, tetracyclines, nitroprusside, warfarin, fluconazole, all contraindicated. Even for the occasional yeast infection, they recommend against use of fluconazole. So just have this list in your head for whenever you're treating young women who are or may become pregnant. 25-year-old woman whose G1P0 presents at 10 weeks of gestation for evaluation. She's asymptomatic. Her hemoglobin's 12, hematocrit's 36%. Oh, her urine culture shows 100,000 colonies of E. coli. Who keeps getting urine cultures, darn it? What would you recommend? Would you put her on amoxicillin, ciprofloxacin, TMP sulfa, or no treatment? So the correct answer here is amoxicillin. About 70% of you got that correct. Some of you wanted to use TMP sulfa. I like the fact that all of you want to treat this. So even though she's asymptomatic bacteriuria of pregnancy can lead to some pretty bad outcomes. So the recommendation is a screening urinalysis at 12 to 16 weeks of gestation. A third of asymptomatic bacteriuria will go on to pyelo if you don't treat them. It's associated with low birth weights, preterm birth, and increased perinatal mortality. So you definitely want to treat asymptomatic bacteriuria. This is in contrast to that nursing home patient we talked about earlier, where we didn't want to treat him because he didn't have symptoms. Women who are pregnant, you treat. Peripartum cardiomyopathy is something to just have your eye on. So women just prior to delivery or for the first several months after delivery are at risk for having an acute onset of heart failure, probably like a help me with the Takotsubo. Takotsubo's cardiomyopathy type of pattern, where they get pretty severe symptoms and overt heart failure. You would do all the usual things for diagnosis that you would with anyone else with acute onset heart failure. You want to avoid certain therapies, especially while pregnant. You're not using the ACE, ARBs, or spironolactone because we know they're teratogenic. And then a lot of these women will eventually return to normal cardiac function and probably do not require lifelong goal-directed medical therapy for heart failure. Ectopics are something to be on the lookout for on your boards. So this is pregnancy outside of the uterus. It's usually in the tubes. These are women with vaginal bleeding, oftentimes abdominal pain early on in pregnancy. They've got a positive HCG, and then you look and you're unable to find an intrauterine pregnancy. You want to make sure that these women are appropriately increasing their ACG. They should be, near doubling. The rule is if they're not rising by more than about 35% every couple days, that suggests that they've got an ectopic pregnancy. This is a life-threatening emergency, so you want to get them evaluated with typically ultrasound to start. And if they're hemodynamically stable, these are women who, under the care of usually a gynecologist, get treated with methotrexate. And if they're unstable, then they need to go to surgery. The ACOG put out a list of things that cause abnormal uterine bleeding. So abnormal uterine bleeding is when they have altered frequency, duration, regularity, or amount of flow in a non-pregnant patient. So they gave us this useful mnemonic, just kind of a ridiculous, aren't mnemonics being something you're supposed to remember? So anyway, they recommend thinking about structural causes, PALM, okay, that works. So that's polyps, adenomyoma, leiomyoma, and then malignancies. And then non-structural causes, the common word we use is COI, right? So anyway, these are all causes of why women might have abnormal uterine bleeding. Typically, we start with history, physical exam, and then labs. Most important lab of all of these is rule out pregnancy, right? So we want to get the HCG. We want to look at CBC to see how much they're bleeding, how far they've gone. Coags to see if there's a bleeding diathesis. Checking standard hormone levels. And then most of these women get evaluated with a transvaginal ultrasound. And or especially if they're older than 45, we want to get an endometrial biopsy to rule out endometrial cancer as a cause. And then treatment for this varies based on the cause. For most younger women who are having abnormal bleeding, OCPs will straighten this out quite frequently. Surgery for some of the more structural scary causes. And then obviously for any of the endocrinopathies, you're going to pursue and treat those. Menopause. So this is the permanent cessation of menses, and generally confirmed once you've gone a full year. Average age is about 55. Perimenopausal, a lot of women will get irregular menses and lots of vasomotor symptoms, especially the hot flashes, mood changes, irritability, sleep disturbances, and dryness of the vaginal mucosa. Women can get early menopause in the 40s. And then if it's below age 40, we think about primary ovarian insufficiency. Both early menopause and primary ovarian insufficiency, those women have higher rates of heart disease as well as osteoporosis because of the protective nature in general of estrogen on the heart and bones. So, how do we diagnose menopause? Mostly it's a clinical diagnosis. Most women don't need testing for this. In women who are 45 and up, we make a clinical diagnosis, provided they have a negative HCG, they're not pregnant. FSH is typically quite elevated in menopause. In perimenopause, it's less accurate at making a diagnosis. For women who are under age 45, that's where we want to do more of a workup, checking obviously for pregnancy again, and then looking for more endocrine causes. Hot flashes. So starting out, these are very disturbing symptoms that women get, and therapy, whatever it is, tends to be helpful, including the placebo effect. If you look at all the studies, like the original estrogen studies, 100% of women had reductions in hot flash frequency and severity with estrogens. 60% of the placebo group had significant reductions. So something is better than nothing. In general, estrogens are the most effective therapy. If women have their uterus, you need to combine the estrogen with progestin to prevent endometrial cancer. If they've had a hysterectomy, then you can use estrogen alone. In women, there are some women who are at high risk and should not receive hormonal therapy. Those women, namely, are women who have breast cancer history, thromboembolic events, or cardiovascular disease. And for those women, we would favor other agents like the SNRIs. Venlafaxine has some really good data. SSRIs like paroxetine and citalopram. Gabapentin is also a very helpful one. And then if you're following TV commercials nowadays, fezolinetant, I'm not sure how to pronounce it, but I don't like to use brand names, but fezolinetant is a neurokinin 3 inhibitor, I think they call it, a non-hormonal form that is effective. No direct comparisons with these other agents yet. A drug warning, paroxetine. So for women who are taking tamoxifen, they've had a breast cancer, they're taking tamoxifen, we're looking at non-hormonal therapies. Paroxetine prevents the conversion of tamoxifen to its active form. And so you will not get the protective effects of tamoxifen if you're on paroxetine. So that's another drug interaction to be aware of. All right. Anything else we want to say about hot flashes? Average length of hot flashes depends in part on racial backgrounds, but about 5 to 10 years. And then in series, about 8% of women were complaining of vasomotor symptoms 20 years out. So for some women, it can be very distressing for a long time. All right. 52-year-old woman is experiencing hot flashes, dysphoria, and sleep disturbance. She has a history of breast cancer and poorly controlled hypertension. She still has her uterus. She's taking metoprolol, lisinopril hydrochlorothiazide, and tamoxifen. What would you recommend? Would you start her on an SSRI paroxetine, SNRI venlafaxine, gabapentinoid gabapentin, estrogen, or estrogen plus progestin? Let's end on 100%. Oh. So both agents are reasonable. Why do I prefer the gabapentin in this case? Because the hypertension. So remember that of the antidepressant medications, the main one that can affect blood pressure is venlafaxine. So it ups the blood pressure. She's already got poorly controlled hypertension. So for that reason, I would preferentially choose gabapentin. You wisely avoided paroxetine because we just talked about how that interferes with the proper function of tamoxifen. And then estrogens are out of the question given her personal history of breast cancer. All right. I want to end with just some thoughts. One, I have tremendous respect for all you guys. You're in this because your hearts are good and you want to care for people. Boards are not going to try and trick you. They're they're not. I've taken them 3 times. I'm taking my 4th round next year. They're asking mostly straightforward questions. They want to make sure that you know your medicines. They want to make sure that you sort of know the high stakes things that you need to look out for or avoid. But for the most part, when I go through the board's questions, like, yeah, that's a fair question. So I think you're going to do great. Have confidence. Um, After this course, you're going to know so much. And, you're already putting it into this network where you have tremendous amounts of knowledge. So think of it as a refresher review where you're just becoming that much better a physician. And then you're going to sail through these boards. So have confidence. Thank you for your kind attention. And I'll open up to questions now or after, or how do you want me to do this? After. So yeah, come up to me after, or we'll shut down this, and then and then people online can ask questions. All right, thanks so much, folks.
Hey, well, thank you very much, Lenny. Of all the topics that we go over here, that's the most board relevant per minute talk that you can get for sure. So tomorrow, cardiology and rheumatology will start at 7:30 a.m. Mountain Time, and I'll see you then. And do try the preview questions. It seems like a real drag, but actually, if you just ponder them, each question, if you have time, cardiology has a lot of questions. But good luck. Let me know how it goes. Thank you very much. I'll see you tomorrow.